And welcome. My name is John Enville, and I would like to uh, welcome you to Bug Day 2024. As you heard from Jose Francois, we have approximately 2,400 people registered so far. I'm sure there'll be a few more during the course of the day. Today's program should be stellar. For those of you who registered online with the Department of Continuing Professional Development, please ensure you have checked in and recorded your attendance on in Slido at hashtag BUG 2024. This will allow you to download your certificate and claim credits for attending today's event. Please allow about 14 days for attendance to be recorded. Slido will become your friend over the course of the day, so you can ask questions and so forth. If you require a certificate or credits and you have not registered with Continuing Professional Development, please visit the Continuing Professional Development website now and register at www.cpd-umanitoba.com. And it should actually be quite easy. Just go to Bug Day 2024 on the internet and it pops up. Registration closes at 4 o'clock today. There's no need to register with the Department of Continuing Professional Development if a certificate or credits are not required. Questions and feedback may be submitted via slido.com. And again, go to slido.com and use the event code hashtag bug 2024. Please take a moment to complete the welcome poll, demographic information, and about our audience, as this is valuable for research purposes for the Department of Continuing Professional Development. You can ask the speakers questions using Slido and vote up any specific question that you might have or that you might like to have answered. You can access Slido from any device as long as you're connected to the internet. We appreciate you giving us feedback, and today's feedback is critical because it helps us plan for next year's Bug Day. And more importantly, we're now also thinking about Bug Day 2026, which is the 30th anniversary of this program. So we need your feedback. Please provide it with Slido, and there's a variety of questionnaires related on Slido. So please complete each speaker's evaluation before you switch to the next speaker in Slido, and please also complete the overall evaluation for the day. Now, without a doubt, there will always be small glitches in any program that's held virtually. Hopefully there'll be few and far between. And with that, I'll turn you over to Dr. Tony Battad, who will present to us complex battlefield wound infections, lessons learned from Afghanistan. As a matter of background, Tony is a retired Canadian Armed Forces internist with multiple overseas deployments over a 24-year career. He is currently an associate professor in the section of general internal medicine at the Max Rady College at the University of Manitoba. Tony, take it away.
Thank you very much. I hope everyone can hear me okay and see my slides. Thank you for the invitation and the opportunity to present. It's been a while since I've retired, and it's been a while since Canadian Forces have been in Afghanistan, but there are some lessons that are still important. Just some pre-presentation statements. I have no conflicts of interest to declare, and all the information I'm going to present here have been declassified, as well as all the photos, and is fit for public consumption. The views expressed during this presentation are mine alone and not at all affiliated with the Max Rady College of Medicine or Canadian Armed Forces. And there are, by nature of this presentation, some graphic images, and so I will warn you, I tried to minimize them, but I thought that some of them would be important to get the context of what I will be presenting. The objectives are as follows. Hopefully, the audience will become familiar with the unique nature of battlefield wound infections and why this is important, even in current day, and how to care for the returning soldier. And I put soldier there because of the nature of this presentation, but as you will see, it's not necessarily soldiers or armed combatants anymore. And what treatments are available for battlefield wound infections, since they are so unique. So I will outline sort of 5 things as we sort of go on, and the implications are for civilian medicine, but the lines between civilian and military medicine have been blurred. We've always learned a lot from, unfortunately, conflicts, and it's no different in this instance. So just a brief overview of the Afghanistan experience. The Canadian Armed Forces deployed to Afghanistan for 13 years. The Royal Canadian Medical Service sent medical personnel there, but we staffed a level 3 trauma hospital in Kandahar as the lead nation for almost 5 years. And this was the largest deployment of the Royal Canadian Medical Service since the Korean War. Over 40,000 Canadian Armed Forces personnel deployed. 158 died, with 7 civilians amongst them. And over 2,000 physical injuries, and more importantly, probably thousands more non-physical and psychological injuries. To give you a flavor of what it's like, that's what it looks like in Afghanistan on a lot of days. There's this talcum powder dust that sort of blows everywhere, and this became very important for infection control in our hospitals. In the summers, it got to 50 degrees. If you happen to be there in the winter, it could be -10, -15, depending on where you were in Afghanistan. And our hospital was plywood and austere, to say the least, although we had lots of modern medical equipment, as you can see there. So what happens to the casualty? It's very different. If somebody gets hurt in Canada, they go essentially from the point where they get hurt to a fairly sanitary and advanced hospital. That's not the case in battlefield medicine. The point of wounding is usually in the field. It's in a tactical area. There's all sorts of dangers going on. And tactical combat casualty care is something that has saved lives. It is when ordinary non-medical personnel, such as soldiers, are the first to apply dressings, including quick clot. They do decompression of chest trauma, and they can do all of these things, and they can actually start IVs also. So that's the first time that the casualty will actually see medical care. But from there is no sterility or anything like that, because the objective is to get the casualty out of the theater and into safety as quickly as possible. From there, medical station, usually the forward operating base, where the first instance of almost a definitive therapy is given. So wounds are addressed, they're triaged, and then arrangements are made to fly them to a Role 3 hospital. This was in Kandahar. A Role 3 hospital has surgical capabilities. From the Role 3 hospital, once damage control surgery is done and the casualties are stable, they then go to a Role 4 hospital that is essentially what is a tertiary care hospital. And we staged out of Landstuhl, Germany. And then from there, they came to a Canadian hospital. So as you can see, there are many points where things can go wrong or where infections can take place. This is just a graphic presentation. On the upper left corner is how casualties come to us. If there's mass casualties, which was often, then they would use a bigger Chinook helicopter. There was always a second helicopter hovering in the background or above, because there was always threats of being under fire. So that helicopter always kept watch. So you can see then that when casualties are being transported, again, it's not the best sort of scenario. Once they get there, they're transported into hospitals, and we triage them in the parking lot of the hospital, essentially, because there's not enough room in the hospital. And then from there, the sickest ones go to surgery right away, and everything is staged. And the last picture is the ICU ward. And as you can see, infection control would be very challenging in this environment because it's crowded, and it's dusty, and it's not well ventilated. So what kind of injuries were we seeing? Well, 65% were blast injuries, and the injury severity score was over 15 in over half of them. So these were very, very seriously ill casualties. 20% or 1 in 5 had traumatic or early amputation. So they were actually sometimes amputated in the aid station to stem bleeding. Now, tourniquets were normally applied, but most of the time they were just a temporary measure to stop the bleeding. But partial traumatic or early amputation happened quite often. 75% had at least one fracture, and 34% were diagnosed with at least one infection, with soft tissue infections comprising almost half of them. We did notice a lot of pneumonia that was starting to happen, and a lot of them were ventilator-associated pneumonia. We had a 4-bed ICU that could expand to a 6 to 8 bed ICU, depending if our ventilators were working. And we were noticing ventilator-associated pneumonia that was happening within 12 hours. And I will show you why that is in a second. So it didn't actually meet ventilator-associated pneumonia criteria, but we were noticing that they were happening. And bloodstream infections, usually through IVs that were inserted in the field, as mentioned earlier. This is just a representation of what human beings will do to each other, and what landmines and blast injuries can be. So you can see that they're very complex sort of injuries. So what is unique about these battlefield wounds? And again, it's not, I'm calling them battlefield wounds, but they can actually occur anytime there are mechanisms of injury, such as bombs and blasts. These wounds are very complicated. The wounds that we're used to in Canada or in peacetime usually are not this complex. You may have multiple injuries, such as farming accidents or motor vehicle accidents, but these types of wounds are quite more severe. So they're usually multiple injuries at multiple sites requiring multiple surgeries, and these surgeries may be delayed, right? The definitive care may not happen until they get to the Roll 4 hospital. Although we had a surgical capability in Kandahar, much of the surgeries we did were damage control surgery. If you're familiar at all with MASH, that's exactly how it happened. Our surgeons did an excellent job of patching people up, but the definitive care didn't happen until they got to Landstuhl, Germany. Now, we did take care of a lot of local, the local population, including local Afghan soldiers. And there we tried to do as much definitive care as possible. And we almost always lost the infection battle because we had no place to send them to for proper healing. So late onset infections were quite common, and this is what we observed in the local Afghan population. And we did observe these in our soldiers that were returning also. So what are the main players? The picture here is a filter from one of our ventilators. And we were wondering, when we first got to Kandahar, I was one of the first ICU physicians to arrive in Kandahar. Our surgeons were wondering, why are these patients almost always getting pneumonia within 12 hours? And so we took apart the ventilators, and this is what we found. And that's the dust that sort of hangs everywhere. And actually, it was at that time that I called Dr. Embel, and I said, what can we do about this? I called him from Kandahar, actually, and I said, you know, we've got this stuff. What do we do to try to figure out what's growing in here? And he put me in touch with Michael Mulvey, and we sent samples actually of this, and we grew Acinetobacter baumannii from these filters. That was probably the causative agent. And then it took us a long time to convince the Canadian government to send us more filters more frequently, but they eventually did that. So most of the main players really are multi-drug resistance gram-negative rods, comprise about a quarter of all the infections, with Acinetobacter baumannii being a big player. And as the audience may know, Acinetobacter has inherent resistance, so it was a very challenging organism. And there was a seasonality to it. Wintertime tended to have worse infections. Interestingly, the MDR-GNR bacteria, as the casualties got better, gave way to the more normal gram-positive bacteria, such as staph and strep. What was interesting was in 2009, my last deployment to Afghanistan. I deployed 4 times. My last deployment to Afghanistan was at the end of 2009, and we had an unexpected finding with our American and British colleagues of invasive fungal infections. The risk factors for this was eventually identified as blast injury, and as you saw earlier, blasts were very common, traumatic above knee amputation, and massive transfusion. And massive transfusion was not uncommon in a trauma hospital. This is what happens when there's a blast and a burn, and this is a local Afghan boy that was involved in a blast and eventually burned. And so this is what we were starting to see. What was interesting was eventually they found out, the Americans did, that this wasn't nosocomial, because we initially thought, because of infection control problems and supply problems, that this was nosocomial, but they tended to be local organisms, and there was a wide variety of them. Mucoroides species was the big player, and it tended to have a higher mortality than the other species, such as Aspergillus or Fusarium. So this was a very interesting thing that they continue to study actually to this day. They try to come up with guidelines. The thing that we needed to do is we needed to suspect it in high-risk patients with the blast injury, and different kinds of scoring mechanisms were done. But if we thought that there was a progressive and rapid wound necrosis with no other cause or explanation in the right population, we went ahead and treated for an invasive fungal infection. So early on, again, before we knew any of this stuff, we knew that we had rudimentary microbiology at our Role 3 hospital. And our American counterparts also had a bit better microbiology capability further north to Bagram, where we could send some of our cultures. And we noticed a lot of gram-negative rods, as I said, because they come early. So what we started doing was giving broad-spectrum antimicrobial agents, and we went through a lot of carbapenems and so forth. But then eventually we realized that this actually increased complications. So empiric treatment against broad-spectrum antimicrobial agents, it took us about a year to 18 months to figure out that this was not actually a good idea. And eventually, the guidelines for battlefield medicine and trauma medicine said, don't do that. Instead, targeted therapy towards invasive fungal infections in the right patient and gram-positives were the standard. And really, it's based on a clinical situation and what cultures that you were getting. Wound care, though, was absolutely necessary. Multiple debridements are usually necessary. Wider debridement than a civilian casualty is usually necessary, simply because, again, because of the journey and how these infections were or how these injuries were being handled. At least 2 debridements in the field. So before they even got to a level 3 or level 4 facility, somebody had already debrided those wounds. And again, it's not always in the most sterile of conditions because as you can see, we didn't work in conditions that lent itself to very strict infection control. What was interesting also was orthopedic injuries presented challenges. Now, they knew this from the Vietnam experience. So it was always policy never to put internal fixation. So it was always, orthopedic injuries were always treated with external fixation devices, even in the local population. And we just brought them back to fix them for definitive therapy once we knew that they were out of the infection range. So that was at least one thing that they did correctly, although those external fixation devices almost always got infected and they lent themselves to bacteremia as well. So what are the implications for today? Well, battlefield wound infections are complex, normally polymicrobial. They carry a high rate of morbidity and mortality. And although it's been a while since we've been in Afghanistan, global conflict is still a reality and sees battlefield wound infections are no longer limited to military personnel, and they're no longer happening to just armed combatants. And conflict is no longer between armies. As you can see in the news, there's all sorts of a conflict all over the world. And if you go, like I know some people who have gone off to try to help in various areas of the world, this is what they're seeing in the civilian population. And so a lot of the lessons we learned in Afghanistan and Iraq before that, with our American counterparts and our British counterparts, are more relevant now than ever. If you're able to go and help the civilian population that is caught in the middle of these conflicts. Really, the principles of treatment are meticulous wound care and frequent debridement, and that can happen also once they get to Canada. When our soldiers came back, they still required quite a bit of debridement of the wounds. And again, targeted antimicrobial prophylaxis and close follow-up. The challenges are this is resource heavy, and we sometimes don't recognize it. So we may get a refugee from an area that has had a wound that maybe wasn't addressed properly, and they could end up losing a limb because of it. So we must really understand and recognize a high risk patients that we see in our civilian practices. Guidelines are coming, especially for invasive fungal infections. Now, guidelines are developed for the Joint Task Force and trauma care for the militaries. They're not completely applicable to the civilian population yet, but we can learn a little bit of that from them, because again, military populations are a bit different. They tend to be younger and healthier also. But the big principles of treatment are meticulous wound care and really to just watch these wounds frequently. These are my references. I'd be happy to forward them to you, like in my email on my next screen. I'd like to thank you for your attention. I'd like to thank Dr. Embel for the opportunity to present this very important topic, as it becomes unfortunately more important in the present day. And I would welcome any questions after or to my email below. Thank you.
Thank you very much, Tony. Now, I've been informed that the land acknowledgement was not heard as there were issues with the audio when José Francois introduced the program. So since the introduction was not optimally heard, I'd like to welcome everyone to the 28th annual Bug Day. Every year the program gets better, and before we continue with the program, I want to remind all of the speakers that it is a 15-minute presentation, and the presentations are grouped in clusters of 3 with a 15-minute question and answer session at the end. Before we continue, I'd like to introduce to provide the land acknowledgement. So today we begin by acknowledging that health services across Manitoba are provided in facilities located on the original lands of the First Nations, Inuit, and the national homeland of the Red River Métis Nation. Shared Health and the Health Sciences Centre respect the First Nations treaties that were made on these territories, and we acknowledge the harms and mistakes and dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. The organizing committee has once again brought together a great lineup of speakers, all of whom will adhere to the 15-minute time interval. And with that, I'd like to introduce Dr. Christina Greenaway, who will present to us refugee health, infectious disease disparities, challenges and opportunities. As a matter of background, Chris is an infectious disease physician, clinician, researcher, and migrant health expert at the Jewish General Hospital at McGill University. Her research program focuses on the promotion of health among immigrants and addressing infectious disease health disparities in this population. She has conducted clinically and policy relevant research on the magnitude and on the magnitude of the burden of various infectious diseases and has led infectious disease screening guidelines for immigrants in Canada and Europe. Chris, thank you very much for joining us. The floor is yours.
So thank you very much for the opportunity to be here. Thanks for the invitation. And it's my pleasure to be here at my alma mater, even though this is virtual. I did my infectious disease fellowship in Winnipeg and under the supervision of Lindsay Nicole, who's here today, and John Emble was an internal medicine resident when I was an ID fellow. So it really is a pleasure to be here. And I will talk about refugee health, infectious disease disparities, challenges, and opportunities. And I have no conflicts of interest to declare. And today, what we will review is trends in voluntary and forced migration globally and in Canada, describe some of the burdens of various infectious diseases among refugees, and try and understand some of the barriers that patients, providers, and health systems encounter, and what are some of the best practice approaches to develop to deliver culturally adapted care. So, as was alluded to in the previous presentation, migration has tripled in the last 50 years, and forced migration is at an all-time high of 117 million people in 2022. This is the highest since World War II. This is driven by conflicts, climate change, and economic instability. And as you can see on the graph on the right, that the majority of migrants are in Asia and Europe, but we have many also in North America, in the US, and Canada. Canada is an immigrant receiving country and has been built on migration. 23% of the population in Canada are foreign born. And since in the past, up to 2020, we're receiving over 250,000 new permanent immigrants per year. This increased to almost 500,000 between 2021 and projected to 2025. And this is to fill our labor force needs. And our migration policy has really been built on accepting large numbers of economic immigrants who do fill our labor force needs, and family reunification of bringing the families of these economic immigrants to Canada, and then our humanitarian responsibilities and accepting 15 to 20% refugees. So just to go through this briefly, because I think it's important to understand that immigrants are heterogeneous, that we do have voluntary and forced migrants, that as you can see on the left, that voluntary migrants are the permanent residents that we just talked about. There are temporary residents that are on work visas, student visas, and visitors, and there are forced migrants that we will focus on today. And these are refugees that have a well-founded fear of persecution for many reasons, meet the Geneva Convention, and refugee claimants are people who claim asylum, and their claim has not yet been decided. We have a long humanitarian history of accepting refugees, and refugee flows have increased dramatically over the last 10 years to match the conflicts that are ongoing in the world. And so now we accept 72,000 refugees, and these are from people that are from Syria, Afghanistan, and most recently from the Ukraine. And we have also seen concomitantly a dramatic increase in asylum seeking claims to Canada in the past 10 years. And as you can see that in the graph in 2015, there were less than 20,000 asylum seeking claims, whereas projected there are almost 180,000 asylum seeking claims in the upcoming year. 90% of these claims have occurred in Quebec and in Ontario. And in Quebec, we've received about 50% of the asylum seekers. And as you can see that asylum seeking claims were increasing, decreased in COVID, and then post-COVID, there was a dramatic increase. And this increase, you can see that where people were making claims changed from the green, which is on the border, to claims at the airport. And just to give just a little bit of background, that the migration routes to Canada, as you can see, that Canada is geographically isolated, that the only way typically to get into Canada, to migrate to Canada, is by plane. And so our refugee movements have been orderly, planned, and have come by plane. And in the post-COVID era, that with increasing economic instability and different political changes, there has been a dramatic increase of migration. So you can see that the US, Europe, and Asia have a land border where people can cross, whereas in Canada, this has not been the case. But we have seen a dramatic increase in asylum seekers, and this is, as you can see, because of the economic instability and geopolitical forces, that there was an increase of people coming across the Darien Gap, which is a 97-kilometer jungle trek that is treacherous, with many land and aquatic animals, and criminals and human traffickers. And these people have gone through this journey up through from South America through Central America and to North America. And what we saw was that there was a large number of people that made their way through the US and up through the border between New York and Quebec. And so there were more than 500,000 people that came to the Darien Gap in 2023. This border crossing was closed in March of 2023. And so what you saw consequently was flows move from the border to airports. And this just illustrates the dynamic changing migration patterns that are driven by geopolitical forces in the world. Migrants are heterogeneous. You have economic migrants and you have refugees. Economic migrants, as I previously described, these are healthy people that are pre-selected and have a healthy immigrant effect, whereas refugees are selected from some of the most vulnerable situations or have come through very difficult conditions and have higher medical and mental health needs. We have been screening for many years. In Canada, we screen with a history of costly chronic diseases, do a physical exam, we do a chest x-ray to rule out active TB, do syphilis testing, HIV testing, and HIV hepatitis, viral hepatitis only if there's HIV or chronic liver disease, so very few get screened, and refugees have recently been offered vaccines pre-arrival. So refugees are screened pre-arrival and asylum seekers are screened after arrival. Migrants have several infectious disease health disparities. As you can see in the first column, that many of these people come from countries that have a high prevalence of several infectious diseases, including tuberculosis, viral hepatitis, HIV, and various parasitic infections. And under the column of percent among migrants, you can see that migrants have a disproportionate portion of these diseases. Their risks are several-fold higher than the Canadian population, and refugees often have a higher risk than other migrants. So let's just walk through a few cases that we've seen and some of the challenges that we encountered. So this is an 18-year-old Haitian male who arrived in Canada 2 weeks prior. He had a 2-month history of a painful enlarging cutaneous ulcer on the right arm. He was otherwise well, and the differential diagnosis of this would be non-infectious or infectious. Looks like Mycobacterium ulcerans, given the chronicity, or maybe cutaneous leishmaniasis. How is this possible? He's from Haiti, and actually this was leishmania. And so how was that possible? Well, he was born in Haiti, had lived in Brazil for 2 years, and then traveled for 3 months and went through the Darien Gap and through many countries that have that are endemic for leishmania. Another woman that we saw was a Congolese woman who was pregnant, who arrived from a refugee camp 6 months previously. She presented with a 2-month history of cough and hemoptysis. and she was diagnosed with smear-positive pulmonary TB. She was screened with a chest X-ray prior to arrival, but this is not uncommon to develop active TB despite a normal chest X-ray. She had a complicated hospital stay where she had toxicity to her TB drugs. She delivered a preterm baby. The baby went to the NICU. There were infection control issues. She had prolonged isolation. There was also a complex social situation where she lived in a refugee hotel where she was not able to isolate, and there were a lot of social issues. I'm happy to say that she did extremely well. The baby did well. She responded well to treatment, and she's now living in an apartment with her family with a lot of supports and social supports that were provided to her. One other example is a 58-year-old Syrian male who arrived in Canada as a refugee. He was found to have diabetes, and because of an increased ALT, had investigations and had an ultrasound that showed cirrhosis. He was found to have chronic hepatitis B, and this was due to a transfusion that he had when he was younger. And this case illustrates the delayed diagnosis and delayed access to care. He was not screened because we don't have routine screening before or after arrival. And because he's unilingual Arabic, he had several difficulties accessing care. So what these cases show us is that there are many barriers accessing care at the patient level, the provider level, and the health system level. For the patient, there are language barriers, cultural barriers, difficulties navigating the health system, some financial barriers. Providers don't know who to screen, how to screen, and often don't have the resources. And our health systems, we often do not have the kinds of wraparound care that we need or linguistic supports for patients. So some of the best practice models are for the patient, multidisciplinary care with wraparound care, linguistically and culturally adapted, with supporting the social determinants of health, giving providers the education as well as the tools of reminders and access to interpreters and administrative supports. There are many examples of refugee clinics that do a very good job of welcoming new refugees and integrating them and supporting them. Some of the major challenges after 2 years is integrating them into our health system, our regular routine health system. There are many resources for practitioners in terms of their migrant screening and vaccination guidelines for Canada, as well as several other resources as outlined on this slide. The WHO has also produced many great resources. There's a new online course on how to the standards for delivering culturally competent care. The World Health Report reviews many of the disparities and some of the solutions. And to end my presentation, what I would like to say and summarize is that migration is here and it's increasing and it's dynamic, and I assume that it will continue to increase due to conflicts and global change, global climate change. And migration is an important health determinant, and forced migration increases the risk. Many immigrants are at increased risk for several infectious diseases. As practitioners, we need to be aware of the global distribution of infectious diseases. We have to make sure that we screen, and as there is no routine screening post-arrival. We need to be aware of imported diseases that may not be native to the country of origin, as that young Haitian case showed us. So there's need for a good migration history and travel history. So where were you born, but also where have you traveled? And the typical infectious diseases can be difficult to manage given complex social situations, and our health system needs strengthening to address culturally and linguistically diverse populations. So I will end there and just say that the global is local and now here, and I will be happy to address questions at the end of this, at the end of the session.
Thank you very much, Chris. Our next speakers, Charles Bernstein and David Alexander, are a dynamic duo of a clinician and basic scientist. Charles is a gastroenterologist at the University of Manitoba and recognized as a world authority on inflammatory bowel diseases. Charles has a specific interest in Helicobacter pylori and has undertaken extensive studies to better understand the epidemiology of this pathogen. And David is a laboratory scientist at Chatham Provincial Laboratory in Winnipeg and an assistant professor with the University of Manitoba Department of Medical Microbiology and Infectious Diseases. Charles and David are going to present Helicobacter pylori, the clinical story in 2024. Now, I would like to remind everyone that we're going to listen to Charles and David and then transition to a 15-minute question and answer session. So please upload your questions to Slido, and we'll address all of the questions for the past 3 presentations in the question and answer session. Charles and David, the floor is yours.
Thank you, John. Do I have screen sharing? Can you guys see my slides?
Yes, your slides are perfect. Do screen perfect. Thank you.
So thanks for this opportunity, John. I want to say before we start that it's great to see Tony Battad, who works across the river, but we never see each other, and wonderful to see Chris Greenaway, who I don't think I've actually seen in 35 years, maybe longer. So great to see you, Chris. And thank you both for those really interesting talks. So H. pylori was an interest of mine when I began my gastroenterology career, because I began it at the Center for Ulcer and Research Education at UCLA in 1989, when the dictum was no acid, no ulcer. And these were the acid gurus at UCLA, and they really didn't believe that H. pylori was the answer for peptic ulcer disease, because they thought they had the answer with acid, and both are really the answer. But H. pylori's discovery won Barry Marshall, a clinician, Nobel Prize in medicine in the 1990s. We had done some epidemiological work on H. pylori in the 1990s, especially with our indigenous communities, showing that they're nearly ubiquitously infected with H. pylori. And the work on H. pylori sort of died down, and it's been resurrected through a grant that David and I are involved with the National Microbiology Laboratory in trying to develop ways to define antibiotic resistance easily so that we could better treat H. pylori, because we're treating it in, quite frankly, a pathetic way, relying on old data to use relatively old regimens and not really knowing whether our treatments are really going to be sensitive for the H. pylori in our communities. So H. pylori remains an international infection where the highest infection rates still are in the developing world and lower in the Western world. As you can see by this slide and the different colors, the lightest colors being in the Western world and the lowest rates. It is though typically in the 90s was found extensively in the indigenous community and also in new immigrants, as Chris was discussing. However, the immigrants' children and offspring are rarely harboring H. pylori these days. The prevalence is still high, though, in those immigrants and the children of those immigrants who come with them. And as I mentioned, First Nation Canadians. The lifetime risk of developing a gastric or duodenal ulcer is thought to be somewhere between 5 and 15%. Dyspepsia is really a complicated issue around H. pylori. Most patients with dyspepsia who have their H. pylori eradicated, in fact, do not have their dyspepsia cured. H. pylori is associated with gastric cancer, although, quite frankly, it's rare in those that are infected, although it is considered a carcinogen. Most infections are acquired in childhood during the first 10 years of life, although it's not recommended to routinely test family members of H. pylori infected individuals we in Canada have never embarked on a widespread, let's eradicate all H. pylori. We would have to seriously treat, for instance, in our Indigenous communities, everyone in the community, other than those who are already treated and known to be having the infection resolved. It's unlikely, it's thought, that H. pylori is transmitted as adults, even with close personal contact, which is very interesting, so that once a patient has H. pylori and causes a bad ulcer, and we treat them, and they go back to live even in a crowded house, we're not necessarily worried about them getting reinfected so much. Now, this is interesting because these are data from Malaysia, and we talk about H. pylori in different countries, and I show these data just to show you that it's not uniform in any one country. In Malaysia, where they have 3 predominant populations, of course, the breakdown of H. pylori prevalence by pediatric age varies, but also varies by ethnicity in that country. So who should be tested for HP? People with a duodenal or gastric ulcer diagnosis, whether you're seeing them now and when I see them acutely and scope them and find an ulcer, I'm of course looking for H. pylori. And if somebody tells me they had an ulcer treated a year ago or 5 years ago or 10 years ago, and it wasn't sure whether H. pylori was treated, when I'm scoping them, if I'm scoping them, I will biopsy their stomach to look for H. pylori. In patients with dyspepsia, especially with epigastric pain dominant symptoms, it's reasonable to look for H. pylori and treat it even without an endoscopy if you find it, on the consideration that the dyspepsia may reflect a peptic ulcer. Now, people who have gastric cancer, especially in a young index case, it would be reasonable to get rid of H. pylori in their first degree relatives, since there may be a genetic risk that may have the cofactor of H. pylori contributing to a gastric cancer. And I do think, and when I do this, when I'm scoping First Nations patients and immigrants, I am biopsying them to look for H. pylori because I think the prevalence rate is very high. And when I do find H. pylori, I do treat it. It is controversial, though. It's not necessarily an approach shared by everyone. In fact, at our international GI symposium this year, which will be our 28th on June 12th and 13th, it doesn't quite have the viewership as Dr. Emble's famous Bug Day, but it is a wonderful symposium with international speakers, and I am bringing a speaker in from Brown University, a world expert on managing H. pylori, and we'll hear more about that. How to diagnose it? One of the most sensitive and specific diagnostic approaches is on biopsy, when biopsies are taken during gastroscopy to assess for histology. The urea breath test is very accurate to identify infection. That's in our hospital done through nuclear medicine. And the H. pylori stool antigen test has been used and should be used more frequently. Clinicians are not always aware that it's available, but it's an excellent test to identify current infection. There are a higher proportion of equivocal results with it than with the urea breath test. Serology, which is widely used, is a bad test. It identifies if somebody's ever had an H. pylori infection, but cannot discriminate between current infection and past treated infection. One has to stop proton pump inhibitors, which are widely used, maybe the most widely used drug in the world, for 14 days prior to performing a UBT or a H. pylori stool antigen test, because it can suppress the use of PPIs, can suppress H. pylori infection and growth. Up to 20% of people while on PPIs may get false negative results due to the suppression of the organism. PCR for HP has a high sensitivity and specificity, and we'll hear a little bit more about this from David. So how do we treat H. pylori? Well, not very well is the punchline. And you really need to use a quadruple therapy regimen for 14 days. The first regimen on this list and this list is 8 years old. The first regimen on this list includes 2 drugs that we're highly resistant to in North America, chlorithro and metro. But for some reason, when you use them together, including with amoxil and PPI, the eradication rate is good. I typically start with a bismuth-based quadruple therapy regimen. That's bismuth, salicylate, metro, and tetracycline. Resistant rates are low with bismuth and tetracycline. This is a tough regimen because you're looking at agents given 4 times a day. And by the way, any regimen that uses metronidazole, many patients get very nauseated with it. One could use amoxil and levofloxacin with a PPI, and one could use amoxicillin with rifabutin, although I have to admit that's rarely used. I can't remember the last time I prescribed rifabutin. You should not use just a triple regimen with chlorithro and amoxil because the resistant rates are very high with chlorithro, and certainly not chlorithro and metro because the resistance rates are high for both. Just a few words about these data in Canada. We have no data from Manitoba that I know of, although David may correct me on that. And you could see from Alberta how high resistance rates have been shown in recent times, even for levo. And the cure rate, if somebody's previously had a failed treatment, is lower than if people are having their first treatment. And so you can see that these rates aren't very good. I mean, to cure an infection with antibiotics these days at 75%, I don't think any of our experts on the panel with us today would think that that would be adequate. Sander Van Zanten in Edmonton has had an interest in, and he's a gastroenterologist in H. pylori for years. He originally worked in Halifax and subsequently in Edmonton, and he has studied this for many years. And you could see how if Halifax and Edmonton do share similar epidemiology, and we don't know this, but if they do, you can see how resistance rates have risen between the early 21st century with rates below 30% for these antibiotics early on, and later much higher rates. It's suggested that the resistance to HP in the USA and Europe is also high for metro and less for chlorithro than has been reported in Canada, with very low resistance rates for amoxicillin. So it's a good agent to partner in our regimens. There is a combination pill that has been developed. We don't have it in Canada of bismuth, metro, and tetracycline. Its advantage is just for ease of use for patients. I mentioned the rifabutin regimen. There is a combo pill for that as well. And as I mentioned, that metronidazole resistance can be somewhat overcome if combined with something like amoxicillin, but not clarithromycin. There's a suggestion that certain PPIs have higher cure rates, like esomeprazole and rabeprazole. And there is a new acid neutralizer, vonoprazan, that is available and FDA approved in the States. It's a potassium competitive inhibitor, not available yet in Canada, and may be a more potent contributor to an H. pylori eradication regimen. If we're going to test for eradication, we need to wait for at least 4 weeks after treatment is finished. And for patients who are H. pylori positive and have a peptic ulcer, all of us do continue to treat the ulcer with PPIs for at least 2 to 3 months to be sure we're healing the ulcer when we're not going to be sure whether we've actually eradicated the H. pylori. So I'm going to turn it over to my colleague, David Alexander. David, if you can share your slides, do that. And if you can't share them, you can just tell me to advance the slides and I'll do that for you.
I'm going to try sharing my own slides and hopefully this will work. Just get the full screen going, hopefully. Does everyone see the full screen for my slides now?
Yes.
Okay, perfect. So first of all, it's a pleasure to be speaking at Bug Day. I'm relatively new to this Helicobacter world. And in fact, I'm used to working with enteric bacteria, organisms that are typically diagnosed through bacterial culture or molecular testing such as PCR. Especially culture is really helpful because it promotes antimicrobial susceptibility testing and supports a variety of molecular epidemiology and research techniques. However, as Dr. Bernstein has described, for diagnosis of Helicobacter, we typically use indirect methods, and you can't culture H. pylori from a urine breath test, for example. You only get culture from invasive techniques such as gastric biopsies. Molecular tests, PCR for Helicobacter, have been developed, but none are Health Canada licensed, which means they're not used in Canada. And that's unfortunate because molecular testing really can help us tackle this issue of antimicrobial resistance. So for example, we know that clarithromycin acts by binding to the bacterial ribosome to inhibit protein synthesis. And we know that if you have mutations in ribosomal genes, these lead to clarithromycin resistance by altering the ribosome structure just enough that the drug can no longer bind. And using a properly designed molecular test, you can actually find these mutations and better inform treatment. In fact, for all of the drugs that are used to treat Helicobacter, resistance genes have been identified or at least proposed. The trick is not all of these resistance genes or the mutations associated with the genes have been validated. We don't know which mutations are clinically relevant to improve or influence patient outcomes. And the other thing too is your typical PCR test can only really target maybe 3 or 4 of these mutations, and we're looking at dozens of genes and even more mutations. So the question is, what's to be done? Dr. Bernstein mentioned, some of us in Manitoba have created what is called the Canadian Antibiotic Testing Consortium for H. pylori, and this CATCH-HP group, which includes Manitoba labs as well as colleagues from across public health and academic centers in Canada, actually have funding from both Genome Prairie and FAC to use targeted metagenomic approaches, really cutting-edge genomic tools to improve detection of Helicobacter pylori and ideally catalog and detect mutations that contribute to antimicrobial resistance in this bug. And really the goal is to better inform treatment. Now, I'm the first to admit there's a lot of technical barriers that we're facing with this project, and there's no guarantee of success, but if it does work, maybe we'll be invited back to Bug Day in a couple of years. That said, we're very excited about the genomic approach, and we're not the only one. There's actually an international consortium who recently published this paper where they sequenced over 1,000 Helicobacter genomes from 50 countries. And the goal was really to capture the genetic diversity of Helicobacter and understand what's contributing not only to this diversity in the world, but also to drug resistance. And I guess the biggest take-home message from this paper was really Helicobacter globally is incredibly diverse, but this diversity is not random. It is very closely tied to geography and some would argue community. The genomic signature of a Helicobacter strain from Europe or from somebody of European descent is very distinct from Helicobacter genomic signatures from Asia. And the other fascinating thing is the longer a population has been perhaps isolated, such as in Australia and New Zealand, the more distinctive their Helicobacter signatures are. Some have argued that this pattern actually highlights the intimate relationship between Helicobacter and humans, and that the patterns we're seeing in these genomic signatures of Helicobacter mimic the dispersal of human populations out of Africa and around the world. So lots to be excited about with Helicobacter genomics. And with that, I guess our time is up and I'll finish. I hope you've learned a little bit about Helicobacter. It's a very prevalent bacterial pathogen associated with dyspepsia and can cause stomach ulcers and gastric cancer. Effective treatments are available, although we'd like to make more effective treatments because we're very concerned about antibiotic resistance, as well as we've highlighted a need for better diagnostic tools. And with that, I'd like to thank you for your attention, and I guess we're on to the question period.
Thank you very much. Now, I have a question for Amanda. Where on earth are the questions?
They'll appear on the screen in 30 seconds.
Oh, thank you. Well, thank you very much to all of our speakers. And I'm told the questions will appear in a matter of seconds. The first question is, Dr. Bernstein, what is the risk of reinfection with Helicobacter, and how should these be managed?
It's a great question, and I wish I had a good answer. So I'm going to make up an answer because I think that the data are weak in this area. And of course, this is a question that cannot be answered serologically because once someone is seropositive, they're going to remain seropositive for a very long time. And so clinicians should not consider that a patient is reinfected if they were once treated and then do a serological test. So one would have to actually study patients through indirect testing, for instance, stool antigen testing or urea breath testing, or subject them to gastroscopy with biopsy for histologic testing. And that would really require a substantial study because we think the reinfection rates are actually quite low, which is why we don't follow up patients years to follow. You'd think, let's say today you diagnose a patient with an H. pylori positive peptic ulcer, you treat them for H. pylori, and let's say in 2 months from now you prove that their H. pylori is eradicated, and so you're pleased with this outcome. Since they'd had H. pylori once, you'd think that you might want to know in 5 years from now because their peptic ulcer may have led to a life-threatening GI bleed. But in fact, we don't do that because we do think the reinfection rates are quite low. And in fact, we know that when we send people back to communities where the infection is quite highly prevalent, the reinfection rate is still quite low. And I don't understand the immunobiology behind that, what it is that immunologically is established that protects a patient from reinfection.
Thank you. The next question is, currently in Manitoba, only gastroenterologists can order Helicobacter pylori stool antigen testing. Will this change in the future?
I don't know if that's true. I do believe that pediatricians can order it on kids. If it's true, it's unfortunate. And I would defer to David because CADM does run the stool antigen testing. Do you know if any clinician can order that, or is there a limit on this testing?
So I actually don't know because CADM only runs serology testing, and the fecal antigen test is something that I know has been a hot topic of recent. I guess the only thing I'd comment is really Helicobacter, even though I've worked in public health for many years, Helicobacter hasn't been on our radar as much because in many ways it's treated by gastroenterologists and clinicians as sort of a disease, not as an infectious disease. And so I think that's one of the reasons why some of the surveillance and testing and other things hasn't kept up with how, for example, rapidly we responded to something new like COVID. And this is where it's really great to put together this collaboration, both in Manitoba and across the country, to see if we can change that and pull Helicobacter into the 21st century. The other thing, I guess, with Helicobacter is it wasn't discovered till 1982, and it wasn't until the 1990s, which really wasn't that long ago, that it was recognized. So we have a lot of catching up to do with how we both detect and manage and treat this organism.
John, as the Director of Infection Control at HSC, do you know if there's some prevention on who can order HP stool antigen testing?
No, that would be a shared health laboratory question. Sorry, I don't know.
Okay.
Thank you. So 2 questions from Dr. Battad. Both are actually very good. With massive transfusion, are blood products supplied by the Canadian Blood Services, or is there a local or global supply? And this refers directly to the conflict that you discussed.
So an interesting question. We had massive transfusion protocols, but we would have blood supplied from Canadian Blood Services, although it was never really enough. Our American and British counterparts also supplied blood, but when we had massive blood transfusions, it was a lot of whole blood that was taken from the camp, actually. So Kandahar exploded to a population of almost 5,000-6,000 by the time I was there. And so everybody had their blood type and screened And if we needed a massive blood transfusion, we would actually go on the loudspeaker and say, we need this type of blood, and people would come and we would take their blood and use a transfusion.
Wow. Next question for Dr. Battad. Were there notable differences between infectious presentations of civilians presenting to a military hospital compared with those of the soldiers?
Yeah, there were actually quite a bit. We saw a lot of younger people. The civilians were mostly younger people that got caught up in the crossfire, and because of their nourishment status, they tended to get infections very quickly, especially pneumonias. And this is actually how we discovered why we were getting such a high rate of ventilator-associated pneumonias, because our local populations were the ones that were getting them. And unfortunately, with respect to the wound infections, we didn't follow them. Once we did the best we could, we had to move them out of our hospital to make room for Allied soldiers. And so we had to move them to the local hospitals. And after a while, it became a little too dangerous for me to go out, and they didn't want me going out to follow them up at the local hospital. So we lost quite a few of them to follow up, but there was definitely a difference, especially in the children.
Thank you. Now, although this question isn't present, it's a question that I've had for some time. For Dr. Greenaway, what do you predict will be the healthcare implication for our increased migration to Canada? And you made a couple of very interesting points, specifically that Canada needs the immigrant population base basically for workers. As I mean, the Canadian population just isn't big enough to support all of the work that needs to be done. But what do you perceive, or what do the experts perceive as the financial and healthcare impact of the massive migration that we're having now?
Thanks, John. And I think that just in terms of, as you mentioned, I mean, we need migrants to fill our labor force needs. But I think that we're very behind just in terms of two things. One, our screening protocols, that we have no systematic screening post-arrival. We have no Department of Migration at the level of FAC or so to give guidance for screening guidance, and there's no accreditation for implementing culturally competent care. So I think that the writing is on the wall in terms of the numbers of people that are coming to our country. We're feeling it in Quebec, and I think that we just really need to start to begin to have discussions as to how do we improve screening programs to optimize the health of people that are coming, as well as how do we improve our health systems to be able to address needs, so the needs of these diverse populations. So I think that there's a lot of work to be done. And I think that the implications for our health system is if we don't make some changes, I think that we're going to continue to see poor outcomes for the population that we're bringing, the healthy young people that we're not screening for viral hepatitis, as well as people who are coming as asylum seekers. So I think that we have a lot of work to do to improve not only our policies and practices in Canada, but to strengthen our health system so that you give practitioners the tools to be able to really provide care, culturally competent care.
Thank you. Another question for Dr. Battad. Thank you for your service. It begins, how did military logistical challenges like supply chain disruption in conflict zones impact the management of complex chronic infections like osteomyelitis, for example?
This is actually an excellent question. Osteomyelitis presented a unique challenge, and there's still a lot of data that we're trying to sort out. I'm not anymore. I'm out of that, but they're still trying to sort that out. So early on, challenges getting antibiotics, and we were going through them quickly. And of course, the bureaucracy in Ottawa was telling us that no, we had our supply and it should last this long. And so that was a big challenge. And because of that, although I can't really present the data on what we learned from that was there were a lot of probably unnecessarily complicated wounds such as osteomyelitis, especially in the complex orthopedic patients. So that presented a challenge. And if you expand that now to the current conflict, the conflicts that are going on with civilians, that's even a bigger problem, because at least in the military, we had a dedicated supply, and we were eventually getting them from countries that were closer. But for the refugee populations, they don't have that.
Thank you. So one last question to Dr. Bernstein. Helicobacter quad therapy containing bismuth subsalicylate, what's more desirable, the chewable tablets or the liquid version? Or does it matter?
Yeah, I don't know whether it matters. It's an interesting query about reducing the effectiveness of one of the other agents. It's a weird thing with Helicobacter treatment. We know that we're using agents that are potentially highly resistant, but when they're in combination, they seem to work. It's not highly resistant to tetracycline or bismuth, but it is highly resistant to metro, but it seems to add to that regimen. I almost never give people liquid Pepto-Bismol. They're almost always taking tablets. So that regimen does still seem to work, even though it is a very difficult regimen. There are a host of other questions that we're not going to get to, but I see that they really all revolve around the H. pylori stool antigen testing. And so if people from Shared Health are on the line, you should see that this is a test that we really need expanded. It should not just be available for pediatricians, not just available for gastroenterologists, and nobody really should be rejected for ordering it. It's really not that expensive a test, and it does identify active HP infections. So this is something that hopefully Bug Day's presentation can change.
Thank you to our three speakers, and we'll move on to the next section. I'd like to introduce Dr. Greg German. Greg is a phage professor, clinician investigator from the University of Toronto, and lead of the Association of Medical Microbiologists and Infectious Diseases Canada, phage therapy group. He is the co-founder of Phage Canada, a nonprofit organization, and chair of the Global Clinical Phage Rounds case discussion group. Greg is going to speak to us about phage therapy, ready for prime time or wishful thinking. Now, just for clarification, although this is a therapy that's been around for many, many years, it hasn't seen prime time in Canada. Are we ready, or is this make-believe? Greg, floor is yours.
Thank you so much for the introduction, and let's get the party started. Forgive the small technical challenges. I think you're seeing my main screen. We're ready to go? And you can hear me?
Ready to
Great.
go.
Yeah.
Thank you. So wonderful to talk about this prime time or wishful thinking for the 20th annual Bug Day. And just to share with you, I have only a few disclosures as being a co-founder and clinical director, and we're all treaty people from an extra land acknowledgement. So is this prime time on the left, or is this wishful thinking on the right? And so, you know, this is essentially what we're working from a phage therapy perspective. It was already mentioned on how long it's been happening. From phage therapy, it predates the antibiotic age, and phages were used in the 1920s. If you're going to try to make a case for good viruses eating deadly bacteria, and for those that don't know much about phage therapy, there are bacterial viruses that target bacterial infections. The idea is that they're very specific and less collateral damage than antibiotics. They out-evolve and have been doing this with bacteria over the last 3 billion years. They're adaptable, trainable, and modifiable. They're like a little bit of a nanobot soldier with 50,000 pieces of information to make it the way you want it. Generally, they have a predictable code and safe, and they're ubiquitous. They have immune escape. The humans have been living around bacteriophages for a long time, and there's more bacteriophages in their gut than there are bacteria in human cells. The other issue we're sharing is that it biocures, where you end up targeting biofilm infections that are otherwise sticky and dead-end infections. And so you can have those phages, when they see that bacteria, they make 30 to 300 more of those phages. So it's actually a pharmaceutical site or a police station right at the scene of the crime or right where the medication's needed. And when the bacteria is gone, the phages are gone, which is the auto-dosing point. It disables bacteria if it doesn't kill it. Sometimes capsule and losing a capsule is important for getting around a bacteria. But if you lose a capsule, now the immune system works. They're scalable, they're shareable, they're synergistic, and they treat not only infections, which is a big focus of today, but non-infections, because if you modify the gut flora, it's been shown that you can target issues like diabetes and weight loss and inflammation in general. And then from a phage perspective, as seen in this review article, not only is it for human health, we'll be spending a lot of time on today, but there's environmental health and animal health. So we've been doing phage therapy in Canada for a long period of time. We actually have one of the progenitors, Dr. Felix Deharel, who's in the Canadian Medicine Hall of Fame, discussed phages in a 1931 paper. Phages were installated in a wound in 1935 and published at the Montreal General Hospital. But there's a comment, there have been no cases. So if you go up to use the up-to-date resource, and other resources just suggest that there's like a handful of cases, and that's a challenge that has to be worked through. So just in your own mind, in your own head, if you can just think, as of November of 2022 in the published literature, how many patients have been treated with phage therapy for urinary tract infections? If you could just think, was it that handful of 5 cases? Or maybe there's more because you're picking up other cases from other places that aren't in the English literature, or 800 or 1,000 or 1,400. So if you really thought about it for a second, it would actually be, the answer isn't even on this scale. It's actually been 1,450 human cases since 1926 all the way from 2022. And what that shows is that when we studied this over, approximately 80% reported clinical cure with the therapy, with even a higher proportion showing clinical improvement. Now this is with both phage and antibiotic in some of these phage arms. So it could have been the antibiotic that produced that. We did a subgroup analysis, and Dr. Jonathan Cook did that. And when we just looked at the 557 cases alone, and most of these were intravesicular cases, the cure ranged from 74 to 80% and eradication at 80%. And in that small study, or that small series of 557 cases, there was only one minor adverse event. So you're now probably going to be thinking a few other things. Where else are all these cases? And not just for UTIs, which is about 8% of the global cases are for urinary tract infections. What about for other infections? So if you think of it globally, there's a process called Global Clinical Phage Rounds, which started about 15 months ago, and I'm the international chair of this rounds. And we've now had our 15 sessions where we hear about cases across the world, including ones that we have done in Canada. And we're seeing cases from the Belgians, the Georgians, and others. I'm actually going to Lyon, France to talk about UTI cases, and as well as a time when Dr. Tristan Ferry and Dr. Ranier Paz are hosting a session with 60 other treaters, and he'll be sharing more about the 40 patients that he's treated, and he takes video clips of these and shows that people can walk when they couldn't otherwise, and they're avoiding amputations to their dead-end infections. And you can see that some of these are already been published cases, or cases in to be published. It's also focusing on transplant health. There's even a recent series out of Switzerland on trying to decolonize with fecal microbiota plus phage therapy in addition to that. You can see that the Canadian arm also talks about Dr. Michael Parsi and his efforts at the Public Health Agency Canada National Microbiology Lab, where they're developing a phage laboratory. Okay. So, but hey, there's case selection bias. You can just publish cases whenever, and that really doesn't move the needle anywhere. So there are a couple strategies for that perspective. Let me just get into the right world. And one is you can just do consecutive cases, which gives you an idea of its success rate. And the Belgians have done this. And the Belgians had worked off the Georgian phages. And the Canadian helped the Georgian develop their phage center in the 1920s. So where we're working with this is that this is a registered trial. It was methodical. It was for challenging infections, which otherwise wouldn't be easy to use with antibiotics alone. Antibiotics were used, but most importantly, the phage and the bacteria had the best opportunity to match from a lock and key perspective. They used a compounding or magistral preparation rather than a off-the-shelf manufacturing, good manufacturing perspective. And you can see that there's actually really high eradication events and 7%, only 7% minor side effects. You can see the variety of conditions and that were addressed. You can also see the variety of organisms that were addressed with a high predominance for Pseudomonas aeruginosa. And then here's a little bit more of their workflow. So if you want to send an email to pt@mil.be, this goes to the Belgian military, and they'll work with you further on that perspective. At the same time, there are cases of being published that are negative or ineffective. And you can see Dr. Simon Aslam is the clinical lead of the IPATH group out of UC San Diego, the first phage center in North America. And she comments on 5 individual applications and 4 patients, and non-modified phages were used. Phages showed less susceptibility in 3 out of the 5 treatments. There were breakthrough bacteremias occurring, even appears to be sensitive. Now these ventricular assist devices, they have a lot of goo and they have a lot of blind ends, and that may be one reason why, but suffice to say, we are publishing cases that aren't working. Phage therapy doesn't show the mechanism, so that's another potential issue. So we have our Australian colleagues who've also been leading this personalized phage therapy space, and they've now treated, instead of 30, it's up to 45 cases across Australia, and you can see from their website on one of them, and they're trying to show where the bullets are. They're trying to show where the parachutes are working or not working by doing as much information as they can in terms of how the phages are interacting, and they're using a variety of protocols, including kinetic blood sampling, as well as even transcriptomics and metagenomics to show that things are working. They're still in the process of analyzing their information. They're also trying to get good PK/PD information on where the phages are before and after the dose, and even where virology is before even being exposed to the bacteriophage. So there's been over 25 cases that have distinctly used this STAMP protocol out of the 45 cases in total. Detailed results are pending, and there's another process called Phagistry, an international group that's also trying to lead off the STAMP protocol, and there's Canadian interest in this as well. So the next is, where's the successful clinical trial? And there has been a lot of a lack of clinical trial production. There's the PhagoBurn trial, which essentially used something that was so low in a concentration because of a variety of things, and head-to-head versus silver treatment for wounds that already has a very good chance of success. So that was a negative trial, but also published. And then there was a trial that occurred with Georgian phages out of Switzerland, and in that trial, it showed an effect, but the placebo also showed the same effect, and maybe because it had an inhibitor or some sort of preservative in that placebo, that may have been one reason why, but we're still lacking a clinical trial, and it's also showing a lack of success in Pseudomonas and clinical trial for cystic fibrosis, where they're not using personalized phages. There's challenges with recruitment as well. Yet, there is something, and that just happened recently in August, where it's the early results for a phase 2 trial, and this is from a company called Locus Biosciences, and suffice it to say that they have a preparation of 6 E. coli bacteriophages, and they have super changed with genetic engineering 3 of those phages to be even broader host range. And as a whole, they offer that at this time, because they can develop resistance later, 95% of E. coli isolates are addressed with this. So just go through some of the aspects of this trial, because it's one of the few trials that I'm going to actually share with you that shows a clear benefit from an RCT perspective, although not a placebo-controlled RCT. You can see how 39 female adult patients were randomized at 6 private institutions, and there was IV infusion at 10 to the 9th plaque-forming units intraurethral, and this was varied depending which arm they were in, at either 10 to the 9th, 10 to the 10th, or 10 to the 11th, and they all received trimethoprim sulfamethoxazole and as an antibiotic, regardless of susceptibility testing for it, and I'll tell you how that plays out. There was no serious adverse events. There were minor events, and it was seemingly associated with higher dosages like tachycardia. There's a rapid reduction in urine counts of 4 hours after treatment and maintained. And overall, there's an 88% reduction. And then super interesting, in 9 of the 11 patients that had a TMP SMX resistant isolate, it actually showed eradication 82%. So that is exciting and provides some evidence as we look for more evidence in phase 3 trials that would have a RCT component. So there's no RCT placebo-controlled clinical trial. If you can just build off the case that we did, which we had called a clinical trial because it had to be registered, where we used 3 phages that were provided by Houston to treat Victoria Marshall. You can see more information on the poster as well as how those phages targeted. These phages are now becoming part of a company's cocktail that's a spin-off of Taylor Labs. And you can see our Taylor Labs collaborators, as well as our urology team and pharmacy teams that have been part of this. And you can listen to Victoria and share her story. And we're in the process of submitting our paper/trial for publication. I talked about this further on how we have to use all the weapons possible to move forward. And we're now looking to develop what we call PPEACs, or phage plus ertapenem or ceftriaxone kinetic synergy. We won't have all the time to go through this, but essentially we're trying to recruit 20 women and have it so that they're in the control group or in the phage therapy group. And this would be in the setting of kind of after they've just been treated, but still colonized, as a way to successfully decolonize them. Those in the control arm will still get the phage after a 6-month course of being in this study. And then the phages would be given in bladder instilled just one time, topical multiple times, oral multiple times, and we'll look for a cure at 30 days. And we submitted an application or an interest survey, and we received good interest from others across the AMI Canada network. So, but phage regulation is a mess. Guess what? Antibiotics are a mess. It's hard to get people to do things, and so phages are actually an opportunity to move around that. And you can see here in where key antibiotics that are available in other countries, only 3 out of 18 that are available in Canada. Evermore the reason why we need to be thinking of innovative strategies like phage therapy. There's also compounding versus manufacturing aspects. Now, the bacteria phage is enriched in an area where there is endotoxin present, because that's on the surface on the bacteria. So we have to try and separate that endotoxin from the phages, and how we do that. And in the future or near future, we're looking at cell-free mechanisms of replicating those phages to get the high amounts necessary to provide them without endotoxin. There are still issues of, is this a compounding process, which is more like a state or provincial regulation, or is this a manufacturing process, which is a federal regulation? And I can offer that in the near future, compounding regulations are going to be up for discussion. So there's an opportunity. Ultimately, there are challenges. Is this a biologic versus a drug versus a supplement versus a feed, if you're thinking from an animal standpoint? We are trying to investigate this further. You can see Riley Alvarez, where we're trying to survey a variety of countries on what's being done from a phage therapy perspective. We're launching a survey to clinicians who have experience with phage or are about to have experience with phage therapy, as well as a survey to regulators themselves. And I'll be speaking virtually in Brazil in November to the regulators at the international table and seeing on how we can work together in this space. Phage susceptibility, I'm almost there, is a mess. And you can see how antibiotics, just a little bit like antibiotic testing, you have slow and laborious methods, but there are now more rapid methods that are happening. To do phage screening, it's also slow and laborious, and there's no standardized criteria. So if you do it for solid media versus liquid media, when we do the testing, you get different results. There are papers on Pseudomonas aeruginosa, same lab, next day, different results. Different labs, different results. A little bit better for Staph aureus in terms of consistency amongst laboratories, but then there's also challenges time, and from a rapid high throughput technology, we're looking for those strategies. There's now a working group, which I'm part of with 25 other experts on developing what is sensitive intermediate resistance. And that's so important. So we have all these trials taking place and we don't have standardized criteria. And so we're in the process of working on that. You can see a key article that came out recently that capitalizes on this from a Canadian perspective on using freeze-dried phage or other things to make things as consistent as possible from a testing perspective. We at Unity Health Toronto are also working on a portable box to allow for droplet microfluidics or rapid susceptibility testing to test for phages and bacteria interactions much more quickly, much more rapidly, and much more consistently. So with that, you can see that we're trying to develop a personal trial on phage therapy, and it's with a group that includes our colleagues at the Université Laval, as well as those at the national laboratories and our phage therapy colleagues in Australia, as well as the Mayo Clinic. And the last point is there's no one behind this. And to say that there is Phage Canada, and as you know, there's a disclaimer, if you'd like to be a member of it, it's open to the general public. And there's actually an FAQ on how to access phages in Canada, or how we can help that process take place in other places. But we're hoping to advance not just for human health, where I'm the clinical director, but for others, for other conditions and other diseases. So you can sign up if you're interested in that. And then there's also further networks available. I didn't mention Phage Canada, but then there's the AMI Canada working groups, the Global Clinical Phage Rounds, and we have meetups every year. We received a large fund, about $5 million, which we've now distributed across Canada, at least a portion of it, and that helps pay for the professorship. And you can see that there's other groups that are happening on the international level. So if you have any questions, please, I assume there'll be a good, solid question session, but if you're unable to get your questions answered, feel free to send me a message, and then you can also provide a separate evaluation for my professorship, as you see there. And then ultimately, I want to offer where have you, and I'm very interested in Dr. Emberl and where he has changed. Are you a phage fanatic? So enemy, my enemy is my friend, and we have an AMR crisis. Or are you phage friendly? I studied phages, it makes sense, there's hope. Are you on the phage fence? Ask me later. Do you have phage fear? It's like, please show me the successful RCTs, don't phages carry toxins or resistance genes? And then are you at last phage, forget about it. So thank you for the opportunity to share what's happening in our world from a phage standpoint as we look to reduce dead-end infections.
Greg, thank you for your phage-tastic presentation. We'll turn the floor over to John Conley, who has a fascinating title, and John is no stranger to the bug day world. John's presentation is entitled SARS-CoV-2 Transmission, 1 by Air, 2 if by Hand, 1978 Revisited. John is somewhere in the world right now, but not in his home base. As a matter of background, John is a specialist in infectious diseases with a specific interest in infection prevention and control and antimicrobial stewardship. John is a distinguished professor of medicine at the University of Calgary and has held numerous leadership positions in infectious diseases, in infection prevention and control in Canada and the World Health Organization. He is also one of the founding members of the Canadian Nosocomial Infection Surveillance Program, having had the privilege to work with Dr. Lindsay Nicole, from whom we'll hear later on today. John, take it away.
Thank you very much, Dr. Emba, for that kind introduction. Are the slides showing, and is the voice okay?
Yes and yes.
Okay.
You might want to go to slide show mode.
Yes, I'm just moving over there. There we go. Thank you very much. Over the next 15 minutes, I'll try to take you through an old study that perhaps we should be looking at, and some others that are on the older side. As far as disclosures, I have a number of publicly funded grants. There was only one that was through Pfizer for a quadrivalent Staph aureus vaccine, but I received no personal remuneration. It was all to the University of Calgary, and the rest of them are listed here. And just a land acknowledgement, I'm actually presenting from Los Angeles right now at our IDSA SHE meeting, but the presentation was done in Calgary. And I just want to acknowledge the traditional territories of the peoples of Treaty 7, which is where I'm living. Just go back one. So I'm going to just try to go through the classic modes of transmission of infectious microbes, discuss the modes of transmission for SARS-CoV-2 using the hierarchy of high quality evidence, and then look at the research gaps that we might want to look at to be able to try to sort out what is the relative frequency of various modes of transmission of respiratory viruses. This is the first major pandemic when you look at COVID-19 in the age of instant social messaging. We had social media that was in total overdrive. A lot of polarization of views, often very emotional and strident views that were taken and included across the political spectrum, academics, scientists, media, no vaccinations, COVID zero for 6 months, and COVID will disappear. And it was on a number of topics. And interestingly, a best-selling book about the weaponization of social media came out just a year or two before COVID came along. And we've seen social media and political cycles that has been very weaponized as well to be able to try to push agendas. And here's just to show you the vocal extremists on the other side, the COVID zero people with the Take Action website still up. Front page newspaper articles, you're a loser if you don't follow COVID zero. On the left side, we had the CBC, a little bit left leaning, suggesting emergency powers be granted so that we can stop the wave. Then the National Post, a little bit on the right wing side, COVID zero is not going to happen in Canada. So very interesting dichotomy of opinions that were occurring during the course of the COVID-19 pandemic. Let's go back to basics and look at the classic modes of transmission of microbes. You can see that there are many descriptions, and most of you will know this from the epi literature. This is just a bridge to simplify it. You've got a reservoir and a susceptible host, and then a chain of infection. It can be a direct route from reservoir to host, or it could be indirect via an intermediate step, which is shown diagrammatically there. And if you look at the various direct routes, it's fairly simple as well when you look at direct physical contact. So think humans, animals, soil, and the activities of touching, kissing, biting, licking, sexual activity, blood and body fluids, transplanted organs, and other tissues. If you look at direct droplet, this is in close contact, humans, animals, coughing, sneezing, laughing, singing. Direct transplacental is directly through the placenta. We know there are a number of viruses, the torch syndrome, that can occur in that route. And then we've got the indirect route. And the indirect route is an interesting one to be able to look at because this is via some other intermediary. So they can be classically divided into waterborne, foodborne, airborne, vector-borne, and vehicle-borne. Vehicle-borne, some people like to use the term fomite-borne because fomites are present there as well. But and it's a broader term that can be used for food, water, fomites, which would include fecal-oral spread as well. Vectors, of course, by insects, and then airborne is over long distances. Think of dust and other things, and that can be obligate, preferential, or opportunistic. Think opportunistic when you put fans on in a room and you've got someone who's sneezing in front of the fan, it's going to carry it a much longer distance, those very large coarse droplets. And then if we look at our classic evidence to support the modes of transmission, I just put on the right-hand side of the slide to be able to show you the classic hierarchy with editorials, expert opinions at the bottom, followed by next to the bottom with mechanistic studies and case reports, and then working your way through cross-sectional case control cohort, randomized trials, which are probably the pinnacle for being able to help to drive policy and getting closer to causality. Interestingly, a quick search I did for this Bug Day talk, quickly looked at opinions and editorials. I hit 30,000. There were huge numbers of opinions and looking at transmission modes, mechanistic studies. This is physical science, in vitro studies, and math modeling. They can be useful, but there's a legacy of failures. Think of ivermectin and chloroquine, which really didn't pan out to be. And in fact, there's an increased death rate in a recent systematic review with the use of chloroquine. But in vitro, it looked like it was great. Mechanistically, it looked like this is going to work. We heard President Trump, I take chloroquine for COVID-19. Multiple randomized trials have shown the fallacy of the use of chloroquine. Recent systematic review on air purifiers, which did not provide any evidence to support that they were having any major effect, but there are many randomized trials underway, so we'll have to wait for another systematic review in the future. And the quality of the studies during COVID-19, particularly in the first year or two, were generally not high. There was a huge number that were coming out, and many of them didn't have original data. One review found over 10,000 articles by mid-2020, 81% were moderate to high risk of bias. And in one review of systematic reviews, they found that there were only 3 that on the MSTAR2 quality recording actually were of moderate to high quality. So again, one needs to look very carefully at the quality of the papers that are coming in this area. So it's important to be able to look at some general principles in and assessment transmission causality. A general principle is that a pathogen can exploit multiple modes of transmission, particularly if you have a highly susceptible population. There may be a predominant mode of transmission, and then there are those that might be of lesser importance, but there are also circumstantial and situational settings that can modify or change a mode of transmission, which is very important to look at. And think of the setting of an infant who is in a bassinet, who's premature and has a respiratory infection and a little cough, compared to a 300-pound lineman in a football league. Who's got the greater velocity to spread cough droplets? The infant or the full-grown 300-pound man? And you can see that's a very extreme example, but you can see that there are many things that need to be taken into account. And it's important because this also affects the optimal mitigation and prevention. There are many studies that have been done and guidelines to look at microbial transmission causality as a level of evidence, which I think maybe hasn't been looked at enough. Going all the way back to Koch's postulates, which most of you in this audience will be aware of, and then moving all the way forward to the Bradford Hill criteria, which was with tobacco use and smoking, where he looked at all of the 7 or 8 characteristics with temporality, seasonality, to be able to get closer to causality. Gwaltney and Henley actually did postulates for respiratory virus transmission, and then they've been reformulated with Relman's work looking at molecular work, and then whole genome sequencing in 2016 by Bird and Segre was added in, which is again a sort of more modern reflection on Koch's postulates. And then more recently, the Jefferson hierarchy framework, which brings into effect issues pertaining to human challenge studies. And this is to be able to look at a binary. If we take SARS-CoV-2, for example, binary positive, negative, a PCR. Well, we don't know if the PCR is got reflection of positive growth of virus. And then you've got a single cycle threshold that can help because there is some association with higher thresholds not being suggestive of cultivatable virus, which obviously would not be an infectious. CPE, but CPE on viral culture, very important to look at because many fungi and bacteria can do it. So you have to verify with other techniques to be able to show it is the virus in question. Serial viral culture or decreasing cycle threshold also can be very helpful. And then at the top of the pyramid, this paper was suggesting human challenge studies and going back and looking at how best that might be to reflect upon the causality of transmission events. And here's a review of some of the studies that I put together, and this will be a slide I won't get through in this time, but one can look at animal models, clinical studies, and human challenge. We'll start at the bottom. On this one, there was a human challenge study that was published in Nature, Killingly, and then a follow-up in Lancet Microbe. And that told us a lot about the dynamics, and I'll touch on it in a moment, and about the minimal infectious dose with SARS-CoV-2 and where you can find a cultivatable virus in the environment. Direct transplacental has got what I consider a human challenge with respect to a recent study which indicated the presence of an identical virus that was cultivated from a infant and the placenta, which was a complete match, and the histopathology did show that there was on the both maternal and fetal sides in the syncytial trophoblast the presence of SARS-CoV-2 on histopathology. And there was direct genome sequencing that showed an exact match between them, and the mother did not have any contact with the infant. So that's pretty powerful evidence that this virus can cross the placenta. In the clinical study setting, There was a recent direct contact, but it's somewhat of a low quality study. It's observational case control, just published last month, where it was found that hand hygiene, lack of, was the highest likelihood of healthcare workers acquiring SARS-CoV-2. We also have several studies on direct transplantation with kidney and lung transplants, where they were transplanted, found out to be SARS-CoV-2 positive after they were transplanted, and then the patients developed SARS-CoV-2. So obviously, transplant direct contact can occur with direct droplet. There was a systematic review that just 4 of the 5 studies showed that the use of eye protection was protective. And that was published 2 years ago, and we need to see more studies in that area. Then there was the British Medical Journal, neonatal outcomes. I touched on this with the positive viral cultures, with a clinical study and a human challenge in some respects. Then the BMJ systematic review on 18 studies. And this was mainly in the area of buses and hotels and quarantine facilities, a fitness center, and also the singing choirs. Only 3 of them were high quality methodologically and had whole genome sequencing. And it looked like there was some evidence in these closed settings where there may have been true airborne transmission, but there was always a mixed modes where people were congregating either before or after the choir practice, for example. And then on the vehicle-borne front, there was evidence from a recent study from a couple of years ago that we were involved with that found a vital signs card that was epidemiologically linked to where all the cases occurred in a hospital outbreak. And the cycle thresholds for SARS-CoV-2 were in the teens, which is highly suggestive that that would have been cultivatable virus. In the waterborne, foodborne area, just covering on my slide here, so I'll just try to remove that. There was a study showing viable virus from an immunocompromised host that was present, and then a meta-analysis that suggested that at meal times was highly associated. And when I take you up to above, there's some studies that are also quite interesting on the GI front. They used nasogastric and nasoduodenal instillation, bypassing the respiratory tract of SARS-CoV-2 in a non-human primate. And they all developed SARS-CoV-2 enteritis and pneumonitis, suggesting that the oral route may occasionally be a route because they're our closest on the mammalian chain. There was a study on vehicle-borne looking at fomites in scientific reports, and they found, and I'll touch on this in a moment, a number of studies showing cultivatable virus at the bedside and other areas near patients who are in the early stages of infection. And then also when they put in an animal model golden hamsters in a cage in which previously infected golden hamsters had been, 1 out of 3 of them, this is very low numbers, became infected just by walking across the cage where there had been viable virus present. In the airborne, there was ferret studies, but they were using very high volumes of air, 100 liters per minute. That was published in Nature Comms, and 4 to 4 ferrets became infected. In another study with the human ACE2 transgenic mice carrying that gene, they found it was very difficult to be able to infect the mice, but only with 10 to the 5, 10 to the 6 PFUs per milliliter that they were spraying into the air, and it took 25 minutes of exposure. And then direct droplet, similar animal studies have shown direct contact and direct droplet settings where there's been transmission, either the golden Syrian hamster or in another setting with the use of the transgenic mice. Studies in households, or studies that actually look at SARS-CoV transmission, important to look at. There was only 1 study I was able to find that looked and followed it, and that was just published in Lancet Microbe. And actually they showed that the major association was the presence of RT PCR RNA positivity on the hands prior to the upper respiratory tract in this study. And it was suggestive evidence, but again, it's an observational study, but it does suggest that hands may be very important. And just to take you back to the study that I had talked about, the human challenge studies that were done back in the 60s to 80s in the Common Cold Unit, they did human coronavirus 229E, and they did OC43, which is the closest known beta coronavirus to SARS-CoV-2. And they did show strikingly similar. They used 4 platforming units per milliliter in a very small inoculum with those early human coronavirus studies, and had above 50% attack rates when they dropped it into their noses. And in the human trial, it was 7 platforming units. It seems like nobody went back and looked at these old studies from 50 years ago to show that the minimal infectious dose was extremely small for the human coronaviruses and almost identical with SARS-CoV-2. And then just to show the human challenge experiments that were done, the fluorescent dye study that was done years ago, where somebody had a cold and then they looked at the fluorescent dye afterwards, and it was everywhere on the card table on their hands. And then the Gwaltney and Hendley studies, the famous teacup study, where 50% of people who came in and there was rhinovirus on the teacup, and then they touched their noses or their eyes, there's a 50% attack rate. So this is clear evidence of fomite transmission with rhinovirus. And similarly, hand, nose, eye contact, where they dropped rhinovirus on their fingertips and have them touch their eyes and nose. And then with rhinovirus, when they did coughing, sneezing, they found only an 8% attack rate when they put people into a room. And these are all old studies that people didn't seem to pay much attention to. And we know that there was a lot of rubbing of eyes and picking of noses that occurs. They actually studied this in a lecture theater with medical professionals, believe it or not. But these are, again, studies that people just seemingly forgot about. Here's some work that we did in looking at cultivatable virus. And we inoculated keyboard stethoscopes and call bells, and we found that the half-life was about 6 hours with cultivatable virus, and we used actual clinical specimens. And we found that nasal prongs, used tissues at the bedside, the denture cups, the phone and call bells, hands, and kiss plates were the most frequently found with viable SARS-CoV-2. Sputum and saliva also had a very high frequency of cultivatable virus. This is in a diagnostically rich sampling environment where we picked on, found individuals within the first 5 days. And I think this still remains one of the largest studies with over 500 samples and 75 patients. The human challenge study, and I won't touch this on all of this because of time, but again, 94% were symptomatic. This is individuals with no immunity, very low infectious dose with 7 plaque-forming units and 40 microliters, very tiny amount, or 100 microliters, very tiny amount, and yet a 50% attack rate. And they also did in a follow-up study, found infectious virus in small numbers, but on the insides of masks, on surfaces, over bed tables, bed frames, TV remotes, and bathroom handles. And interestingly, they only found viral load aerosol emissions in positive before symptoms in only 7%, because this had been a big debate as well. So what about hands? And I'll just finish in the next couple of minutes. There's been recent systematic reviews that have suggested hands and respiratory virus infection. There's an association. There's the WHO multi-country study that I just mentioned with an adjusted odds ratio of 2.5 as being the most prominently found feature for transmission to healthcare workers. And this is in the setting of masking, of course. And interestingly, in human autopsy samples, you can have about 9 hours of continued growth of infectious SARS-CoV-2. And we recently did a study, just published in abstract form, where we collected 35 hand specimens during the course of the pandemic. And we didn't know if they were, coughing into their hands or not, but it covered the whole lineages from the early days all the way through to Omicron. And what we found was 1/3 of these individuals carried infectious SARS-CoV-2 up to 10 to the 3rd plaque-forming units per ml. That's a whopping big load of virus on hands. And when we looked at N gene positivity, 86.7% were positive. And when we looked at those that might have had a CT value less than 29, 70% would have had infectious virus on their hands at one point. The levels are 8 to 200 times above the minimal infectious dose. And then we took these same specimens and we touched the nostrils of the human K18H2 mice, and we found 92% of them, we fished it out of their lungs at necropsy. This was done at the Li Ka-shing Virology Institute in Edmonton. And our findings were not yet published, except in abstract form, suggest a very high efficiency transmission on human hands. So then we come to the airborne. This is one of the big areas of debate, the continuum. We've all recognized fine aerosol to large droplet, and all likelihood, all of them come into play depending on the setting. And there are many research gaps yet, and in all likelihood, we see a full spectrum of modes of transmission. The relative frequency and in what settings and the dynamics all remains to be seen, and why I would advocate that we go back and look at the Gwaltney-Hendley modes of transmission, causality, and look at more human challenge studies, or if ethically it's difficult, human to K18, which mice which are transgenic and have the human ACE2 receptor, because that would be a very valuable means to be able to test multiple hypotheses on transmission in different settings. And with that, I'll close. Thanks for your attention.
Thank you very much. I'd like to now switch gears to Craig Dirksen, who is actually an engineer. Craig is going to speak to us about facilities management strategies for preventing the transmission of pathogens, lessons learned from the COVID-19 pandemic. Craig is actually in South Africa at an engineering conference, and we'll have Craig join us for the questions and answers. This will be a pre-taped presentation. Craig is the Executive Director for Shared Health's Capital and Facilities Management portfolio. Craig's career has always been in healthcare, and he is a member of several Canadian Standards Association technical subcommittees, including healthcare heating, ventilation, and air conditioning, among others. So, Craig, take it away.
Thank you for the introduction, and Dr. Emble for the invitation to speak again at Bug Day. As a matter of potential conflict, I need to declare I'm a member of several Canadian Standards Association healthcare technical subcommittees, including CSA Z317.2, which is the HVAC and healthcare subcommittee. So I must note that my viewpoints do not represent CSA or that committee. Now, after I wrote most of the presentation, I realized that I wanted to flip upside down the presentation, start at the end, and then work backwards. So here's a provocative statement for some and a lame-sounding statement to others. Routine airborne transmission of diseases can and does occur, but the likelihood in a properly ventilated healthcare setting is rare. There have been for centuries, and in the past 40, 20, 10, and certainly 4.5 years, a great deal of debate about this. A significant discussion and focus has occurred about how to manage this airborne transmission. So with that background, today's focus that Dr. Emble and I discussed was, what did we learn about engineering controls from our lived experience? Subsequent to the COVID pandemic, we've had multiple groups further discussing all transmission paths, but especially airborne. Now that's good. And today's presentation, I'm not going to endorse, deny, or refute one type of transmission or another, but I want to consider what are the engineering approaches that we must take and the ones that we have undertaken. Engineering and the medical field intersect regularly, particularly when we look at the transmission of disease, which can occur through multiple pathways or vectors, as an engineer like myself likes to say. The usual for healthcare engineers is to assess these vectors to see how can they be broken, intercepted, redirected, or at the very least, the impact lessened. The role of healthcare engineering and designers in the operational side of this is to find the most effective and efficient ways to break these vectors. Now, something that is effective would be measured in terms of, does it work 50% of the time, 85% of the time, or 100% of the time? Efficient would be measured in terms of considering the effort, the risks, the delays it may cause, and even an inconvenience to patients or healthcare providers to answer whether that associated effectiveness of the measure is worth it. So while we want to do everything in our powers to stop the spread of infection in healthcare settings and outside of healthcare settings, we need to look at the effectiveness and efficiency in our approaches. Now, we can't talk about any of this without looking at the hierarchy of control and those 5 steps used to control exposure to hazards. This begins at elimination of hazards, substitution, engineering controls, administrative controls, and PPE, ranked from the most effective to the least. So while elimination of infectious sources is desirable, we all live with the reality that we do now and will always will have infectious patients. And going ahead, we'll be seeing a higher frequency of new diseases, multi-drug resistant pathogens, and even re-emerging diseases. Now, this version of the hierarchy shows what they considered the engineering controls in infectious disease and all the other categories. Now, the benefits of an engineering control is that it moves the hazard away from others. It isolates the hazard in the workplace, whereas something like personal protection puts just a layer of protection between the hazard and the worker. Healthcare engineering and design has 3 common engineering controls that we'll talk about today. We'll talk about clean environments, physical separation or physical distancing, and airborne control. Now, clean environments really means disinfected environments. The quick point I want to make here is effectiveness of disinfection lies in the proper application and use of the disinfectant. Proper application. Don't spill bleach on poop. It's not going to work. Then there's the proper use. When your disinfection product says that it has a 5-minute wet contact time, do you realize that your staff need to keep that surface wet with disinfectant a full 5 minutes to get full disinfection? That's a nearly impossible task in any environment, let alone the dry Manitoba winters. That's why after the pandemic, it was agreed that all healthcare space cleaning in Manitoba was to move to a short wet contact time product, something less than 2 minutes. Check with your environmental services team as to the product they're using. Now on to our second engineering control, physical distancing or separation. Well, our healthcare spaces in Canada, and in particular in Manitoba, often do not provide physical separation to support infection control. While there are a few new Manitoba facilities meeting current space standards, the vast majority of our facilities predate current standards for private patient spaces and having shared spaces. The physical distancing and separation engineering control actually addresses 3 transmission paths: contact, droplet, and we'll also jump over to our final engineering control of airborne transmission. The engineering control is to create a physical separation from possible contaminated sources. How do we do that? Firstly and best, create a space. It's the most effective. But where we have spatial issues in tight multi-bedded spaces, waiting rooms, options in use are including physical barriers and curtains to prevent contact. However, those same barriers now become contaminated and we need to clean them or change the curtains between use. Now, before I lose you, yes, physical barriers will also assist in droplet transmission. So think about the dual benefits, but also the drawbacks of physical barriers. Keeping a physical barrier disinfected is required. Otherwise, it's not effective. Our second benefit of physical distancing is that it deals with droplet transmission. And normal droplet transmission from speaking, shouting, coughing, sneezing, we are known to fall out after 2 meters. These images became embedded in our minds during COVID about what happens within that 2 meters. So when we don't control that with masking, we need to have a physical distance. The third benefit of physical distancing and separation is that it can reduce the transmission of airborne. So that segues us back over to our third engineering control for airborne transmission. Now, airborne transmission is where infectious particles are small enough that they don't drop out after 2 meters, and because of their small size, usually less than 5 microns, and their weight, they can become suspended in the airstream. Now, most of what we talk about in airborne realm for transmission are viruses. Sometimes we have others like TB, bacteria. Now, viruses will usually start by being suspended in mucus or saliva. But once that moisture dries, the virus begins to die as it has no host. Not immediately, but it will die. Now, lifespans of minutes up to hours are reported. However, normal lifespans are in minutes, not into the hours. Now, temperature and humidity of the air does quicken the drying time for viruses and therefore shortens the virus's life outside of its host. Now, there's a weird part of the humidity argument that in recent studies shows that actually the humidity range between 40 to 60% is the best range to promote healthy mucus and membranes in the nose, eyes, and mouth, because our moist human membranes are more effective at fending off virus bombardment to the human respiratory immune system. If you want more on this, see Dr. Stephanie Taylor, who has lots of good information out there. Now, leaving behind those controls, we put in on aerosol generating medical procedures. Those were the specific tasks which generate additional aerosols. We've dealt with those in the ICUs with HEPA filtration on our breathing air circuit exhausts. We have handled them AGMPs in the ORs and the ICUs and patient rooms by managing our air clearance times, which is an engineering approach. We've supplemented with physical distance management and wearing higher effective PPE. It is, however, the inpatient areas where we can safely state that the private patient room has the largest effect. At most sites, we can group our patients and resident spaces into the 3 categories: shared rooms that have poor ventilation, shared rooms with ventilations that meet standards, and private rooms with ventilations that meet standard. So where did we have our outbreaks during COVID? Shared rooms, regardless of whether the ventilation was subpar or meeting standards. Where did we see few, if any, outbreaks? Where we have all private patient rooms, which also happens to have extensive hand hygiene sinks, private patient washrooms, and of course offers physical separation. So what does this say? Strongly supports that physical separation in the care environment as the biggest factor in transmission. But now back to our opening statement. Can airborne transmission occur? Sure. Direct in-room transmission where the target is exposed to a high concentration of suspended particles represents the greatest possibility. But transmission through the ventilation system, let's just do some math around this. Now let's use a typical situation, an older style 24 to 30 bed patient ward with a double loaded hallway, meaning we have patients on both sides. That usually is around 7,000 square feet. It would be ventilated for 6 air changes per hour with a total of 2 fresh air for dilution. We would usually have 2 levels of filtration, a MERV 8 filter, which is for larger particles, and the MERV 14, which works to filter out 90% of particles in the 1 to 3 micron range. And I'll note that COVID aerosol was usually around 2.5 microns. For a patient ward of this type, we would normally see a 7,000 cubic foot per minute air handling unit serving the ward. And remember, we have 1/3 of fresh air coming in to dilute it, working alongside our filtration. Now, an infected patient or a patient will normally exhale at about 0.21 cubic feet per minute. Now, if we assumed that 100% of that air was completely contaminated and assume that it all stays airborne, doesn't get stuck to anything, because it travels through twists and turns in the room, through the return air ductwork. It's spun through the return air fan at 1,100 revolutions per minute, meaning the fan tip is at 250 kilometers an hour. It then passes through a first MERV 8 filter, which theoretically doesn't capture those smallest particles. It then goes through a heating coil, a cooling coil, which have thousands of thin ribs. It then sees that MERV 14 filter, which removes 90% of the contamination. And that, after the dilution, now drops us down to 0.014 cubic feet of contaminated air out of the 7,000 cubic feet that are moving every minute. Finally, that air meets the supply air fan. The tip again is spinning at 250 kilometers an hour, makes its way back through the ductwork, through bends and turns before getting back to the occupied space. So that leaves us with a maximum of 0.0002% of the air in this patient ward that has contamination. Now, if all 24 patients were expelling contaminated air, then we'd be at 0.005% of the air contaminated. Now, this theory, this calculation didn't factor in all those surfaces where the aerosols are going to be adhered to along the way or fall out. So asking what amount of contamination will affect someone? Well, we don't know that. So would we say that a properly ventilated space like this is an effective and efficient engineering approach? Well, if we're diluting and removing contamination by 99.9998%, not quite a 6 log reduction, but it's a 5 log reduction achieved through dilution and reduction in contaminants. So for a viral load, that's considered disinfection. Yes, it's effective and very efficient. But another example would be an infected person is a resident in a, say, long-term care home, sharing their 300 square foot room with another occupant. And there's little air exchange, sometimes 25 cubic feet per minute, exhausting out of the bathroom fan only. Well, this changes that percentage significantly. Now we're looking at nearly 1% of the room air is considered contaminant. That's a huge step up, over 4,000 times greater concentration. And by the way, we observed this in our evaluation of Manitoba's personal care. So summarizing what I'm trying to say about engineering controls. First, please, let's not forget about surface disinfection. Until we get to self-disinfecting surfaces that work, let's use the most reliable, effective engineering disinfection solution with a short, wet contact time. Secondly, physical separation. We see that physical separation is a key factor we need to focus on. Achieving private patient and resident rooms is key to ensuring that the healthcare associated infections from contact and from airborne standpoint will be greatly reduced. And with airborne control, let's ensure that our ventilation systems which are in place are maintained and working properly. Let's focus on our shared environments and those which have a substandard airflows to ensure that what we have is working as effectively as it can to achieve the most effective air change and dilution that we can. Shared patient and resident spaces are an Achilles heel to contact, droplet, and airborne contamination. We can engineer that out. Let's work together to promote getting private enclosed healthcare spaces for all, and let's properly maintain the systems that we have. Thank you.
Thank you very much. So Craig Dirksen is actually joining us from South Africa. He's on for the questions and answers. Our 3 speakers are still on. Some great questions. And I'd like to say we've actually run out of time, so we don't actually have that 15-minute cushion for a break. So I'm going to suggest that those who want to take a break, please take a break. And those who are diehards want to hear the questions and answers, stay for the questions and answers. I personally have a question for Greg German about phages. What is the cost, and can we bring phage therapy into mainstream for the management of complex urinary tract infections and implanted orthopedic implants in terms of cost and timeliness?
I think to hear the last part of that, but to address the costs in general, you know, rather than 10 years of work and $2 billion US to get a new antibiotic, it's somewhere on the order of $50,000 to have a good laboratory manufacturing practice, which is like compound level quality for phages. If we can have it so that the phages are given non-intravenously, whether it be oral, bladder, instilled, or topical at the vaginal opening, then the costs can come down even further. So, you know, what we're trying to do is obviously right size it and address the cost, but it's still making it a personalized, slash precision medicine. another thing that's worth sharing is how do we get insurance companies to start paying for it? Because that will also address the cost. In some ways, the cost is free because there's academic or clinical trial arms, but not readily available. We looked for more information on called the European Pharmacopoeia, because then that would also assist in us being able to charge for the phage or phage services. And there's other models or ways of trying to make this happen in the future.
So I'm going to switch gears slightly. I have a question for both Dr. Conley and Craig Dirksen, and it's the same question. I'm just curious how the two presenters would answer this. Knowing that coronaviruses are crafty devils and that they'll likely be around for a long time to come, what should we be doing looking into the future to prepare ourselves for the next pandemic? Because I suspect that if it doesn't happen this year, next year, the year after, it may be off on the horizon somewhere. So, Craig, what are your thoughts?
Well, I mean, we need to continue, and I said this at the end, we need to continue to push forward for better patient spaces, private and the like, but those are 10 years off. The cycle of buildings is around 10 years from a government committing to a building to the delivery of that building. What we need to focus on is what we have now, and if we're dealing with, and I heard Dr. Connolly talking about hand washing as a primary vector, that needs to be managed. We need to manage what we can in the disinfection of the environment, and then to my facility management peers, we need to maintain what we have. A lot of the challenges that I see across Manitoba experience, and quite frankly, in talking to my peers across Canada and now even internationally, we let things go. And why have we let them go? Well, we say we don't have enough maintenance budget. Well, if you have it, you need to maintain it. And so that's the challenge I put out to all of us, is to maintain those systems so that we maintain those surfaces so that they aren't harboring bacteria, and so that we're maintaining our ventilation systems properly to aid in the control of airborne movement, potential airborne movement of virus, but also just comfort for our patients.
So, John Conley, knowing that we're 10 years away from optimal healthcare facilities, and sadly in Manitoba, I suspect that we're more than 10 years away from optimal healthcare facilities, what are your thoughts, and what prophetic words do you have as we prepare for the next coronavirus pandemic?
Well, maybe an influenza pandemic. You're probably aware there's some circulation of H5N1 occurring now with, I think, between 10 and 20 cases in the US. So it may be one of the avian influenzas, we don't know. But there will likely be another. I think the key is to look at implementation and adherence. That's always the issue. Despite the fact that we think everyone does hand washing, cleans their surfaces, we've got good ventilation, there are things that just aren't necessarily occurring, human behavior being what it is. So I think looking at human factors and implementation approaches to be able to enhance the measures that we have at hand is probably going to be a key measure as we move forward. Ultimately, there may be other engineering solutions. People are looking, there's now a methylene blue emitting mask that releases oxygen radicals under even fluorescent lighting. There are impregnated curtains to self-disinfect. So there may be engineering solutions that will come about. But again, with human behavior, I think the key is really the implementation and the focus on adherence and how we can implement the measures that we already have to a higher degree.
Oh,
Absolutely.
I'm going to be about like 30 seconds.
So the next question for John Conley is a great question, and of course controversial. And the question is, Dr. Conley, can you comment on the politicization of COVID and its impact and implementation of evidence-based guidance, both positive and negative?
Yes, I can comment. I think that we have seen the politicization of COVID, but at the end of the day, I think having really strong evidence, I thought I'd emphasize that during my presentation. I'm sorry if it didn't come across, but I think in all settings, to be able to focus on the highest possible quality studies and the best evidence that we can possibly generate, be it from randomized controlled trials all the way down to human challenge studies, or what the WHO and others are talking about is human to animal challenge studies because of the ethical issues. We do have transgenic mice that have the ACE2 receptor, and there are a number of people around the world talking about doing transmission studies in that setting, and then what are the optimal mitigation modes to be able to interrupt that transmission. So I think just striving for the highest possible quality evidence would be the route to be able to go.
Thank you. Greg German, another great question. Given the concerns about the mRNA vaccine for COVID-19, what do you think public perception would be about introducing phages as part of routine care?
There's definitely an image issue with phages because you see where they're collected from, runoff from hospitals and from other ponds and whatnot. Ultimately, these are highly purified, significantly screened to make sure that they don't have any deleterious or troublesome elements. It's about science in general and modifying things. What we're dealing with is a wall of dead-end infections and a wall of resistance on those reports from physicians. So a little bit like fecal microbiota transplant, where we're like, well, I don't want to put that in me. People who are suffering with C. diff, they're saying, put that in me. So I do think we'll see that occurring as well from a phage therapy perspective. And these are nanotechnology. We're seeing more precision medicine. And so I do think as a whole, we'll be talking about this at the dinner table and actually not, what's the right way of saying it, feeling sick about it.
Thank you. So, Craig Dirksen, a question for you. Yesterday in Clinical Infectious Diseases, there was an article published that ultraviolet light may not be all that it's cracked up to be for environmental surface decontamination. Can you comment on the concept of environmental surface decontamination, particularly as it pertained to our 18 to 24 months of the COVID-19 pandemic?
Yeah. Well, certainly that, I saw that article, John, as you forwarded it to me, and I've been having some conversations these last couple of days down here in Cape Town with a few others. We always need to remember we need to clean and then disinfect. We need to remove that solid material, and then we need to lead to a disinfection. We know that that physical action and that wetting action does it. Do the supplemental systems like ultraviolet, do the supplemental systems like copper impregnated handrails on beds and copper impregnated curtains, as Dr. Connolly referred to, are they effective? They are highly efficient, because if I can spray a handrail on a patient bed with a nano copper particle, that's highly efficient in that I can cover all that surface and it's working all the time. But is it effective at reducing that and killing those pathogens before those pathogens get to the patient? That is where something like the UV study is saying, and John, we've said this, UV works. It works to kill the pathogens that it sees, but we're not sure that it's seeing all the pathogens, or that what it's killing off is actually the cause of our hospital-acquired infections. So it's good to see these studies continue to come out, because it needs to inform where we're putting our dollar value, because engineering solutions cost money. Over ventilating a space or buying higher quality air filters, that costs a lot of money. Is it actually improving something? And the same back to the disinfection, our UV lights that we've rolled out. Well, they are costly to buy and they are costly to maintain. If they're not giving us a reduction in hospital-acquired infections, then we need to stop promulgating the use of these. And so, but we have to jump in and try something and then get these good research studies and get high quality studies that will support this.
Thank you. Now, the last questions for John Connolly superficially appears to be very simple. Should we continue masking in healthcare facilities? And I think what the person asking the question was, should we continue with the mandatory masking that we did during the pandemic? I can tell you in Manitoba, we have struggled with this question. I'm just curious, John, your thoughts?
Yeah, I think we need to have higher quality evidence. There was a study that was just published last month from the in the Journal of Hospital Infection, the St. George experience, with a more immunized population and Omicron in the enhanced hospital masking, hallways, cafeteria, and it showed there was no difference, and they did this as an interrupted time series. It's not a randomized controlled trial, but it is something we've talked about. We are conducting our own study in Alberta. Unfortunately, it's not going to be at the level of a cluster randomized trial, which I think would be ideal. But I think very high quality observational studies, prospective cohort, which can be done, or a very large multi-center cluster randomized trial might give us the definitive answer on that regard. And I think we need to just see how the evidence plays out. In Alberta, there was no mandatory masking. Every institution was allowed to make its own decisions. Most of Southern Alberta did not do enhanced masking last year, and parts in Northern Alberta did. So we're going to analyze that. There's a study underway which has been funded to be able to look at that, to get some in-house experience in Alberta, but then additionally prospective studies. And I suspect the St. George's study, it's observational, and obviously you will have some bias in it, but as more and more studies come out, perhaps a systematic review can help to address that question as we move forward in the current climate that we have. And hopefully that evidence will provide us with the answers that we're looking for.
Thank you very much to all three speakers. We'll now shift gears, and I'd like to introduce Dr. Lindsay Nicole and Cassandra Lieback. Now, I think this is this is a monumental event. Lindsay is a specialist in infectious diseases with specific interest in infection prevention and control. Lindsay was one of the founding members of the Canadian Nosocomial Infection Surveillance Program and is now the chair of the Human Research Ethics Committee for the Faculty of Medicine at the University of Manitoba. And Cassandra is an epidemiologist with the Canadian Nosocomial Infection Surveillance Program, CNISP, where she leads projects focused on healthcare-associated infections and antimicrobial resistance. And the presentation is entitled Canadian Nosocomial Infection Surveillance Program, CNISP, Canada's Infection Surveillance Program celebrates 30 years. So it's a little older than Bug Day, but not by much. So Lindsay, please.
Okay, thank you very much, John. I'm really here just to help celebrate the 30 years since CNISP started. Somewhat over 30 years ago, the small group of individuals who are dedicated to infection control in Canada were endlessly frustrated by the tremendous information that the NISP program in the States was constantly making available, and often complained about it when we got together. And Shirley Payton was then at what was then also LCDC, and she had phoned me up for one day to say that she had been able to identify a little bit of money to be able to perhaps do some surveillance, and could I assist by helping get together a group of interested people who might be willing to sit down and talk about it. Now, there weren't that many people who really were committed to infection control in Canada at that time, certainly not the ones trained from the internal medicine or pediatrics viewpoint. But a group of us got together with Shirley, and that included John Connolly, who's here, myself, also Lynn Johnson, who was out in Halifax, and Jeff Taylor from Edmonton. And we got together at a meeting in the United States, an infectious diseases meeting in the States that we were all at. And I can't remember whether it was New Orleans or Chicago, maybe John can remember, and discussed where we should go with this little bit of funding that was available. ultimately decided on some initial MRSA surveillance. And that was a time, which many of you will not remember, when MRSA was really just beginning to emerge. The interesting thing and very gratifying thing.
Okay, maybe I'll just get started on the presentation. My apologies for John and Lindsay for the audio issues that we've had. However, I think I'll just proceed. Thank you, Dr. Lindsay Nicole, for providing that brief summary that we heard. It's an absolute privilege to be here, and as we celebrate this remarkable milestone of 30 years of surveillance with the Canadian Nosocomial Surveillance System or Program, or CNISP. So over the past 3 decades, CNISP has played a pivotal role in shaping our understanding of healthcare-associated infections and antimicrobial resistance in Canada. So today I'm here to share a high-level summary of this program. So the objectives of this session are to describe the CNISP program, understand the objectives of CNISP, and we're also going to talk about the future plans that CNISP has to monitor HAIs, or healthcare-associated infections, AROs, or antimicrobial resistant organisms, VRIs, or viral respiratory infections, and AMU, which is antimicrobial use, and I will use these abbreviations throughout the presentation. So on that note, CNISP is a hospital-based surveillance system. So the CNISP network that's shown here is a collaboration between the Public Health Agency of Canada, the National Microbiology Laboratory, or the NML, and the Association of Medical Microbiology and Infectious Disease Canada, or AMI Canada, as well as Sentinel hospitals across our country. It was first established in 1994 with 18 hospitals and began surveillance, as Dr. Lindsay Nicole mentioned, on MRSA in 1995. So the CNISP objectives are to provide national and regional trends on selected HAIs and AROs, and these data are used to help inform programs and policies that are related to antimicrobial stewardship, antimicrobial resistance, and infection prevention and control. So if we look at the CNISP, at CNISP representativeness, we started from 18 hospitals at its inception, but CNISP has since grown to a total of 106 hospitals that participate in surveillance today. So the network is geographically diverse and consists of rural, northern, community, and urban hospitals across all provinces and 1 territory. So as you can see on the map on the left, it shows the proportion of acute care beds represented in each province and territory. And although CNISP hospitals only make up 30% of acute care beds in Canada, we do have data on community-associated ARO cases by forward sortation areas, or FSAs. And these indicate that these hospitals capture patients from over 70% of all FSAs. So this suggests that CNISP hospitals are involved in surveillance across a wide geographic area. So since 1995, CNISP has also expanded in scope. So we conduct surveillance on 15 different active surveillance projects that are listed and shown here. And we also have 2 new initiatives in place. In addition, we have periodic point prevalence surveys on HAIs, including AROs and AMU. And these are also separate ongoing projects. So I would just like to note that CNISP has a number of surveillance strengths that enhance our data collection and analysis efforts, and the most notable items are listed here. However, it's also important to recognize some of the weaknesses that can impact the effectiveness of our surveillance program. These gaps are things we have identified and are working to improve. So CNISP monitors trends in national infection rates. So we collect data on the selected AROs listed here. And we also collect the following infection types: healthcare-associated, community-associated, and infections with unknown sources of acquisition. And on the right, you'll just see an example of the type of data that we would produce. So here you're looking at the incidence rates per 10,000 patient days for CDI, MRSA, VRE and CPE infections over the last 10 years. So CNISP also monitors trends in infection rates for device-related infections. So we collect surveillance data for several different device and procedure-related infections. These include central line-associated bloodstream infections, or CLABSIs, cerebral spinal fluid shunt surgical site infections, or SSIs, hip and knee SSIs, and pediatric cardiac SSIs. And also not shown on this figure is a new project that we initiated to collect data on adult cardiac SSIs. So CNISP also monitors trends of organism strain types and antimicrobial resistance. So the molecular characterization of the select arrows is done by the NML, and they support this research that's focused on understanding the molecular mechanisms that drive the epidemic behavior of resistant strains. And there will be more information provided on this in the next presentation by Dr. George Golding. And an example of the data that we would typically show for these arrows is shown on the right. So the proportion of CDI ribotypes over the last 10 years is shown here as an example. So CNISP monitors as well the antimicrobial use, or AMU. So prior to CNISP AMU surveillance, there was limited national AMU data in Canadian hospitals. And since antimicrobial stewardship is an important component of infection control and patient safety, it was important to address the surveillance gap. So in 2009, CNISP began collecting AMU data directly from CNISP hospital pharmacies. And as you can see in these figures, these data are analyzed using defined daily doses or days of therapy for pediatric patients, as per the WHO guidelines, and this allows for comparisons within Canada and internationally. As well, we can link this information with resistance data. So CNISP can track trends and provides valuable insight to healthcare workers and policymakers in order to support better antibiotic use and combat resistance. CNISP monitors viral respiratory infections. So prior to the start of the COVID-19 pandemic, CNISP recognized the need to monitor VRIs due to their serious impact on vulnerable populations, such as children and older adults with existing comorbidities. And the emergence of new viruses only highlighted the importance of having more real-time data. So in 2020, CNISP adapted the VRI surveillance to include healthcare-associated and community-associated COVID-19. So the VRI surveillance helps us to understand the burden of these infections, guide prevention practices, and make timely public health decisions. And as you can see in the figure here, it shows more recent trends over time for COVID-19 on the left and influenza A, influenza B, and RSV on the right. Data is reported bi-weekly from 78 acute care hospitals in 10 provinces and 1 territory that participate in the CNISP weekly VRI surveillance. And this data is updated bi-weekly and available on our InfoBase page that I'll describe in a moment. CNISP also has the capacity to monitor emerging threats. For example, Candida auris is an emerging multi-drug resistant pathogen, and it's listed as a critical priority by the WHO. And this surveillance began in 2017 at the NML. So all C. auris isolates were sent for whole genome sequencing. And then in 2019, CNISP began surveillance for hospitalized patients. And more details will be provided on this surveillance project in one of the next presentations by my colleague, Erin McGill. Next, I would like to discuss some of the new initiatives that CNISP has in place. And the first one is the long-term care initiative. So as we may have heard in some of the previous presentations, residents of long-term care homes are at higher risk for HAIs and AROs. And despite having over 2,000 publicly funded long-term care homes in Canada, and with about half of them privately owned, there's still a lack of comprehensive national surveillance in these settings. So in 2023, CNISP conducted a cross-sectional survey with the aim to better understand HIA, AROs, and AMU surveillance activities among Canadian long-term care homes. And then some of the results are shown here. Following this, a scoping review was launched in 2024, and CNIS developed a proposal for a pilot project and developed a surveillance protocol, and this work is ongoing. And as mentioned previously, CNIS conducts periodic point prevalence surveys on HAIs, including AROs and AMU. And these surveys measure how common a particular characteristic, such as infection or illness or risk factors, are during a particular point in time. So 3-point prevalence surveys were conducted in 2002, 2009, and 2017. However, the most recent one was done this year in 2024. And the results of these point prevalence surveys are used to benchmark HAI, AROs, and AME rates. They also measure changes in prevalence over time. They provide information to infection prevention and control and antimicrobial stewardship programs. They are a source to identify new targets for surveillance, and they raise awareness for the burden of HAIs and AROs in Canada. The last new initiative we will discuss is the Simplified Dataset, or the SDS. So the SDS aims to capture and report on aggregate level AMR data from hospitals outside of the CNIS network. So this initiative was launched in 2022 and targeted hospitals that are not participating in CNIS patient level HAI and ARO surveillance. It's based on voluntary participation from hospitals across Canada. It allows for HAI and ARO surveillance to be more accessible and feasible for sites that may not have the resources to conduct active surveillance. And to date, this project has recruited a total of 106 sites. And with these additional sites, CNIS has been able to extend its coverage from 37% to 43% of acute care beds in Canada in 2023. And I just wanted to note that CNIS data is openly accessible through Infobase. So here you can see a QR code and a link to the Infobase website and an example on the right of how this information looks, if you would like to investigate for more information. Additionally, CNIS produces a number of publications, and these are used as benchmarks by hospitals in Canada and internationally. So since 1995, in collaboration with the NML and our stakeholders from participating hospitals, CNIS has produced over 260 publications, and these include peer review articles, reports, and conference abstracts. And as you can see on the left, there is an example of our annual reports that we summarize trends in HAIs and AMR in Canada, in the Canada Communicable Disease Report, and on the Government of Canada website. And as well, we have a list of the most recent CNIS publications here provided on the right. So in summary, CNIS is a collaboration between FAC, and including the NMO, AMI Canada, and Sentinel hospitals across Canada. It conducts surveillance of HAIs, AROs, and AMU on the number of projects provided here. It combines demographic and clinical data from patient charts with molecular and microbiological lab data. It monitors emerging threats like Candida auris, and it leads in new initiatives within the network to improve surveillance. And with that, I would like to give a big thanks to everyone who participates in CNIS surveillance, infection control professionals, pharmacists, epidemiologists, physicians, and medical microbiologists at our reporting hospitals, the FAC CNIS team, and the NML team. And if you would like more information, our email is provided here.
Thank you, Cassandra. I'm going to turn things over to George Golding. George is a research scientist at the National Microbiology Laboratory, where he is head of antimicrobial resistance and hospital infections unit, and an adjunct professor at the University of Manitoba in the Department of Medical Microbiology and Infectious Diseases. So George is going to springboard from Cassandra's presentation and give us an overview of the Canadian Nosocomial Infection Surveillance Program, State of the Nation. George.
Great, thank you. I'm just getting my screen set up here. Bear with me. We got a full screen on for everybody. That's good. Okay, great. So good morning, everyone. Today I'm here to sort of thank you for the introduction and invitation to present to you today. We just heard a great introduction into the CNIS program, and for this presentation, I'd like to focus on some of the surveillance results. So this would include the rates, the evolving epidemiology, and antimicrobial resistance of select AMR pathogens in CNIS hospitals. And we'll end this sort of little segment with how the implementation of whole genome sequencing can greatly understand our evolution and transmission of these AMR pathogens across Canada, and also how whole genome sequencing could potentially assist in infection prevention and control, especially during outbreak investigations. So this timeline infographic was presented just in the last presentation there, but just wanted to highlight the projects that I'll be focusing on. So this includes MRSA, which is CNIS's longest standing surveillance initiative, and this dates all the way back to 1995. We'll take a look at VRE, CDI, and CPOs. And I think that the greatest takeaway from this figure is the ability of the CNIS program to quickly adapt and respond to emerging public health threats as they arise. So from the figure, we can see, the response to the C. diff/SIL outbreaks in the early 2000s, the emergence of CPOs in 2000, COVID-19, and most recently, the establishment of a national surveillance program for the newly emergent fungal pathogen Candida auris, and that'll be the focus of our next presentation. So CNIS surveillance data focuses on benchmarking rates, which is tied in together with patient epi information. So to begin, this figure will highlight the rates per 10,000 patient days of the carbapenemase producing organisms, C. diff/SIL, and bloodstream infections for VRE and MRSA from 2015 to 2023. So overall, C. diff/SIL has the highest rates of infection compared amongst the other three. But it's the one good news story of today, as the rates have been declining between 2015 and 23. VRE bloodstream infection rates in adult facilities have tripled from 0.16 to 0.48 cases per 10,000 patient days. And the MRSA bloodstream infection rates have increased 30%. And this is really being driven by a continued increase in community-associated MRSA cases. So while overall rates are low, the rates of CPO infections continue to steadily increase. So what was once mostly travel-related cases, the majority of CPOs are now acquired domestically, with 68% acquired in a healthcare facility in Canada. So in addition to rates, we also look at the molecular typing of select isolates. For VRE and MRSA, we collect and type all bloodstream infection isolates, and we have traditionally performed multi-locus sequence typing for VRE and spot typing for MRSA. For both VRE and MRSA, we see a continual ebb and flow of epidemic types over time. So in regards to the VRE isolates, we can see that in the past 5 years, then multiple shifts in the predominant types, beginning with sequence type 1478, and that's shown in the yellow bars, which was the predominant strain in 2019. This was replaced by sequence type 19, which is shown in the blue bars, which has peaked in 2021. And finally, sequence type 80, which are shown in the red bars, which has been emerging and is now the predominant strain type in 2023. For MRSA, the once predominant healthcare-associated MRSA epidemic type, CMRSA2, and that's shown as the yellow line, has been replaced by a community-associated MRSA epidemic type strain, CMRSA10, just shown in the orange. And as CMRSA10 now spreads within hospitals, the line between community-associated and healthcare-associated strains have definitely blurred. So in addition to molecular typing, we also perform susceptibility testing on all CNIS isolates. And as with many AMR pathogens, there are particular epidemic types of isolates that can drive the overall antimicrobial resistance. In this example, we take a look at the differences in AMR amongst the three predominant VRE strain types. And as you can see, obviously the rise and fall of certain epidemic types over time can have a significant effect on the overall resistant antibiograms that can be produced at a local or provincial level on a year-to-year basis. Another top priority pathogen under CNIS surveillance is C. difficile. So this program was established in response to the Quebec outbreaks in the early 2000s. In response, CNIS established an active surveillance program for C. difficile. And what was found was that there was a fluoroquinolone-resistant hypervirulent strain that surfaced in Quebec hospitals and killed around 2,000 people during this outbreak. And it was this NAP1 strain from Quebec that rapidly spread throughout North America and globally. So from 2015 to 2022, CNIS hospitals have documented nearly 31,000 patients admitted with CDI. So even 2 decades past the original outbreaks, C. difficile remains a significant burden on our healthcare system. Keeping with C. difficile, I'd just like to highlight an example of integrating the molecular typing, AMU, and AMR to highlight the potential importance of antimicrobial stewardship. So in the 2000s, fluoroquinolones were widely used to treat everything from urinary to respiratory tract infections and become one of the most common antibiotic given in many countries around the world. So this in turn likely gave rise to the fluoroquinolone-resistant hypervirulent NAP1 strain. And so what we have on the figure at the left, it actually shows a rapid decrease of this NAP1 strain across CNIS hospitals. So the strain once represented 45% of all isolates in 2009, and it's now down to less than 5% of all isolates tested in 2023. When we compare this fluoroquinolone usage in CNIS hospitals, and that's shown here in the middle figure, we see a concordant decrease. And this decrease in usage not only likely had a role in driving down the number of fluoroquinolone-resistant NAP1 isolates, but when we look even at the proportion of NAP1 isolates resistant to fluoroquinolones, which is shown in the far right figure, we see also a huge decrease. So from the original outbreaks in Quebec in 2015, the proportion of NAP1 isolates resistance to fluoroquinolones was well over 90%, which in 2022 fell below 10%. So similar findings are found in many other countries where the prevalence of the NAP1 is continuing to decrease along with decreasing fluoroquinolone usage. And last but certainly not least is the CNIS surveillance of our carbapenemase producing organisms. So this was established in 2010 following some of the first Canadian reports of resistance to this last line treatment option for many serious bacterial infections. So in CNIS hospitals, the top 3 carbapenemases were KPC, NDM, and OXA48. And these carbapenemases are found in a plethora of different bacteria, with the majority being identified in E. coli, Klebsiella, Enterobacter, and Citrobacter. If we break down the distribution of these top 3 carbapenemases amongst just E. coli and Kleb, we see once again a high diversity of strain types, a number of which are actually high-risk clones on a global scale. Many of these clones are actually found to contain different carbapenemases. So while clonal expansion is one mechanism for the dissemination of these AMR pathogens across Canada and globally, the importance of horizontal gene transfer is of ultimate significance, especially since the majority of these carbapenemases are encoded within these promiscuous plasmids. So in this figure, we see obviously the huge implications that CPOs have on infection prevention and control. This is just an example of an outbreak investigation involving multiple plasmids and bacteria harboring carbapenemases. And obviously this is that huge challenge that these plasmids represent. And so this is really why we've shifted a lot of our molecular typing to whole genome sequencing. This would be both for pathogen and in certain scenarios, plasmids as well for different outbreak investigations. So we've transitioned to whole genome sequencing for our CNIS surveillance for all our organisms now. So to date, we've sequenced nearly 13,000 isolates, and this data is being used for various downstream applications. The one thing we sort of first were looking at is to look at new typing methods by newer methods such as core genome MLST and phylogenetic analysis. So going down to just a single nucleotide variant. So at a whole genome level, really narrowing in. Whole genome sequencing provides, insight also into other things we never had data on before, including heavy metal resistance, disinfectant tolerances, replaces a lot of our old traditional typing methods, which were time consuming and laborious in the lab, and provides additional data on some of these virulence and fitness factors, which can contribute to the success and dissemination of some of these emerging AMR pathogens across Canada. So in essence, going back to that question, what's driving that ebb and flow of different epidemic types across Canada? So for those not familiar with molecular typing, basically you can think of these as looking through a different camera lens, where we have multi-locus sequence type is your basic camera lens. So we're looking at just 7 gene differences. Going down to a core genome MLST, where for the case of VRE, we're looking at over 1,400 different loci. And then finally, the most discriminatory would be our SNVL analysis, where we're looking at single nucleotide variants amongst an entire genome. So here we look at the distribution of VRE bloodstream infections using multi-locus sequence typing. It highlights the proportion of the different strain types, but just MLST lacks that discriminatory power to look at transmission and potential outbreaks. So if we wanted to look more closely at a specific sequence type, we can use a more discriminatory method like core genome MLST to drill down even further. So for this, we can focus on the most recent emerging strain type of VRE, which was sequence type 80. So this was found to contain 50 isolates, and we just take a look at just one of the provinces. And that's highlighted here in the large pink circle. So we'll take a look a little bit closer at this sequence type. So here's a minimum spanning tree of all 50 of those sequence type 80s from the previous slide. Based on core genome MLST. Reminder that we're going from 7 alleles to 1,453 different alleles. And each core complex type is represented by a different colored circle. So on the top left, we have a clonal type 2933. And this really adds a lot of additional discriminatory power, which would be enough to deduce relatedness, particularly in a surveillance situation. But we can even drill down further now into this clonal type 2933 using SNV analysis. And this would really give us an idea of that true genetic relatedness that we wanted to look for in transmission or outbreak situations. So those are here's the same 13 isolates from the sequence type 80 2933 cluster. Overall SNV range from 0 to 163 nucleotide differences. And so this really highlights that genetic relatedness, which can now guide us to look for more of those epi-lab linkages and outbreak investigations. Obviously, one of the major challenges we have right now at this level is determining what a SNV cutoff would be for each particular AMR pathogen we're investigating. And it's something that we're continually looking into. And in closing, I'm going to leave you with what's commonly known as the AMR confusogram. What I presented today is obviously just a small section of the human component, but to truly understand AMR, we need to look at it under a One Health lens. And this is where contributions from the agri-food sectors and the environment all play a significant role. So through the Genomics Research and Development Initiative, we're currently leveraging the CNIS sequencing data of human clinical AMR pathogens and examining linkages with environmental and agri-food sectors with the ultimate goal of identifying possible novel sources and mitigation strategies through risk assessments and the protection ultimately for both human and animal health. And thank everyone for listening in. Obviously, same acknowledgements that Cassandra gave, but to all our IPC and participating hospitals within CNISP, the FACT team at the NML, and the FACT team over in Ottawa that provide the epidemiological support. So thank you, everybody.
George, thank you very much. I'd like to turn things over to Erin McGill. Erin is an epidemiologist with the Canadian Nosocomial Infection Surveillance Program, also known as CNISP, at the Public Health Agency of Canada. She leads projects focused on viral respiratory infections, carbapenemase producing organisms, Candida auris, and hospital characteristics. Erin's presentation is entitled Canadian Nosocomial Infection Surveillance Program, CNISP, Candida auris in Canada, 2012 to 2023. This will be a very interesting presentation because this microorganism appeared out of the blue and appears to be making its presence known. Erin, floor is yours.
Erin, we cannot hear you. No, it's still not.
Nope, still can't hear you. Are you muted? Sorry, no audio.
Okay, I have tested.
There you go.
Oh, it's working?
Perfect.
Yes. Okay, perfect. Yeah. Okay. I was like, I've been through all the different audio settings on my computer. So, all right then. So everyone can see my screen okay?
We cannot see your screen yet. Have you
Okay.
shared it? Yeah.
Are you able to see it now?
Yes.
Okay, perfect. Okay. All right. Sorry, everyone, for the technical difficulties. My apologies for that, but thank you for bearing with me. So I'm just going to be discussing the Candida auris surveillance in Canada. So Candida auris has been recognized as a top priority threat by many organizations. On the World Health Organization list of fungal priority pathogens, C. auris is in the critical priority group, which is the highest level of concern. And on the United States CDC list of AMR threats, C. auris is in the urgent threats group, which again is of the highest level of concern. The United States has continued to see an increase in cases since 2016. They experienced over 2,000 clinical cases and over 5,000 screening cases in 2022 alone. The map on the right-hand side shows the number of clinical cases in each state in 2022. There were 6 states that experienced between 101 to 500 clinical cases, represented by the dark orange. These were California, Nevada, Texas, Illinois, New York, and Florida. 17 states identified their first C. auris case during 2019 to 2021. And echinocandin resistance tripled in 2021 compared to 2019 and 2020. Concerningly, isolates of pan-resistant C. auris, which are resistant to all 3 classes of antifungal drugs, have also been reported in the USA since 2019. In the United States, about 90% of C. auris isolates have been resistant to fluconazole, about 30% have been resistant to amphotericin B, and less than 2% have been resistant to echinocandins. These proportions may include multiple isolates for the same patient and may change as more isolates are tested. Regarding C. auris in Canada, we have two different streams of surveillance. So the first started in 2017 with the National Microbiology Laboratory, who established surveillance with the help of the provincial and territorial laboratories, who forward all C. auris isolates that they receive to the NML for whole genome sequencing. These isolates come with limited and optional metadata, such as travel. There is also the enhanced version of surveillance through the Canadian Nosocomial Infection Surveillance Program, which started in 2019. And this is a sentinel network of hospitals who are participating in CNIST. And these cases reported through this surveillance program have a detailed patient questionnaire containing information about demographics, risk factors, acquisition sources, and 30-day outcome. And just to kind of plug here that we're kindly requesting that you forward all C. auris isolates to the NML for whole genome sequencing via your provincial territorial laboratory. And the NML will provide a report to the PT lab for each whole genome sequencing submission. This is the epi curve of C. auris cases in Canada. So as you can see here, the number of cases in Canada is still low, but we have a window of opportunity now to prepare for potential emergence. As previously mentioned on the slide, a C. auris surveillance was established in 2017 through the NML and the provincial public labs that are part of the Canadian Public Health Laboratory Network, or CPHLN. All 10 provinces will submit isolates of C. auris to the NML. And then, as mentioned previously, a subset of these isolates are from healthcare facilities that are participating in CNIST, and those cases will come with enhanced patient data. So far in Canada, 53 cases have been reported to the Public Health Agency between 2012 and 2023. Most cases that have been reported have been from the central region, which you can see in purple, which would be from Ontario and Quebec, followed by the West, which is kind of that yellow-orange color, which would include BC, Alberta, Saskatchewan, and Manitoba. You can see that the first case was detected in 2012, and then the first multi-drug resistant case was detected in 2017. Currently, we don't have any pan resistance in Canada, only multi-drug resistant cases. No cases have been resistant to echinocandins yet. Cases, as you can see, were lower during the pandemic years, such as in 2020 and 2021, but increased in 2022. So we had 12 cases in 2022 and 10 cases in 2023, and not shown on this figure because it's an incomplete surveillance year, but there have been 8 cases reported for 2024 so far. We have travel information on 17 cases. And of these 17 cases, 5 reported healthcare or migration from India, shown in pink. 4 patients reported no travel, reported in gray. And then 5 reported healthcare in the United States, shown in that kind of navy blue. What is striking to us is that receipt of healthcare in the United States emerged as a potential risk factor in 2022, and these patients reported receiving healthcare in the sunny destinations of Florida and Nevada. Another reason for concern for C. auris is high rates of antifungal resistance. So there are 4 genetic clades or strain types of C. auris that have been detected in Canada so far. Antifungal resistance was associated with clades 1 and clades 3. So 33% of Canadian isolates were multi-drug resistant, or MDR, shown in blue. MDR is defined as resistance to 2 out of the 3 major antifungal classes. And in Canada, the multi-drug resistant isolates were resistant to fluconazole and amphotericin B, and they were found in clades 1. Isolates with resistance to 1 class, shown in green, were resistant to fluconazole, and they were in clades 1 and clades 3. The mechanism of resistance to azole that we've observed are the same that have been observed elsewhere, with Y132F or K143R in clades 1, or F126L in clade 3. These are the specimen types that have yielded C. auris in Canada. Some C. auris were identified when screening, and then some were identified during the course of clinical care. Axilla and/or groin was the most commonly identified specimen type, and these would represent colonization screenings. Other specimen types yielding C. auris were ear, blood, respiratory tract, leg, toe, urine, and other sites. As you might know, Candida auris was named after the Latin word for ear or oral, since this is a common site of infection. So the other category that's demonstrated on the screen included isolates that were taken from wound, peritoneal fluid, and unspecified drainage. We have used whole genome sequencing to monitor the emergence of C. auris in Canada, and this is a genomic tree that is based on single nucleotide variants, or SNVs, in the core genome. Canadian isolates belong to 4 major clades or strains of C. auris, which are named clades 1 to 4. A smaller 5th clade and potentially a 6th clade have been identified elsewhere, but they have not been detected in Canada. Currently, the largest clade in Canada is clade 1, as you can see on the bottom left. There is a very clear separation of the clades with tens of thousands of nucleotide variants between them. But within each clade, isolates can be highly clonal. Fortunately, whole genome sequencing has the resolution to distinguish between these isolates when you view the clades one at a time. So for instance, here's a zoomed in section of the whole genome sequencing tree, and you can see that WGS can be used to support outbreak investigations. So you can see there were 2 patients denoted with the 2 blue dots that were identified from the same facility, and they had a strong epidemiological link. And you can see that they were also closely genetically related, which helped further confirm that transmission had occurred. In 2018, CNISP hospitals were surveyed to evaluate infection prevention and laboratory preparedness for Candida auris, and there was a publication based on the results of that survey. Given that there's been a global increase in C. auris and the recent rapid spread in the United States, CNISP is repeating the 2018 survey with the following goals: to provide an updated assessment of C. auris infection prevention and laboratory practices among participating hospitals, and to inform the response of emergence of C. auris among healthcare facilities in Canada. There were 2 different survey components, one for IPAC information and one for laboratory information. The IPAC survey included questions on how CNISP hospitals screen patients to identify those who are infected or colonized, and what additional precautions are used to reduce the risk of transmission from colonized patients to others. And the laboratory survey included questions on how labs process specimens to identify C. auris. We're currently finalizing the results right now, and the results will be presented at our annual CNISP meeting in November, and we are also pursuing a publication of the results of the survey as well. So I just want to thank submitters from our 2 streams of surveillance, thank everyone from CNISP, including the C. auris working group and participating facilities, as well as a thank you to the CPHN mycology working group, all the healthcare facilities who forward isolates for surveillance, and the late Dr. Michael Melvey, who was the former chief of the AMR and nosocomial infection surveillance section, and who championed all things AMR, including this work. So that's it for me.
Thank you very much. So I have a question for all of our 3 CNISP speakers, and you can each give a commentary to the global question. If you had infinite resources for CNISP, an understanding that that's a question based on fantasy, if you had infinite resources for CNISP, Cassandra, what would be your your vision for the future?
That's a wonderful question. With infinite resources, I think it would be interesting to to look into surveillance of cesarean SSIs. I know that that would come with a lot of complications and challenges, but I think that that would be an interesting project to add to our list.
Excellent.
I'll go with that. But that is just my personal answer to that question.
No, and that's a great question because it basically comes down to clean surgical procedures. Sure. George, infinite resources.
What a day that would be. So for CNIS, I think expansion of, including as many different organisms as we could. We have current gaps in a lot of our different pathogens that we look at. So we're really targeted. So we look at the lab predominantly just 4 types, but there's a lack of ESBL surveillance, for an example. Many other emerging pathogens, furthering the fungal research into beyond just Candida auris, but into other fungal pathogens as well. Sequencing and typing the data, pulling it all together, increasing representativeness of sort of the CNIS surveillance into a lot more of the remote northern communities. You can recall back to the map of, we're trying our efforts to increase that representation, but still from the map, we're still looking very urban oriented. So to get sort of a better reflection of that. And then looking into more of our emergency room and outpatient data for a lot of these organisms. So there's a little bit of a gap in our what's going on in the community. So to expand the hospital into the community would be another area that I would love to get into.
Thank you. And Cassandra, clearly, not Cassandra, Aaron, clearly your passion would be for Candida auris and expanding surveillance. But if CNIS had infinite resources, your wish list?
I kind of echo what George and Cass have previously said. I think another thing on top of expanding our representativeness of Canadian hospitals would be to improve our timeliness. Currently, the detailed patient questionnaires are on a quarterly submission, and VRI, as Cass mentioned, is kind of the exception to that, where we receive aggregate submissions on a biweekly basis. I think it's really appreciated by the hospitals to have that timely understanding of what's going on, and I think it would be really great if that would be possible for other pathogens as well.
Thank you. So one of the questions asks, is there a reason why Candida auris is not a reportable disease or disease of public health significance in all provinces, territories, given the high level of concern associated with it? I think that there's a direct laboratory to public health reporting of Candida auris, as there is of all pathogens of clinical and epidemiologic significance. I don't know. Do any of the speakers have any commentary about Candida auris reporting?
I can try and make a comment on this one. So it's reportable in certain provinces. Certain jurisdictions have made it mandatory and a reportable disease. At the national level, it's not a reportable disease. We have flagged that as potentially a gap. So far, we don't feel that we've missed anything, as provinces and territories do submit all isolates to NML for sequencing. But the challenge with making a reportable disease, from my understanding, is that then the whole list of reportable diseases also goes under review. And so it kind of makes it a little bit tricky, but it has been raised to senior tables at the Public Health Agency as a potential gap that it's not a reportable disease in Canada.
Okay, thank you. And then one of the questions asks, what about the WHO protocols for Candida auris. I've never heard of this. So what I would suggest to the person who put that question is go to the internet, type in WRHA, infection control, Candida auris, and you will find a protocol in the infection prevention and control section of the WRHA, and it summarizes who's at risk and where should screening occur. And our primary concern for Candida auris are persons who have received health care in other locations other than Canada. And we evaluate persons that are potentially at risk on a case-by-case basis. So it's not done wide scale. Let's see what other questions we've got. So one of the questions was, what are we doing for deflagging patients with MRSA in hospital? This is more of a facility, regional health authority issue and not one for CNISP, but whenever possible, we try to deflag or de-identify individuals who have been identified as having colonization or infection with MRSA. And that same question had a component that talked about resource utilization and bed flow issues with patient isolation. And I think we all agree that in our current healthcare facilities in Manitoba, we really do struggle with flow as it pertains to patient isolation, and this becomes even more convoluted during the respiratory virus season. Now I want to see if, unfortunately, the screen is very small on my computer. And then there's a question about comment, if you would, on surveillance in ambulatory care facilities compared to inpatient healthcare facilities. And again, CNISP, how much outpatient surveillance are you doing?
So I can just talk maybe on C. difficile as an example. So within the past, I guess since 2015, we began looking at community-associated CDI, and that was expanded into outpatient collection of data as well for C. difficile. So we look at basically your outpatient settings, emergency room as well. Not all sites can participate in that. It's a challenging aspect to add to the surveillance programs, but for the ones that do are contributing, we have quite a bit of data on C. diff, comparing the two, the hospital and what we see in the outpatient data. So doable, but challenging.
Thank you very much. Just looking to see if there are any other. I unfortunately can't really make out the rest of the questions on my computer screen. It's 11:29. Why don't we break for lunch? See you back at noontime. And again, please make sure that you've signed into Slido, register, and you can ask your questions through Slido, and you can increase or decrease the priority of a specific question. When we return at noon, it will be medical grand rounds, and we'll be joined by Dr. Carl Boodman, who will present pathogens forgotten but not gone, reviving and maintaining interest in important microorganisms. So we will see you all at noon. Thank you for attending the morning sessions. So for those who registered online with CPD, please ensure you've checked in and recorded your attendance on Slido using the code #BOG in capital 2024. This will allow you to download your certificate and claim credits for attending today's event. If you require a certificate or credits and you have not registered with the Department of Continuing Professional Development, please visit the CPD website now and register, www.cpd-umanitoba.com. Registration closes at 4 p.m. today. No need to register with CPD if a certificate or credits are not required. Reminder, please use Slido, because that's where you can enter your evaluations and switch from room to room and ask questions. So our next speaker for the next hour or 45 minutes to an hour is Carl Boodman, whose medical grand rounds presentation is entitled Pathogens Forgotten but Not Gone, Reviving and Maintaining Interest in Important Microorganisms. Carl is an infectious disease physician and medical microbiologist pursuing additional training, in particular a PhD, at the Institute of Tropical Medicine in Belgium, supported by the University of Manitoba's Clinical Investigator Program and the Canadian Institutes of Health Research. Carl's research focuses on neglected vector-borne diseases linked to poverty. Carl, the floor is yours.
Thank you very much, John. It's a great honor to be here and speak at Bug Day. I've appreciated many iterations of Bug Day, and I wouldn't be where I am today without a lot of the support from the University of Manitoba and their infectious disease and medical microbiology program. So forgotten but not gone, I'll talk about reviving interest, mostly in the louse-borne bacterium, Bartonella quintana, and I'll explain why. And this involves renewing interest both in lice as well as this disease. So I know that there have been a number of land acknowledgements so far today. I just wanted to add a special one here regarding this talk, because this talk does deal with underhousing, and I want to recognize that Canada-wide Indigenous people are 8 times more likely to be homeless, and this relates to colonial disruptions with regards to self, family, community, land, water, place, animals, and culture. And if you're interested in this, there's a really fascinating and well-written article by Jessie Thistle and Janet Smiley on advancing good relations with Indigenous people experiencing homelessness. So the objectives are I think I have some conflicts of interest that I skipped over. So I'm a CIHR fellow, so I get some salary there. Also from the Clinical Investigator Program at the University of Manitoba. And I have a couple of research grants with the European Society of Medical Microbiology and Infectious Diseases. These are operational, also a bilateral Flanders-Quebec operational grant and the European Commission. And I'm part of a guideline committee that's volunteer basis with the National Institutes of Health, but they don't really sway me one way or another. So the objectives, so we're going to discuss the historical evolution of Bartonella quintana from its forgotten past to its relevant present. We'll talk about the epidemiology, both in Canada and globally, and we'll also talk about different disease manifestations. Now, we'll start off in 1915. So the very first description of Bartonella quintana was done during World War I by a British medical officer on the Western Front. And he reported in the Lancet of a soldier with a relapsing fever and shin pain. And you could see the original Lancet description, a note on a relapsing fever of unknown origin, just to your right here. So Major Graham says, I've been receiving cases in considerable numbers presenting with clinical features that do not differ from those given above. And we later find out that there's been over 1 million cases of quote unquote trench fever in World War I. From 1915 to 1918, the transmission and the cause of trench fever were hotly debated. In 1918, there were 2 commissions in true bureaucratic fashion, one British, one American, and they came to the same conclusion. And that conclusion was that the disease was louse-borne. And the bacterium, what they called then Rickettsia quintana, now we know it as Bartonella quintana, was consistently found in the gut and the feces of lice that fed on patients with trench fever. And here you can see the report on the progress of trench fever performed by the American Red Cross. And you can see here that the subject of transmission of trench fever as being one of the most important for investigations in connection with the loss of manpower in some of the armies on the Western Front and being an urgent problem. So basically, I just want you to, as an audience, to think, okay, so people are describing this as very important and an urgent problem at this time and a major loss of manpower. Then there's also the British Commission. And you can see here that there's a beautiful drawing of sewing cotton fouled by lice excreta. And if you look at this picture, there's a bunch of lice excreta, so lice feces, but you actually don't see the lice. And I'd just like to indicate here that we find out that the lice excreta are filled with this bacteria. So this image is actually quite important to understand transmission. And then at that time, in around in the 19-teens, in the early 1920s, there was experimental lice fed on patients with trench fever. And then the lice feces were scarified and inoculated in healthy volunteers who then developed fever. So these are, experiments that we couldn't do today due to ethics, but did provide some insights into trench fever. And you can see here that lice were fed upon the individual, the original individual, from the 298th to the 339th day from the onset of his trench fever attack. So the person started having the onset of symptoms around 300 days before. And even after the lice fed and were transferred to someone new, the new person got fever. And this indicates even 100 years ago that the bacteremia lasts for around a year, or sometimes longer, many, many months. And the result of subcutaneous injection of 1.5 milligrams of lice excreta, causes fever, but then if you half that, well, it kind of failed to produce an infection. And they note the increasing incubation periods as the dose was reduced. So with a lower dose, there's a longer incubation period. Higher dose, people get fever a little bit earlier. Now, one of the other interesting parts of this was understanding, well, what is the burden of lice on each individual? And it concluded that in extreme cases, around 90%, 95% of the soldiers had lice on them. And the average number was 20 lice per person, but the range being 10 to 30. But then some of them actually found 350 lice on each person, and some estimated to have 10,000 lice on a single individual. And we've seen this subsequently in other contexts, which I'll explain, where sometimes there's individuals with just a couple of lice, and then there's sometimes individuals that are hyper infested with hundreds of lice. Now, this is a picture of a body louse, and the body louse is feeding and in the process of defecating. And you can see at the tail end of the louse that while it's feeding, it's actually kind of producing this feces full of blood. Now, this is important because the transmission of trench fever happens not like a mosquito with malaria. It actually happens through the feces of the body louse. So the body louse takes a blood meal from an individual, and the bacterium replicate in the gut. But while it's and then if there's individuals in close contact without access to running water, then an infested louse would go onto a new host, a new human being that is not yet infected, bite, but also defecate while biting. And the bite causes a lot of itchiness. So people will scratch. And when they scratch, the feces from the louse is teeming with 10 to the 7, like hundreds of thousands of bacteria will actually make its way into the bloodstream of the new individual and cause this chronic bacteremia that we discussed earlier. So, this initial investigation into body lice and trench fever was a big deal. And it actually was what caused mandatory showers in World War I among the Allied forces. So you can see here, dozens of individuals lining up for mandatory showers. And before that, there actually weren't mandatory showers for soldiers. They also included a steam disinfector for clothing that you can see here. And actually, with some of our outreach with Doctors Without Borders, we use something actually not that different to deal with ectoparasites that are infesting people's clothing and bedding. So as of 1919, what do we know about Bartonella quintana? So we know it's a cause of febrile illness known as trench fever. We know it affects soldiers, mostly men, in the trenches of World War I. It's transmitted by body lice feces, scratched into skin, and then causing a prolonged bloodstream infection, at least 10 months at this point. That it couldn't be cultured, and that the disease was a major public health concern. There were 2 commissions that were publicly funded. And then if we fast forward between 1919 and 1990, there's really not that much research. So there's outbreaks that were reported in World War II. There's some in Ethiopia in 1946, in Tunisia in 61. There was a major breakthrough in the 1960s when Vincent was able to cultivate the rickettsial agent of trench fever, Bartonella quintana, from a patient in Mexico City. So you can see here, I've mentioned World War I, that was kind of in Belgium and France, the Western Front, and you see Ethiopia, Tunisia, Mexico. You already get a sense that the disease is widespread. And then in 1990, people identified it as a cause of bacillary angiomatosis. And I'll show you pictures of this in a second, but this is a vascular lesion. And this was mostly found in immunosuppressed individuals living with HIV and AIDS. And they found that they were wondering, they were seeing individuals with these vascular lesions and they didn't know what it was. And then they found, okay, this is actually caused by a rickettsia-like organism closely related to Bartonella quintana or Rickettsia quintana. And we now know that it is caused both by Bartonella quintana as well as Bartonella henselae. And these are some images of bacillary angiomatosis, actually from the prairies, and someone from Saskatchewan published in 2005. And this was molecularly confirmed to be caused by Bartonella quintana. Now I'll talk about the Canadian epidemiology a little bit later. And then in 1993, we have the first case of endocarditis. So we've heard about chronic bacteremia. We started off talking about trench fever. And then in we talked about bacillary angiomatosis with HIV and AIDS. And then in 93, there's this description of endocarditis. And this is a new manifestation of this disease, or new discovery of what this disease can cause. And so they say, okay, our report expands the spectrum of Rocalame, that was the genus at that point, infections, and identifies a new infectious cause of endocarditis. And actually, David Spatt at University of Washington is still involved. If you go to Up to Date, he's the one who wrote that chapter, and he edits a lot of papers, which is great. Then a couple of years later, they kind of find, okay, well, there's actually chronic bacteremia, and it's linked to houselessness. So we have both endocarditis, but we also have these small clusters, these case series among individuals in inner city environments who are experiencing houselessness and often have chronic alcohol use disorder. And so there were 10 patients, and 10 of them had chronic bacteremia. This was also David Spack, so this was in Seattle. And 2 out of the 10 developed subacute endocarditis and required surgical removal of the aortic valve. And so now we know Bartonella quintana is a cause of fever, bacteremia, endocarditis in both HIV positive, but also HIV negative, underhoused inner city patients. And this was published in the New England Journal of Medicine. And then if you fast forward another couple of years, there's this, they decided to coin the term urban trench fever. So we had the trench fever from 100 years ago in World War I, and then they were saying, well, actually it's the same, there's the same disease, same organism, but with different manifestations, chronic bacteremia. The new thing is endocarditis in this context, and it really is in inner city urban environments. And it predominantly involves, quote unquote, socially disadvantaged individuals. So as of the year 2000, what do we know about Bartonella quintana? Well, we know it's body lice-borne bacterial infection. Okay, we knew this 100 years ago. Now we know, okay, it causes endocarditis, chronic bacteremia, and bacillary angiomatosis. So the endocarditis and bacillary angiomatosis are new. It affects people, predominantly men, experiencing homelessness. So in that case series of 10 individuals, they were all men. And is it a public health concern? Well, there's no commissions, it's not notifiable. There's some kind of case series, but there isn't very much buzz about it. So then, I'll tell you how I ended up getting involved with this, but we decided to look and say, well, what is the global burden of Bartonella quintana endocarditis globally? Is it just in high-income countries? Is it also in low-income countries? Where is it? And it turns out, and this is doing kind of individual cases, systematic review of all published cases that were molecularly confirmed. So that does create some selection bias. And we found that, okay, it's in 40 countries, both in high-income countries and low and middle-income countries. It's both urban and rural. It's linked to a lack of running water everywhere, and that makes sense because it's linked to pediculosis corporis or body lice infestation. But it's not always linked to houselessness, especially not in low and middle income countries. So we found this kind of different epidemiologic pattern between low and middle income countries and high income countries. And I'll just highlight the ones that had a significant p-value here. So you see, okay, rural and housed was more likely in low and middle income countries. So there's actually housed individuals in low and middle income countries who get Bartonella quintana endocarditis. And also in low and middle income countries, they're more likely to have prevalvular disease, either caused by rheumatic heart disease, because there's kind of an overlap in risk factors, or also, I'll mention it soon, with pediatric endocarditis and congenital heart disease. What was interesting was that the clinical manifestations were somewhat different than the manifestations described 100 years ago. So fever was actually in the minority. So, 40% of individuals had fever. More patients actually presented with heart failure. And the median symptom duration when it was recorded prior to presentation was around 5 months. So there's a long diagnostic delay. And that we found that 25% of individuals had embolization, and this was most commonly to the spleen and the brain. And this is also what we've seen in Canada. And by the time it's diagnosed, the vegetation size is big. It's 2 centimeters. We also saw this signal where the childhood cases of endocarditis were disproportionately from low and middle income countries. So if you look through all the pediatric cases of B. quintana endocarditis, you have Algeria, Senegal, Ethiopia, and then Canada. And I'll talk about this one that we published briefly, but this was actually from a northern and remote indigenous community that doesn't have access to running water, unfortunately. And there's a lot of housing shortage there. So these are housed individuals in Canada. But this was the only case of pediatric Bartonella quintana endocarditis acquired in a high-income country. And this individual did not leave his home community before being diagnosed. Luckily, everybody survived, but they needed heart valve replacement surgery and long courses of antibiotics with doxycycline and then something else, either gentamicin or rifampin. So with all of these cases, the overall case fatality rate was 10%, but this is with treatment. So this is often with valve replacement surgery when it was available and long courses of antibiotics. And when you look at the ones that died versus the ones that survived, the ones that died were more likely to be older, like age above 65, were more likely to present with fever, were more likely to have renal dysfunction, and interestingly, were more likely to not have been treated with valve replacement surgery. And you can imagine this to be the case if the average vegetation size is around 2 centimeters. But then, of course, this makes you wonder because valve replacement surgery is not available in many of the countries and settings where this disease is present. So now, I'll just shift gears a little bit because there's been a lot of talk and some controversy about whether this is transmitted by other arthropods, bed bugs, head lice. And we really wanted to understand what was written about this. So we did another systematic review and meta-analysis of basically every arthropod study that has been tested for B. quintana. And as you can see here, Bartonella quintana has been detected in a whole bunch of different insects. or arthropods. I mean, some of them are not just insects, so I'll call them arthropods because you have arachnids, you have mites here. But the vast majority of the studies show that it's lice, right? Interestingly, there is a number of studies, or there are a number of studies with head lice that are positive. Now, they're not as commonly positive as body lice. So in body lice, on average, among almost 10,000 arthropods, the average proportion of positivity is close to 20%. So if someone had, like globally, if someone has body lice, 1 in almost 5 will be positive for Bartonella quintana. In head lice, it's a lot lower. It's closer to 8%. And I'll talk about this because this is a very controversial claim. Now, if you look at all these other, arthropods, pubic lice or fleas, bed bugs, you occasionally have, a positive result. But the thing is, if you have chronic bacteremia and you have an insect that bites you, and then you take the insect or the arthropod and you analyze it with PCR, you extract the DNA, you could find the bacterium that was in the original blood meal, but it doesn't mean that it's going to that insect or that arthropod will transmit it to something else. Because as I mentioned at the beginning, that arthropod really needs to defecate while feeding, and defecate on the skin. So often bed bugs, okay, well, that might do it, under the bed or on the, hide in the cracks. For mites, that's not really the case. Ticks, less so. So, even though there's B. quintana that's been found in a lot of different insects here and there, or arthropods here and there, it doesn't actually mean that they're responsible for transmission. But the signal about head lice is quite interesting and controversial. So I'll talk a little bit more about that. Exactly. But wait, head lice. Now, it turns out that the signal only occurs in low resource settings. So it's not in high income countries among, kids who've had, head lice. I had head lice when I was a kid, In high income settings, none of the head lice are positive. So if all the studies where B. quintana detection in head lice exceeded that of body lice, you can see it's in Nepal, Ethiopia. I'll talk about the one in USA, Madagascar, again in Ethiopia. Now, the one in USA, the Vanilla, that was a CDC study, and that was done among underhoused individuals in San Francisco. So it's not, school-age kids. These are people who are underhoused and may actually have co-infestation with body lice and head lice. Now, let's look at the studies that exclusively tested head lice, only head lice, no body lice, and reported B. quintana detection. You can see also, again, Senegal, Mexico, Madagascar, Turkey, USA. Now, this one in the USA was done in the Appalachians and in a rural environment that is actually known to have a lot of rural poverty and a lack of access to running water. So this is also a low resource setting, even though it is in the US. Mali, Senegal, France. So, I presented some data globally. It's in 40 countries, and it's transmitted by lice, predominantly still body lice, but head lice may transmit it in low resource settings. There's also some genomic data to support this, but it's quite scant. So what about Canada? So between 1990 to 2019, there were only 2 cases of B. quintana endocarditis reported. And you can see one was in Halifax and that was actually a fatal case. And then one was published by University of Manitoba's Yoav Keenan and the team here. And this was actually in northern Manitoba, close to the border with Saskatchewan. And then, in February to April 2020, we had 4 cases of B. quintana endocarditis diagnosed in inner city Winnipeg. So, you have all of Canada in 30 years and there's 2 cases. And then within a couple of months, there's 4 cases in, Winnipeg. And it's all really linked to, 1 or 2 shelters. This is a description of the 4 initial cases. And I just want to draw your attention to the fact that 2 of the 4 presented with intracranial hemorrhage. So they presented with a ruptured mycotic aneurysm. Some of them had neurologic sequelae. And so they didn't actually present with fever or, chest pain or heart failure symptoms. They presented as a stroke, actually, and were initially maybe misdiagnosed before an echo was done and found, the vegetation. And of course, blood cultures are negative in this pathogen. So it's a culture negative pathogen. Your routine blood cultures won't capture it. Now, if you look at patient 2, this was actually an incidental murmur. So this was a very astute inner city nurse working at Solo Mission who found a new murmur in someone. And luckily, this patient underwent, valve replacement surgery, antibiotics, doxycycline, gentamicin, and made a full recovery. But there was a 2-centimeter vegetation there, and this person was walking around with a little bit of anemia, a little bit of weight loss, but was otherwise actually doing well. But I'm very glad that we caught this individual before it embolized to an area like the brain. So transmission, I already talked about the transmission here, but you could see pictures from Winnipeg of body lice and kind of what it can cause, and especially when people don't have access to laundry services when they're bundled up in the cold. And of course, there's informed consent here, but these are some of the lesions caused by pediculosis corporis. So then we were wondering, okay, well, how many other cases of this disease occur in plain sight in Manitoba that are just, hidden? So we did a retrospective review of all the positive serologies, and the high serologies may be indicative of endocarditis. So we reviewed these cases. And it turned out that there were 11 cases of B. quintana. 8 of the 11 were endocarditis. Most of the endocarditis cases had evidence of embolization. And the most common location of embolization was intracranial, so the brain, with mycotic aneurysms. And then the other place was the spleen. And, I talked about this case a little bit earlier, but subsequently, a child was diagnosed with this disease. So we know it wasn't only in the inner city environment, but also in northern and remote communities that lack access to running water. And this was an 11-year-old, and there's informed consent here for this one as well. And he never left the community before presenting an acute heart failure, not with fever. And he had aortic dysfunction due to a large aortic vegetation and required valve replacement and ICU admission for a couple of months, and luckily did well. And B. quintana was confirmed with sequencing 16S, and his serology with an indirect immunofluorescent antibody assay done at the national lab at the NML was elevated at around 1 in 1,000. And around this cutoff is suggestive of endocarditis. And as I mentioned, thankfully, he did very well. But, where are the body lice? So in all of these descriptions, in the retrospective case series and the serologies, there were really no reports of people having body lice. There was no body lice studies in Canada. And so, we knew that this disease was transmitted by lice and body lice, but really there was like zero data. So then we started to do the first body lice study in Canada to see, hey, is this, are we finding it in the body lice that are around, and are even body lice present here, or is there an alternative form of transmission? We just really didn't know. There was no data. So here are some pictures of the body lice that we collected in inner city Winnipeg, and in collaboration with the NML. And you can see to the left, this is hundreds of body lice from a single individual. And so we subsequently published this in EID. So this is pathogen surveillance among people experiencing homelessness. And you could actually see that among, we had 7 individuals with body lice, and then 1 out of the 7, all of the body lice were positive. So all of the body lice pools were positive for Bartonella, Quintana, multiple targets on PCR, genus and species. There was some co-infection with Acinetobacter in the louse, but it's likely an endosymbiont and not likely a pathogen. Now, interesting. So we know that, hey, and also that individual with body lice positivity was found to be serologically positive, and we followed him up and we were able to treat him. He did not have endocarditis, luckily, but he was able to be treated. So, interestingly, a couple of years later, I'm in collaboration with the team at the University of Alberta and Dr. Kabani. There was a cluster of donor-derived Bartonellosis. So this is now a completely new manifestation. So it was among organ transplant recipients, and they had received organs from underhoused people who had died of predominantly of opiate overdoses. So there was 6 solid organ transplant recipients who developed Bartonellosis, and this was all due to Bartonella quintana, molecularly proven. And most of these were from seropositive donors, and then these were from deceased donors, so donors that were found dead, and they were underhoused. And so the attack rate was actually from positive donors was around 12%. And these are some pictures of the organ transplant recipients. And they presented months after the transplantation, mostly with bacillary angiomatosis, because of course the transplant recipients are immunosuppressed. So they kind of presented similar to those bacillary angiomatosis cases linked to HIV and AIDS in the 90s. And I was chatting with some of the collaborators at the at the US CDC, and they actually said, hey, we've had similar cases. So there was a change in candidacy of organ transplantation, both in the US and Canada, with the availability of Hep C and treatment, direct-acting antivirals, and then also, unfortunately, the amount of organs available due to the epidemic of drug toxicity and overdoses. So then we developed some kind of guidelines or guidance regarding what to do about this issue that was then actually an international phenomenon, so both in the US and Canada. And this led to some changes in donor screening, where we established some risk assessment for donor B. quintana infection, including a history of body lice infestation, homelessness, shelter services, also living in a refugee camp, because we know that the disease is present globally, or immigrating from a low-income country where running water is limited. So it's not, if you're from Lagos and live in, a condo, you're not going to get this disease. But if you're in a high altitude area in Ethiopia and, without access to running water, you may have this disease kind of with chronic bacteremia. We also mentioned, okay, if you're from a Canadian Indigenous community, but not everyone, but one without access to running water, there may be a risk there. And then also death due to drug overdose and a significant or a history of alcohol use disorder. And the alcohol use disorder was really linked to the reports from the 1990s. And subsequently, we decided to work with the National Microbiology Lab to really get an understanding of the cases that were diagnosed at the national lab that weren't published, and combining them with the published cases. And some of these published cases were never sent to the national lab because it could be diagnosed by 16S. People don't think that the endocarditis is caused by B. quintana, so they do their 16S sequencing, often from the heart valve at their own academic hospital. And we look and we find that, hey, cases of B. quintana are increasing in the last number of years. So both the ones tested at the NML and outside the NML. And these ones are all the molecularly confirmed, PCR confirmed cases, multiple targets. And that, sure, there's an absolute case number, but maybe this is just people are paying more attention, they're testing more. But actually, the percent positivity was also increasing. So this is not just more testing. It has to do with, there is a real increase now. Why? Is it linked to trends in housing? Is it linked to maybe people are testing more appropriately? We really don't know. And as you can see here, in 2019, there were only 2 or 3 PCR confirmed cases in Canada that were published. Now we look back, and this year we find 33 confirmed cases, 7 provinces, 1 territory, 20% mortality, all due to endocarditis. You find cases, there's a fatal case in Nunavut, you have cases from BC to Halifax. So it's really across the country. And then we want, but there's still a lot of questions, like quantifying the hidden burden, both in Canada and globally, is really a black box. If you go to the kind of outside realm, the white realm of this, you have, actually, let's start from the inside, scratch that. So let's start with the cases of known effective endocarditis, i.e. So we have some known cases, we have, 20 odd cases in Canada. But, a lot of these cases were found, some of these cases I mentioned were found with an incidental murmur. That was just an astute inner city nurse. So, you have the known cases, but then you have the surrounding it, these unknown cases of infective endocarditis that are not treated or maybe misdiagnosed. We have no idea how big that circle is. And of those, how many contacts, close contacts, have bacteremia, the chronic bacteremia that lasts months to even years? We have no idea. And then around that, seropositivity with cleared infection and community transmission in all these different areas, we really have no clue. So as of 2024, what do we know about Bartonella quintana? Well, we still know it's a louse-borne bacterial infection, predominantly body lice still, but maybe head lice in certain low resource settings. And if you want to talk about this controversial statement, I'll gladly talk to you about it. It causes endocarditis, but also presents with embolization, and cases are initially misdiagnosed often as stroke. And there's bacteremia, bacillary angiomatosis. It affects people experiencing homelessness of all genders, but also housed individuals in low and middle income countries. And it can be a cause of pediatric disease in low resource settings. Then we also found, hey, there's donor-derived infection just in the last couple of years among transplant recipients. That's completely new. There's increasing cases, both in absolute numbers, but also the percent positivity in Canada. Now, is it a public health concern? I mean, I'm arguing that it is, but it's not notifiable. And there's very few research labs globally, definitely no commissions. And honestly, Canada, for dedicated research labs, there's really none in Canada. There's the NML that does testing, and it's wonderful to collaborate with them, but none in Canada. In the US, there's maybe one. There used to be one in San Francisco. That person retired. The rest of the Americas, there's zoonotic Bartonella with Andre Marcos in Sao Paulo, but really nowhere else. In Europe, there's Marseille, and then Asia, Oceania, Africa, there's no dedicated research lab. So there's a global disease, but very little resources and dedicated research labs. So why is B. quintana so neglected? I mean, one, it's not identified by routine culture. Your bacterial culture with 5-day incubation, you won't find it because it grows slowly. It's hidden in the red blood cells. It causes chronic mild symptomatology prior to the endovascular complications. It may be misdiagnosed as stroke or heart failure. It's rarely an acute illness. There's often a delay between the acquisition and then the severe outcome. It could be years until someone presents with endocarditis. There's often no fever, so there's really the misconception about trench fever. And I think the last point is very important, is that it predominantly infects individuals experiencing severe poverty and barriers to healthcare access. So this kind of links up with advocacy. So, I worked with David McDougall from one of the kind of Anishinaabe communities to write an op-ed in the Globe and Mail saying that, running water is not just for drinking, and that this is a human right and can have fatal consequences. The MP Leah Gazan, I think in the West End in Winnipeg, brought this before Parliament, Canadian Parliament, to advocate for better housing and access to laundry services in the inner city. And I want to emphasize that the root cause is really a lack of access to running water and adequate housing. And when I talked about this with some of the Anishinaabe communities in some of their meetings, they said, well, this is an issue of important concern, and that there's actually been issues with lice in different communities for a long period of time. And they mentioned that there's this sculpture in the Winnipeg Art Gallery of someone with lice. And this is actually an Inuit sculpture, but we know that there was at least one fatal case from Nunavut, unfortunately. Now, in the Belgian context, this is, underhousing is a kind of a different epidemiology. It really has to do with migration, similar to what Dr. Chris Greenaway mentioned this morning. And you can see, I do some outreach with MSF and Doctors of the World. MSF is Médecins Sans Frontières, Doctors Without Borders. And this building to your top left is, a huge office building that is now a squat with 300 people. And there's body lice and scabies and bed bug problems there. To the right, you could see a tent. So these are people trying to get to the UK, and are transiting through Belgium. So in Belgium, there's no studies on body lice or B. quintana. There are some B. quintana cases among refugees that have been diagnosed. And most ID docs, when I chatted with them and first arrived here, had never seen body lice. A few IG docs had treated Bartonella quintana infective endocarditis. But then after I started presenting on this, through the woodwork, people get in touch and say, hey, I started looking in someone's clothing and I found, lo and behold, body lice. Someone from the big community organization that provides housing takes a picture and says, hey, bonjour, Carl. Hi, Carl. I hope all's well. Is this a body louse? And lo and behold, they're both cases of body lice, one in Antwerp, one in Brussels. So we know it's there. And then when you talk to inner city organizations, La Fontaine in Brussels provides, laundry services to underhoused individuals in Brussels. It's just one organization of many. And last year, they keep statistics on body lice, and they had 160 cases last year. So our pilot study in emerging infectious diseases was 7 patients. They had 160, and they keep statistics, and they know the difference between body lice and scabies and bed bugs. And of course, the inner city nurses knew it, but it actually hadn't translated or connected with any of the infectious disease specialists. And as we know from the systematic review, around 20% of these body lice may be positive for B. quintana. So that's what we're working on now. Now, in collaboration with MSF, they sent me this internal document of body lice and scabies co-infection in Serbia on the Western Balkan route. So as you see here, some of refugees will come, some come across the Mediterranean, and we hear about this in the news, and a number of the other route is kind of through the Balkans and through Serbia. And I won't read all of these quotes because, I want to make sure there's enough time for questions. But you can see here that, there's 165% with body lice only, 150 with scabies only, and 150 with body lice and scabies co-infection. But this is an internal document not published. And then, but you realize, hey, there's actually hundreds of cases of body lice, and probably on average, 1/5 of these may be infected with B. quintana. And then they did an intervention, but even afterwards, we have hundreds of cases of body lice and many cases of misdiagnosis. Later in a follow-up phase, they had 500 cases of body lice. These are weekly body lice and scabies diagnoses. So every week you could have, at the peak, it's 300 cases of body lice a week. So, this leads to advocacy because it's not just about microbiology and kind of geeking out about the diagnostics, but, there's a hidden burden of this, and also definitely on the African continent. And there's a lot of cases from Ethiopia. We have a cohort of endocarditis, culture-negative endocarditis in Addis, and we're testing those. And then in South Africa, there's the largest prospective cohort on the African continent that tests for culture-negative pathogens is with Alfonso Pecораro's work. He's a cardiologist. And B. quintana is the #2 pathogen after Staph aureus. So more common than Streptococcus, Streptococci species, which is astounding, right? But there's just very little data, but you can see that whether it's Madagascar or Morocco or the DRC, there is evidence both of endocarditis as well as arthropod positivity. But I wanted to emphasize that, what was known 100 years ago, a lot of it is still true. So body lice are found all over the world. There's probably no tribe free of them. So at that, I wanted to thank a lot of people. I want to thank patients, the Anishinaabe communities, Dave McDougall for the advocacy, a lot of inner city organizations and humanitarian organizations. So what I like to do is try to connect these organizations to the labs to actually provide diagnostics. So this includes Médecins Sans Frontières, Médecins du Monde, Doctors of the World, in Winnipeg and the Salome Mission, Main Street Project, Salvation Army, University of Manitoba. Dr. Yoav Keenan has been a great source of support. Terry Wers, Dr. Lagasse Weens, Dr. Andrew Wachte has really helped written so many reference letters. It's been great. The clinical investigator program, Dr. Shane Tabak, who believed in this and allowed me to go to Belgium to study this. At the NML, there's a lot of people. I'll name Heather Coatsworth and Courtney Loomer for now. And then in Belgium, there's a number of people as well. In Ethiopia, there's partners, and in France, Professor Fournier has really helped quite a bit. So there's the Institute of Tropical Medicine, University of Manitoba, and some funders here. Now I'll open it up to questions, and I welcome any input about anything I've shared.
So far we haven't received any questions on this slide though.
Okay. Thank you. I think that was Amanda speaking. I couldn't quite see.
Dana.
Dana, all right, thanks. Well, if any questions come in, don't hesitate to let me know.
Great, yeah.
Well, Carl, let me ask you a question. Given that you've become a world authority in body lice and body louse feces, my question might seem fundamentally simple-minded, but how do we rein this in, given the ravages of Bartonella quintana?
You know, it's a good question. First, we really need to know the magnitude of this, and that's kind of a lot of what I've been working on now. But it's preventable at multiple levels. So, you know, if you have access to laundry services and running water, you know, you prevent transmission. It's as simple as that. If people aren't crowded together, there's no transmission. And then even also, once people are infected, we can treat this. We could treat with doxycycline and you know, and then we could also, you know, treat endocarditis before it happens. But relating to kind of the infection prevention and control thing, you know, this does link to big issues relating to poverty and underhousing. And so basically, a lot of my work is focused on understanding how the burden, you know, when I started and found a couple of cases, there's only 2 described cases in Canada, and now we know there's, you know, over 30, but across Canada, but now we know it's actually really all over the world. So, you know, obviously solving homelessness and migration is not an easy fix, but when you at least have it or you diagnose cases, having it maybe be notifiable will help so we can have good data. And if there is a case, well, you could have, you know, an outbreak protocol where if a case is diagnosed, you contact you screen close contacts with serology, and then you try to, you know, if they're positive, then you could see if there's active bacteremia, you could screen for endocarditis, and obviously providing some laundry services. So I know that in Denver, there was an outbreak and the CDC was involved, and they had a couple of cases of endocarditis, and then they did a seroprevalence study, and basically they ended the outbreak by having this kind of mobile laundry service, and they kept it running, and then they monitored over time, and titers of serology went down and the cases went down. So, you know, if you come across even one case, I mean, there's no animal reservoir, so we know that if there's one case, there's community transmission, and then there's quite simple things you could do, you know. I don't know, did that answer your question, John?
Brilliant. Now, the fundamental problem we've got is how do you find and track the somewhat transient population? And you know, you've done extensive work in the shelters in Winnipeg, and it really is a transient population, and I'm sure that poses considerable challenges. And when you think about the migrants, you know, those camps that you showed, I'm sure it's a challenge tracking who's who and people who probably don't want to be tracked.
That's exactly right. And so it really depends on working with, I mean, some of the migrants, like in that big housing facility in downtown Brussels with 300 people, some people stay there for many, many months at a time while they're waiting to plan their next move. But it does really depend on working with inner city organizations that have existing trust and relationships with those communities and that provide free services. And then also working with hospitals that find ways of providing free care. So, you know, there's both an ethical concern. If you're studying this population, you happen to have a positive result. Well, how do you report it? People don't want to be found. Sometimes, you know, they don't want to be identified by the authorities. And so there's ways, it's not easy, but there are ways, you know, for example, at La Fontaine that saw 160 cases of body lice last year, people often come back. They come back every couple of weeks to get showers and laundry done. And so there's actually, people know each other. And so, there's ways that even if they give a nickname, we could follow up. But it really depends on relationships. Yeah.
We had some questions from the audience.
Okay, so Yoav Keenan asks, Carl, excellent talk. Any studies on optimal antimicrobial therapy?
Great question, Yoav. There's no RCTs. There are some in vitro studies that are contentious, but really the data is very weak or scant. So, we know that doxycycline in combination with something else helps. In France and in Europe, they mostly combine doxycycline with gentamicin based on quite scant in vitro data. In the US, they combine doxycycline with rifampin based on case reports. Now, my opinion is that doxycycline with valve replacement surgery and some other antibiotic that might work is usually enough, but there unfortunately is not enough data to make that claim. Yeah, great question. Sorry, go ahead.
Now we have another question, which is more of a philosophical question. If this could be considered a potential public health risk, why is it acceptable for students in public schools to continue to go to school and not declare if they have head/body lice? Well, I'd like to clarify, and Carl, correct me. Children likely aren't getting body lice, and as I articulated earlier, we're dealing with high-income lice versus low-income lice. So why don't you take it from there?
Thank you, John. Yeah, so exactly. So, ultimately, this is not a concern in high-income settings with children or school-age kids with head lice. So there's zero, all of the studies that test head lice there's not a single positive case. Really, so if head lice are going to transmit it, it has to be when people are living in very close contact with others who are bacteremic with B. quintana. So even if head lice may be in Nepal, in the mountains, or in the DRC, may be able to transmit it, you actually need to be in close proximity to someone who is chronically bacteremic with B. quintana. And in high-income settings among school-age kids, that just simply doesn't happen. And so all of the studies that test school-age kids, they're all negative. So in that sense, head lice are not a public health concern in high-income settings, kind of point. But great question.
So there's another question which actually takes us down an incredible rabbit hole. It says, thank you so much for the excellent talk. In our practice, we have a patient that has been diagnosed with delusional disorder with beliefs that she is infected with body lice. Some of the pieces she has isolated and collected do look consistent with your slides. How do we investigate? So this is more of a question of how do you work through the details with a person who's got a delusional parasitosis, which is an exceptionally difficult condition to treat because the person has to believe that they have the condition, then they have to accept the intervention. My thought would be, and Carl, jump in where you think is appropriate, not to initiate a treatment, submit the specimens to the provincial laboratory for laboratory analysis. Once you've got the piece of paper in hand from the lab that says no parasites observed, then you politely broach the topic of the perception of parasitosis versus true infestation. Carl?
Yes, I completely agree. So these cases are very difficult and, they involve real suffering and psychological suffering, but often to first build trust, it's best to submit these, whatever arthropods they are for analysis. Often they might, if it is true delusional parasitosis, often I've seen cases where it's lint or something else. And then you have the lab report and you bring an individual back And you also encourage them not to, engage with self-harming behaviors such as, putting bleach on their skin or other types of things like that. So it's a matter of kind of making sure that their psychiatric illness does not cause real bodily harm, building trust over time, and using the lab and it's often best to call the lab and say, hey, I really don't think this is body lice, but could you please, look at it and tell us what you think? And then that's a way of building trust and then slowly broaching the topic of having this be a form of delusion. But I completely agree with your approach, John.
Okay. Next one is, how do we as physicians, how can we aid in advocacy as clinicians, especially for communities lacking access to running water? And I think that's ties in beautifully to your article.
There's many ways of going about it. I'm not an expert in advocacy. Some of what I do is, write articles. I've engaged with some community organizations that advocate for bringing running water to Northern Indigenous communities, and they work in collaboration with Northern Indigenous communities. But I mean, I'm open to anybody else's thoughts about how best to do this. At this point, I think a lot of this does depend on really having more data. But I think, as clinicians, we do have some political clout, and so we can use that in certain kind of political ways if we want to. But there's different ways of doing it, and I don't know that my way is the best way.
Okay. Eric Bow asks, and again, I think Eric has asked a superficially very simple question, but likely an exceptionally complicated question. Given the incidence of chronic non-cultural bacteremia, how could we modify our bloodstream infection diagnostic algorithm? And I don't know if that's a Carl question or if it's a Diagnostic Services of Manitoba question.
Sure, I could talk about it hypothetically, because, among people who are not exposed to, who, have not been exposed to body lice, who are not underhoused, have not immigrated from, as an example, a refugee camp in Ethiopia or northern rural Nepal, our current 5-day routine culture identifies the vast majority of the pathogens. So most of the time, our routine culture is great. And this is borne by a lot of studies that show that our routine 5-day culture with automated blood culture techniques identifies, at least 95 to 99% of pathogens. Now, if you have an individual who, has risk factors for certain culture negative organisms, there are techniques you could do to identify it. Some of them are molecular, it's like PCR, even though this, the sensitivity isn't always fantastic from whole blood because the CT values are quite high. The bacterial content is low. But, if you want, you could talk to the lab. And I know Dr. Phil Lagasse-Weens has helped me out. And we've grown B. quintana by incubating it for 3 weeks and freezing and thawing it. I was in touch with Glenn Patriquin at Halifax, who was able to do the same thing. So if you call your microbiology lab and you're suspecting culture negative bacteria, especially related to risk factors in clinical presentation like endocarditis, there are things you could do, and it's best just to talk with your micro lab, and then we could try certain things. I hope that helps, Dr. Bow.
Thank you, Carl. Let's see. And the last question, who would be conducting the notification and contact tracing? I think that's probably a monster of a question.
Yeah, so right now it's not notifiable in any jurisdiction. So, across provinces, nowhere in the world, as far as I know, and I've looked quite a bit, isn't notifiable. So really the first step is making it notifiable, having, clear case definitions, because right now those don't exist. So what is a confirmed case? What is a probable case or suspected case? And so this really depends on an interaction with public health. And so we're not there yet. I mean, hopefully, maybe before I retire in 35 years, B. quintana will be a notifiable disease in Canada, and we'll have clear case definitions. And when we have a case, we could call it up, and there'll be an outbreak investigation or something. But that doesn't happen anywhere, as far as I know.
Well, Carl, thank you very much for an outstanding presentation. Now that it's over, I'll stop scratching. Thank you very much for joining us from Brussels, and have a lovely rest of your day, and we'll switch gears and begin the afternoon session. Thank you,
All
Carl.
right, well, thank you very much.
So now we'll switch gears and introduce Laura McDougall. Laura is a Senior Medical Officer of Health for Alberta Health Services and the Senior Medical Director for Provincial Population and Public Health Program area. Laura is also a Clinical Assistant Professor in the Department of Community Health Sciences at the University of Calgary. Now, what's particularly important is that Laura was on the cutting edge of the foodborne outbreaks in the Alberta daycare centers. And I hope everyone remembers that last August, September, there was a huge outbreak. So Laura is going to speak to us about lessons learned from a daycare center foodborne outbreak. Laura, the floor is yours.
Excellent. Well, thank you so much for allowing me to share some of the lessons learned in managing what did turn out to be the largest outbreak documented anywhere of Shiga toxin producing E. coli or STEC, affecting children 5 years of age and younger. This article in the Winnipeg Free Press and many others in media across the country, as you mentioned, John, suggests there was a fair bit of interest in the outcome from this really large outbreak. So I'll describe how the outbreak unfolded, the public health response to control it, the investigation into the source, and some of the very high-level recommendations from a provincial panel that was convened to assess underlying factors that may have contributed to it. Oops. Thanks. The first sign of severe illness related to this outbreak occurred the Friday before Labor Day weekend in 2023, when pediatric patients began presenting to the pediatric emergency department with bloody diarrhea. On Saturday, the pediatric emerge docs astutely deduced a cluster of bloody diarrhea, all involving 3 childcare facilities, and they contacted the medical officer of health, who began investigating. By Sunday at noon, 14 clinical cases had been seen, and the MOH sent a letter to parents and staff at all 3 childcare facilities, alerting them to the situation and encouraging them to present to the ED if they or their children had symptoms. By 9 p.m., the MOH was aware of 33 clinical cases, and the first culture came back positive for STEC. It would eventually be determined to be Shiga toxin 2 producing, which tends to cause more severe symptoms than Shiga toxin 1 producing types. By then, the public health team had discovered that all 3 childcare sites received meals from a central kitchen, and that all sites were closed for the long weekend. On Labor Day Monday, the MOH declared an outbreak at the central kitchen and all 11 childcare facilities it served food to. Legal closure orders were issued, and affected parties and the public were all notified. So the first lesson is just how rapidly an outbreak can be identified when critical partners in emergency rooms, lab, and public health are very well aligned and work with strong working collaborative relationships. The clinical team did an extraordinary job of identifying patients, monitoring for early symptoms of hemolytic uremic syndrome, and implementing rapid management protocols as needed. Meanwhile, the MOHs and environmental public health officers jumped into action to stem transmission from what appeared to be a point source outbreak. Everyone who had attended the daycare sites that ended up with confirmed cases were excluded from daycare until they had negative culture results, and anyone with symptoms at the remaining daycares that didn't have confirmed cases were also excluded if they were symptomatic. This resulted in more than 1,600 people being legally excluded and followed by public health, and the exclusion orders were not lifted until they had negative stool cultures and confirmed that their symptoms had passed. Other control measures included ensuring other daycares knew not to accept new families from these exposed facilities until their exclusions were lifted, aggressive case finding and investigating all cases and undertaking contact tracing and inspecting the daycare sites themselves and ensuring safe reopening. By the time the outbreak was declared over, 448 cases had been identified, with 359 of those being lab confirmed. Of the confirmed cases, about 90% were primary cases who had been exposed directly to food from the central kitchen. The ratio of primary cases to secondary cases was 11:1, indicating a low rate of person-to-person transmission for an STEC outbreak and good indication that control measures had been successful. However, there were a number of serious outcomes among the primary cases, including 38 children and 1 adult who required hospitalization, 23 people with hemolytic uremic syndrome affecting their kidneys, and 8 needing peritoneal dialysis. And again, due in large measure to the clinical team's concerted efforts, fortunately, there were no deaths. The left side of this slide indicates the childcare facilities that received food from the central kitchen and the very wide range of attack rates among children in these 11 sites, ranging from 47% of children being infected down to 0%. The right side indicates the other 6 childcare facilities that were impacted by virtue of a confirmed case or a contact of a case attending one of these daycares despite the exclusion order. In some instances, their attendance occurred before the outbreak was identified and the exclusion orders were issued. All in all, 17 childcare facilities and all of those families and children had operations interrupted as a result of this outbreak. Proper food processing upstream in the food chain, diligent food handling practices, and robust hand hygiene are, of course, all critical for preventing human STEC infections and outbreaks. And again, here's just a few of the key highlights of Shiga toxin-producing E. coli that are really important in any approach for trying to actually control and take control of an outbreak. Especially the fact that cattle are the major reservoir. And again, this can be transferred to nearby soil and water systems and contaminate crops. Human infections are often linked to undercooked meat, unpasteurized milk or juice, and fruit and green leafy vegetables. And food can be contaminated during production through cross-contamination between foods or after an infected person handles food with inadequate hand hygiene. So all of this was really important in planning the next steps.
Laura, your slides are not advancing.
Oh, no. Where are you at? I'm at source investigation.
It's on the agenda. We're on the agenda slide.
Oh, no.
It's okay.
What do I do? It looks like it's going on mine.
Is there an option to click? Yeah, now we are on regular daycare attendance.
Okay. All right. That's really too bad. Sorry about that.
It's all good. So now we are on exclusion orders and other control.
Okay. This was the breakdown of cases, the severe outcomes, the breakdown by facility, and again, background on E. coli. So on to the source investigation. Again, I'll just try to make up a bit of time here. Again, the epi curve was very useful in trying to indicate the likelihood of this being a point source outbreak, given that it was more or less a single peak over the course of a single incubation period, with cases that were showing up in that second peak, mainly being asymptomatic cases who'd been asked to test at the daycare and who didn't have a very accurate date that could be used for their data bond set. So besides that information from the epi curve, we undertook 2 retrospective cohort studies in order to try to determine the actual contaminated food source. The epi curve suggested that the exposure probably happened on August 28th or 29th, but to get more precise, We looked at a first study with about 1,000 daycare attendees who you'll note were too young to provide a food history of what they'd eaten. We used this study to determine which meals most likely had contaminated food. It turns out the central kitchen provides two types of meals to these daycares: special meals that were dairy and gluten-free and vegan, and regular meals. Meals included breakfast, lunch, and 2 snacks. And all of the daycares kept very precise electronic records of when each child was on site. Meals tended to be served on a regular schedule, and each child in attendance received a special or regular meal, and a record was maintained of which menu they were on. These results show the relative risk of developing STEC according to which meals the children were in attendance for. Lunch on August 29th had a relative risk of 23.5, meaning children who were present for lunch on August 29th were 23 times more likely to have confirmed STEC than if they were not present for that meal. In addition, the relative risk was 19.2 for children on the regular menu and infinite for children on the special menu, indicating that both lunch menus on August 29th, the special and the regular menus, likely contained at least one contaminated food item. But because we don't know exactly which food items the children ate or didn't eat, this study couldn't get any more precise than to say that it was those lunch menus. The meals that were actually served were a beef meatloaf and fresh vegetables for the regular menu, and a vegan meatloaf and oven-ready potatoes for the special menu, both of which were served with fresh vegetables. The second study we did was a retrospective cohort study as well, but this involved more traditional food histories that were gathered from staff who didn't actually order regular or special meals, but who were encouraged to eat whichever foods they liked from the extra trays of food at the daycares. The objective of this study was to pinpoint the contaminated food items themselves. And here you'll see the relative risk for beef meatloaf was 23, indicating that staff who ate beef meatloaf were 23 times more likely to develop confirmed STEC. Very few staff ate the vegan meatloaf. So this study really couldn't accurately determine which item on the special menu was likely contaminated, while we had quite clear evidence that the beef meatloaf was the likely contaminated item on the regular menu. Other source investigations, food sampling was done on 64 food items, all of which tested negative by culture and PCR. There were no actual leftover samples from the meals that were served, but food was collected from any stock in the central kitchen or daycares. It should be noted that over the subsequent 2 weeks, there were 2 cases where a childcare worker had taken beef meatloaf home, and only beef meatloaf, stored it in their fridge or freezer, and then served it to members of the public who ate only the beef meatloaf and became ill with STEC, with a whole genome sequence that matched the rest of the outbreak. A series of other data were gathered and analyzed, but did not provide evidence regarding source or transmission, or any explanation as to why the attack rates varied so widely between the daycares receiving food from the central kitchen. So this was looking at associations between transportation time and attack rates. CFIA did a food trace back and trace forward, oven temperature testing, environmental sampling, etc. Oh, it's control, sorry. Very quickly, the last few slides, Alberta did pull together a FIRIP, Alberta Foodborne Illness and Risk Investigation Protocol, and pulled partners together from all of these agencies to investigate 11 further cases that were identified from the lab during that same time period, who had no connection to the daycare outbreak, but who had matching whole genome sequences. So in this case, again, these groups work together. We did identify that there were 4 of the 11 cases had a connection to uninspected beef. 2 relatives in separate households had consumed beef that was purchased from a private supplier. Both of those people tested positive, again, with this whole genome sequence match, and a piece of leftover beef from that meal also tested positive. There were 2 other relatives who responded to a local advertisement and purchased and then handled or consumed uninspected beef. So as part of the response to the outbreak, as mentioned, the government of Alberta established a food safety and licensed facility-based childcare review panel that included a diverse array of food safety, public health professionals, early learning and childcare professionals, affected family members, and the members of the public. They issued 12 recommendations under these 3 themes, including fostering a culture of food safety that supports high quality, safe and healthy learning environments for children, enhance public policy and legislation and inspection systems, and system alignment and integration. I encourage anyone interested to review their really excellent report that's available on the Government of Alberta website. And finally, just overall lessons learned, responding to an outbreak truly is a team sport. Again, the work between the clinical teams, the lab, public health teams, public health inspectors, and an enormous number of people across AHS who pulled together to work on this outbreak was truly astounding. The public health inspectors were just awarded the Canadian Institute of Public Health Inspectors Fortitude Award this week for their really outstanding service in support of this outbreak. Other lesson learned, central kitchens, which again are a fairly new phenomenon at the size that we're seeing, serving such a large number of daycares, increase the risk of large outbreaks by virtue of the sheer number of people they serve and the need for them to transport food. Attendance records and menu type can be an excellent proxy for food histories when investigating outbreaks in daycares. And in this outbreak, both vegan and regular meals were contaminated during the same meal, most likely due to cross-contamination from introduction of contaminated beef or an infected food handler. And finally, a source of uninspected beef contaminated with a sugar toxin-producing E. coli strain was being distributed in Alberta at the same time as this outbreak that genetically matched the E. coli strain that caused this large outbreak. And again, addressing the supply and distribution of uninspected meat is definitely part of the recommendations from the panel review. And I'll end there. Sorry, one last slide. Again, this slide was shared from Dr. Mark Joffe, many of you know as our current Chief Medical Officer of Health in Alberta. Again, this came from a brochure from a subsequent daycare that was in fact experiencing an STEC outbreak this summer. So again, a little bit ironic, the advertising in their brochure.
Thank you very much, Laura. Fascinating and terrifying all at the same time. So let's switch gears and introduce Celine Nadon. Celine is a director at Canada's National Microbiology Laboratory and adjunct professor in the Department of Medical Microbiology and Infectious Diseases at the Max Rady College of Medicine. Her area of specialty is enteric diseases caused by bacterial pathogens. A perfect dovetail from Laura's presentation. Celine's presentation is entitled Foodborne Disease Outbreaks, Successes and Challenges, 20 Years of PulseNet Canada. Celine.
Thanks very much. So today I'm going to be telling you about how we detect and investigate outbreaks of foodborne disease from a national perspective. So a bit of a broader lens than what we just heard about the daycare outbreak. And we do that using lab data. There was a teaser in the previous talk about the whole genome sequencing, using a system called PulseNet Canada that's been operating across the country for over 20 years, almost 25 years actually. I'm just going to advance my slide. I hope that is advancing for you as well. So the outbreak that we heard about in the daycare is a scenario where there was a lot of cases happening at the same time in the same location. When we talk about outbreaks that happen at the national scale or internationally, that's often not the case. We have a different outbreak paradigm where the cases are very widely distributed across the country, across many countries, and in any single place, there might only be one or maybe two cases occurring. So that one or two cases isn't going to raise a red flag or trigger an outbreak investigation in that location. So we need another tool to be able to connect the dots across all the different locations that there could be a widely distributed outbreak happening. And this is not a trivial problem in Canada. There's millions of these infections every year. Many of them are mild or self-limiting, but a number of them are quite severe, require hospitalization, and lead to death. These infections are caused by a whole variety of microorganisms, bacteria, viruses, parasites. Today, I'm going to be focusing on the most common bacterial causes like Listeria, Salmonella, and E. coli. This is a widely shared image that really describes how we are now in a new outbreak paradigm where instead of the classic scenario of like the church picnic or everybody who went to the same wedding reception got sick as a classic outbreak scenario, those still happen. But what we are now dealing with are widely distributed outbreaks that are largely a reflection of our food distribution around the world, where you have a multi-component food product like the salad, where the ingredients in that food product could come from a huge number of countries. This makes it very difficult to investigate the actual source of the contamination and the tracebacks, but it also makes it possible for cases to occur almost anywhere. So let's go back in time about 30 years to the early 1990s, where that's the first time we really started to see this shift in outbreak paradigm from that classical way to this distributed large way. So the clip in color on the left is relating to an outbreak of listeriosis that happened in the US across many different states. There was over 100 cases and I think 18 people died. And the other clips are relating to an outbreak of E. coli 157 associated with undercooked hamburgers at a US fast food chain in the Western states. Hundreds of cases and quite a few children died in that outbreak. Now, at that time in the 90s, we didn't have the tools to be able to connect these cases that were happening in different locations. So like the Listeria outbreak went on for a year before it was really flagged that something was even happening. And the E. coli outbreak, well, there were hundreds of cases and almost 3 months went by before a flag was raised that there was a massive problem going on. Now in Canada at around the same time, we had a massive outbreak of E. coli associated with water supply in Walkerton, Ontario, infecting over 2,000 people, killing seven. And what these outbreaks did in North America at the time is really cast a very bright light on these diseases, but also illuminated a changing paradigm for what these outbreaks can look like. It also put a big rush on scientists to develop tools to be able to link cases that were happening in a very widespread way. And so that is exactly what we did. This is a picture of the technology that was available in the 90s to do this type of test. So in addition to taking the food histories, interviewing the patients to find out what they ate, what they had in common, the idea was to then examine the bacteria making the people sick itself. So if you have someone in Vancouver diagnosed with E. coli, someone in Winnipeg also diagnosed with E. coli, if the DNA from those two different E. colis are the same, that's a big flag that those two people, even though they're 1,800 kilometers apart, got sick from eating the same thing. And basically, this was the technology pulse field gel electrophoresis that you extract the DNA from the bacteria, chop it up into pieces, and then separate those pieces by size. And that's what we're looking at here, where each column is the DNA fingerprint from different people sick with E. coli. If the patterns of these fragments are the same, there's your clue that people got sick from the same source. Then if you can find that same pattern in E. coli from a food product, well, there's your smoking gun that was the source of the outbreak. The tricky thing was that in order for this to work, every single lab had to use the exact same method in order to be able to compare these patterns. And because of the intense focus on these diseases at that time, every lab in the world was developing a method like this. And of course, every lab thought that their method was the best one. So the National Microbiology Lab got together with all of the provincial public health labs, including CADM here in Manitoba, so that we all could agree on a single method so that we could have results that could be directly compared to each other. That's exactly what we did. Starting in around 2001, the provinces began performing this test in their cases of E. coli, and they would upload those to the National Microbiology Lab, where we were just analyzing these all day long to compare and detect outbreaks with as few as 2 cases. We also brought in the Canadian Food Inspection Agency and Health Canada to compare pathogens from the food products that they were monitoring. We also worked very closely with the United States CDC to make sure that results that were happening in Canada were comparable to what was happening in the US, because as you can imagine, many outbreaks span both sides of the border. We also worked internationally to be able to track outbreaks that were happening anywhere. And we grew a consortium of countries, which now sits at 90 countries that participate in PulseNet International. And you can imagine that, getting this many countries to agree on a method was no small feat. And Canada has participated in this international group since the start in 2005, and we've actually been the co-chair of this committee for a number of years. So that was the PFG era, and we had many good years where we used the PFG method to detect and investigate widely distributed outbreaks across Canada and the world, including this one that is listed here, an outbreak of listeriosis that happened in the summer of 2008. That was tied to ready-to-eat deli meats. There was 57 cases, almost half of them died, and the cost of that outbreak is estimated to be at least $242 million. There are many hundreds of other outbreaks that we detected and investigated using this technology in this era. Then moving forward into the 2010s, things started to shift a little bit, where we thought, we might need to make another change. A couple of things that were happening. First, there was some outbreaks where the lab data wasn't completely making sense. On the left is an outbreak of salmonella that was associated with sprouted chia seed powder. And the PFG results were telling us which cases should have been related to the outbreak. But it wasn't really lining up with the people who actually ate the chia seed powder. Similarly, there was an outbreak of listeria mostly in the US, where using the PFGE technique, it looked like the outbreak was caused by hot dogs because a matching listeria was isolated from hot dog from a patient's fridge in Texas, but that turned out to be wrong. I'll come back to that. What was also happening at the same time was the development of genomics. With the advancement of technologies, we could do a lot better than just chopping up the DNA and comparing the sizes to get an estimate of relatedness. Whole genome sequencing allowed us to actually determine the A's, C's, T's, and G's, the sequence of the genetic code itself, to get a much clearer picture of actual relatedness. The first time the National Microbiology Lab really used this technique was to investigate an outbreak of cholera in Haiti. If you recall, in 2010, there was a large earthquake in Haiti that killed 200,000 people. And then the months after the earthquake, they were also struck by an outbreak of cholera that killed another 10,000 people. So the NML was part of the international team that used genomics and the bioinformatics methods that had been developed here to investigate the source of the cholera, because it had not been endemic to Haiti at that time. we thought, well, let's take those newer techniques and apply it to these outbreaks that don't really make sense. When we did that, a light went on, and they made a lot more sense. With this chia outbreak, we could clearly see that whole genome sequencing ruled out cases that did not eat the powder. And with the listeria outbreak, whole genome sequencing revealed that the hot dog situation wasn't related to this at all. It wasn't even part of the outbreak. The outbreak was actually caused by caramel apples, a food product that no one would have thought of, that had not been previously associated with listeriosis at all. It was at this time that we knew we have to overhaul our entire system to genomics to ensure we're getting the best, most accurate results. If we look at how bacteria are classified, starting in the top left is the broadest, lowest resolution classification, class, order, family, where we're more familiar, maybe genus and species, and then with increasing resolution as you move to the right and down. Now, you might be familiar with a technique like serotyping. Well, that places the resolution somewhere here in the middle of the purple. With the PFGE technique that we were very successful with for many years, that put us over here in the blue. Well, with whole genome sequencing, we were looking at a resolution way down here in the brown. So it would be no surprise to us that this increase in resolution would actually have an impact on public health. But we knew that we had to overhaul the entire system at the same time. Everybody had to, all the labs, provincial public health labs, would have to change at the same time. If we had some parts of Canada that were using the old technique and some parts that were using the newer genomics, we would end up with a mess of incompatible results. So we worked together as a network, and over a couple of years did the validation, the accreditation, the training, and acquired new equipment. And then we made the switch in 2017, starting with salmonella, switched over the entire network. Lo and behold, when we did that, within a few weeks, we started seeing a huge difference. We were detecting so many more outbreaks of Salmonella enteritidis. These outbreaks were leading to a multitude of recalls, outbreak after outbreak, and like 18 different recalls, but all the same type of product, raw frozen breaded chicken products. This is the chicken burgers, chicken fingers, chicken strips, chicken nuggets, chicken shaped like dinosaurs, all the same types of products, which we had always suspected were a problem, but it wasn't until we had these genomic data that we had the proof that they were causing a large burden of illness. These genomic data fueled changes in national food safety policy, basically not allowing salmonella in these products anymore. And then what happened after that? Incidents, a year after that policy was implemented, incidents dropped by 22%. And we estimate that 25,000 illnesses were prevented to the tune of about $27 million. So that is the very practical impact of having really pushed to use the most high resolution methods in the lab. There's some other impacts that we found. We're increasing the number of outbreaks that we are detecting because genomics can link cases together more accurately. We're able to solve outbreaks more frequently. Some outbreaks are smaller in size. There's still many challenges though, because epidemiological data is collected a little bit differently in each of the provinces. So pulling that together at the national scale can be very challenging. And then of course, funding for all of this is always a challenge. But having done that in 2017 meant we had the infrastructure and the governance framework for full-scale genomic surveillance. And this is what was used to build Canada's COVID genomic surveillance program in 2020. The last thing I want to leave you with is this spectrum of food products that have been associated with major outbreaks in Canada just over the last couple of years. Because if you find you make assumptions on what you think is making people sick, I would caution you to think again and have a look at the types of products that are causing major outbreaks across this country. Corn, onions, peaches, frozen cream puffs, shellfish, of course, romaine lettuce, other bag salads, fresh fruit, cantaloupe, kimchi, some chocolate, and you probably heard about the large listeriosis outbreak associated with a new type of product, the plant-based milks that happened this summer, tahini, the traditional things you might think of, like beef and chicken. Also, if you recall, there was a big shortage of infant formula in Canada in 2022. That's because there was an outbreak of Helicobacter in the US that killed 2 infants. And the shortage was caused by the closure of the plant where the problem was. These pathogens are also zoonotic, can be transmitted to and from animals. We also have a large number of outbreaks that are happening with pets. You might have heard of the association of salmonella with turtles. It's not just turtles. Outbreaks associated with dogs that are fed raw food diets, pet snakes, as well as the rodents that are fed to the snakes, pet hedgehogs, the pig ear treats that are fed to dogs, pet geckos that's happening right now. Also, many of these outbreaks are involve strains that are multi-drug resistant or extensively drug resistant. Also, lots of cases that are as a result of international travel and sexually transmitted enteric infections, as well as community-acquired infections, especially in populations experiencing homelessness. So there's a wide variety of sources. It might not just be the potato salad that you think. And my final slide. So lots of successes. The biggest one, of course, is being able to demonstrate that these lab techniques have prevented illnesses and deaths in Canada, that we were able to successfully pivot from molecular to genomic techniques in a large distributed network across the whole country. Some of the challenges we have right now are, of course, the emerging pathogens and new food combinations. It's always something different. We're dealing with that new outbreak paradigm that sees widely distributed cases and zoonotic infections. Some of the things that we'll be facing in the future are the impact of climate change. We're already seeing some of that with increases in things like Vibrio, and also facing the challenge of culture-independent diagnostic tests, because everything that I described in this public health system relies on having an isolate to generate a sequence from. And so we're looking at new scientific techniques that can bridge that gap when there is no culture. I'll stop there. Thanks very much.
Thank you very much. That I think that puts an end to any kind of eating. I think we'll just grow our own and live in our basements. That was moderately terrifying, but a phenomenal presentation. So allow me to welcome Dr. Jared Bullard, also someone who is well known to this group. Jared is a professor and professor of pediatrics and infectious diseases and section head of pediatric infectious diseases. He's also the Director General of Medical and Scientific Affairs at the National Microbiology Laboratory. Jared looks forward to walking us through a case of invasive group A streptococcus from bedside to high-level public health, I guess, investigation and interventions. Jared, thank you very much.
All right, always a pleasure to come to Bug Day. It feels like coming home. It's once a year. It's always fun, and it's actually, this presentation is going to build on what Celine and Laura already have had to say. I just want to make sure that you're seeing the presentation itself and not the presenter mode. So Celine, could you let me know if that's what you're seeing?
We see the presenter mode.
Yeah. Okay, let's whip that around then. Better?
Yes. Yes. Yeah.
Wonderful. Perfect. Okay, so as John talked about, we're going to talk about invasive group A streptococcus disease because it's a phenomenon that impacts us here in Manitoba and, of course, all the way across Canada. Always have to start with your conflicts of interest. At this point, I do not have a relevant conflict of interest to declare. And the objectives are pretty straightforward. I'm going to try to walk you through what we would see at the bedside, how that happens based on what group A strep does, what's happening on a population level, and then also how whole genome sequencing and genomic analysis is really changing the way that we're able to evaluate what's going on from bedside all the way to public health at the national level. So let's start with a pretty basic case. And so this is relevant to practitioners and parents alike, in that you have this 4-year-old girl who comes to clinic with a pretty typical story. So she has 24 hours of a sore throat. She's not liking to eat anything, especially crackers, which she loves. She has a fever of 39 degrees and she doesn't look particularly well. When you look in her throat, it's red. It's got some purulent material there as well. Her gland seems swollen. And so overall, you feel that, this is probably going to be strep throat, although we appreciate that kids get all sorts of viruses which look very similar clinically. What I like about this slide is that Microsoft Teams AI decided that kidneys are the appropriate symbol for taking a throat swab. I'm not sure why, but that's okay. Regardless, you get that done. You send it for rapid antigen testing in the clinic, and you also send a concurrent culture and sensitivity because there could be other things at play as well. A prescription for amoxicillin is provided, and follow-up is arranged in 2 days to talk about the results of those swabs, especially the culture, and then give advice further if you need to go on to antibiotics. So a useful pearl is really when we look at this basic throat swab. So in clinic, I think we have seen a lot more use of rapid antigen tests. And that's great because, you're getting information right there at the bedside and people are very familiar with this, particularly after COVID. And so it's a good technology. It's very specific, meaning that if you see a result, it probably really is group-based strep, but its sensitivity is a bit of an issue with somewhere between 60 to 70%. What can make this more difficult to interpret is that, as I mentioned, some kids, of course, are going to have viruses, and there's also a significant number of kids, anywhere between 5 to 20%, that are going to be colonized with group-based strep, so it might not actually be what's causing the pharyngitis per se. The culture is very sensitive and very specific, and it gives you a bit more information in that you're able to get susceptibilities from it. And you're also able to see if there's something else that isn't group-based strep that you can grow on a routine bacterial culture that might be causing the pharyngitis as well, which of course leads us into the final one, which is talking about molecular analysis. So there are some more simple, straightforward ones. There's also whole genome sequencing, which falls into that category. A very sensitive and specific technique to be certain. So what can group-based strep infections look like? They can be pretty typical. We already just talked about pharyngitis, which is a fairly common one, but you can also see skin infections. And so sometimes that's things like cellulitis, erysipelas, or impetigo. Now, that's when the bacteria itself is crawling into the skin or the throat and the tissues, and it's causing a pretty mild infection. But it's also able to produce toxins, and the toxins themselves can cause a disease as well. So the example of that might be scarlet fever that we see in younger children as well. Sometimes you will have an invasive infection. And so what that means is the group-based strep is now into the tissues or spaces where it shouldn't be. So in the case of sepsis, it could be in the bloodstream. In the case of pneumonia, it's in the pleural fluids and secretions, or it's showing up in the joints. So you might have a septic arthritis or a bone infection. If you see it in the central nervous system, and you have a meningitis, that's a problem. And again, you might see this synergy where you have toxin from the bug and the bug itself all causing sorts of problems. So toxic shock syndrome would be a really classic example of that, as would necrotizing fasciitis. And what they have in common is a super antigen. So in addition to all the problems the bacteria is causing, your immune system is hyper ramped up non-specifically, and it really doesn't know how to calm down. So a significant amount of damage can be done. So let's take that same 4-year-old who's now going to the emergency department because the pharyngitis is getting worse to the point where she's having hoarseness. So the voice sounds different. And then her parents have also noticed that she has intermittent stridor, meaning that when she's taking a breath in, you can kind of hear that a lot more audibly than you'd expect. Her fever is a little bit more significant and her blood pressure is low, along with a heart rate that's trying to compensate. So I think right away you would recognize this child is quite sick. And as a result, they are intubated, they're given some fluids as well as some blood pressure supporting medications, and they're admitted to the PICU because you have to monitor the situation quite closely. Now, you know already from the rapid test that, this is likely group-based strep, and so you start a combination of penicillin as well as clindamycin. And fortunately, they did take cultures prior to starting this, and she hadn't started the amoxicillin that she had at home. And you also give intravenous immune globulin because you're concerned about the very pro-inflammatory state that's going on. And sure enough, the blood culture comes back within 12 hours, showing gram-positive cocci in chains, as you can see in the picture there. And this is ultimately identified as Streptococcus pyogenes. And so this is a scenario that's not unusual for us to have seen in the past respiratory virus season, so like November to January. A number of my colleagues and I have talked about that these are among the sickest kids that we've ever seen, and it particularly relates to, I think, a lot of the viral activity that we were seeing as well. So what antibiotics work best on group A strep? So this is a fun consult that we often get in infectious diseases that are sitting there for 3 days or waiting for susceptibility of group A strep to come back, and it hasn't. What should we use? So fortunately, we do have a lot of data on this, and we know that penicillin is 100% susceptible. And that implies not just penicillin, it can be amoxicillin, it could be piptazo if you're feeling saucy, meropenem. So any of those beta-lactams or even cephalosporins will all have really good activity against this and kill the bug effectively. Vancomycin, it is a shotgun approach, but it is also 100% susceptible. Now, when we look at the antibiogram data, which is produced by our own microbiology colleagues over at HSC, including Andrew Watke, whose birthday it is today, so happy birthday, Andrew Watke. The clindamycin susceptibility is about 80%. And so that can be different depending on what sources you're looking at, and that can sometimes be as low as 4 or 5%. The benefit of clindamycin and other ribosome-specific antibiotics like linezolid is that it can help shut down this toxin production and in theory work a bit faster. And that was something we actually noticed as well this past respiratory virus season, that even with the clindamycin addition and the IVIG, these kids were sicker longer than we were expecting. So what have we seen in Manitoba? For the most part, we were seeing an increase after the pandemic. And so you can see that overall the cases were about 12 per 100,000 population. But I really want to point out what the mortality rate. So what is the likelihood of a child with invasive group A strep or someone with invasive group A strep dying? It's significant. It's almost 10%, and it's highly likely they're going to be in hospital. And you can see that that ranged across the past 5-6 years of as low as 4.2%, but then almost as high as 11. So it's a serious disease. That's why I think we really have to monitor it quite closely. So we do have additional data when we work together across the country to help say, okay, we're seeing this here locally. What are you seeing in BC or Ontario or in Prince Edward Island? And so we do have data that comes in, and you can see a couple of things here that overall, it seems like the rate of invasive group A strep disease is increasing, and in particular in our older population. I think the second important thing you can see in this slide is that it affects primarily the extremes of age. So if we have infants all under the age of 1 year, they're more likely to have this disease overall. And then again, when we get to older, and it looks like I'm actually almost falling into that older category now too, that we might also see increased disease. Now, you already heard Celine talking about the national lab and the work and collaboration that's going on. And so fortunately, we've been looking at streptococcal disease for a while now with the eStrep program. And so it's not exclusive to Streptococcus pyogenes or group A strep. It does include group B strep and pneumococcus as well. And we're looking at different trends in terms of serotype, M-type, and also antimicrobial resistant. And like with the foodborne illnesses, it's to help support outbreak investigations because they may be a little more challenging to figure out exactly where that's coming from. But just as important, whole genome sequencing and genomic analysis is really integral to help inform what we do with vaccine development and also help develop treatment guidelines. I was alluding to that these kids were sicker. So what if the reason was that the toxin is different enough that the antibodies that exist in the general population just aren't enough to really take care of that? It might be that we can develop monoclonal antibodies to help tailor or help to modify disease. So fortunately, we have this collaborative effort where all the isolates, not all, but a significant portion are sent to the NML. And at the NML, we're doing a variety of different tests, including molecular analysis and microbial, antimicrobial resistance as well. And you can see that one of the most important things we can do if we're producing this information is have it be actionable. You have to be able to do something with it. And so I think that we're pretty good at producing reports which are valuable to our end users. Sometimes when you look at whole genome sequencing, you kind of eyes start to water because that's a lot of data. But that data is integral for a variety of reasons. And I think that Celine really highlighted most of those. When it comes to group-based strep specifically, the M type and the toxins that are being produced are very valuable information to obtain. MLST is, like Celine was saying, it's not quite as high fidelity as you would get from a whole genome sequencing. And then from an AMR, antimicrobial resistance perspective, invasive group-based strep, we don't really have or use that as much as we would for some of the other streptococcus. From an outbreak support perspective, it makes sense. We're better able to determine linkages between cases based on the isolates that we get from those patients. When we look at kind of the annual breakdown, what should stand out to you here is that we had a little brief hiatus of strep pyogenes isolates during the pandemic years, and then in 2023 and 24, we're seeing that that's coming right back up. And that likely has to do, again, with a whole bunch of H1N1 influenza activity in the year preceding. And then likewise, we also have increased group-based strep activity a lot in kids, which is exactly what we saw. In fact, that was one of the highest levels that I can recall in my clinical practice. In fact, this entire graph is my clinical practice so far. This is just highlighting that once again, that overall we are expecting that in 2024, we are going to have probably the same amount of invasive group-based strep isolates. So activity is increasing, and that's why it's important to have this collaboration and effort to really figure out why that is happening. So one of the answers comes from this. So when we look at the M type, which is the way that we characterize group-based strep, we can see that traditionally it was a lot more M49, M12, but over the past couple of years, what we've seen is M1 taking over both in children and adults. And this largely relates to the introduction of something that's called M1UK lineage. So why is that relevant? So imagine that you have a group-based strep M protein that's different, and it actually is more successful at causing disease, and disease that is worse. And so that's why we're seeing the M1 take over, because the M1 UK lineage is what's ultimately replacing that, the other two that have been in place for a while. So in summary, you can see that routine M typing is very helpful from whole genome sequencing. It does replace the Sanger sequencing along with your CDs and videotapes from VHS. And it does have a faster turnaround time than it used to be as well, although Sanger still is a little bit quicker. So we can see that overall the rates are increasing. M1 and M12 are both quite common, with M1 coming back with a vengeance. I do like Irene's phrase there. But it's also important to make sure we establish enhanced surveillance of invasive group-based strep, because we really want to make sure that we're figuring out, well, yeah, it's nice to have this on the isolates, and we know that overall cases are increasing. But from a clinical perspective, what does that mean? And so these are going to be the next steps. So we have PICNIC and IMPACT. So PICNIC will actually be looking at invasive group-based strep clinical findings, and we'll be able to link it to whole genome sequencing over the past 10 years. So a retrospective study, whereas IMPACT going forward will be looking at the same thing and gathering the information in a prospective manner. So I would like to take the time to acknowledge all the people across the country who've been providing this information and isolates to us, and all the work done here at NML and Irene Martin in particular. And then hopefully we've achieved these objectives. And in closing, this is a picture from my vacation in Iceland. So my wife was very excited to say, hey, do you want to climb up a mountain in first thing in the morning when it's rain pelting you in the face and it's freezing on the path and there's a likelihood you'll die going back down? You can see I wasn't impressed, but she was thrilled. Man, that woman was thrilled. Anyway, thank you for your time, and I look forward to any questions you might have.
Thank you very much, Jared. Let's jump into the questions. Some absolutely phenomenal questions came in. So one of the questions is, do you investigate how foods become contaminated in the first place? E. coli and salmonella are found in animal waste. Are vegetables becoming contaminated by animal waste from nearby farms? If so, what can we do about this? So I guess that's I think that's a tag team question for Celine and Laura.
I can start with absolutely that's investigated. We have surveillance systems that are targeting the full farm to fork safety spectrum in order to determine best intervene. It's a big area of food safety investigations in the Food Inspection Agency, other government agencies as well. There is some thought with animals being the reservoir, like cattle and other ruminants are reservoir 157, and other animals are the reservoir types of salmonella. That sometimes land use, these food safety problems are a land use problem where proximity of feed operations to produce and other types of plant-based foods, that's how they are becoming contaminated. So that's a big yes from my perspective. Laura?
Thanks, Lynn. Yeah, I would absolutely agree. And I think, you know, that really is the concept behind the One Health approach of working together with our agriculture and other partners on that upstream side of things, and really coming together with, you know, good planning around that surveillance work. And again, planning for land use and really anticipating all of those opportunities for contamination, trying to, you know, separate those risks where possible, and then working together very quickly to intervene when you know, signals arise that contamination has happened. So I think great comment too.
I recently read a report. So I recently read a report about meat from either offshore or other parts of North America making its way into our own ground beef, which is moderately terrifying because we think we know what we're doing, but we're introducing all these new variables. Does that play a role in foodborne illnesses?
Again, yeah, you go ahead, Celine.
I was going to say likely not really. Any sorts of ground beef can be contaminated, but every country imports food products. I can't speak on behalf of the Canadian Food Inspection Agency and how the rules are around importation of foods, but there are very strict safety standards that to import, you have to meet the same safety standards as Canada does. So unless it's an uninspected illegal source, I would say that the likelihood is just the same as our domestic.
Thank you. Next question, and this is a Laura question. Do you believe the central kitchen facility was using uninspected beef? Was the facility investigated for this possibility?
Yeah, fantastic question. We really tried hard to answer that question. You know, we really came down to 3 theories of what happened. One was uninspected meat from that known source had found its way into the kitchen. A second one was that there was some other product that was being used in both the vegan meatloaf and vegan loaf and the meatloaf. Or third, that there was a food handler who had been infected, you know, by accessing that same food source out in the community that had the circulating source from. We tried hard to identify and find any clues at all that the kitchen was using uninspected beef. Their records, and CFIA worked with us on this, matched well enough in terms of their receipts and their records of meat purchase, including the recent delivery that had occurred just the day before the beef meatloaf had been prepared. There was also a lot of effort undertaken with the kitchen staff to identify, you know, again, there was a number of infections among the kitchen staff, trying to time and date those and identify, were they, again, the victims of infection from within the kitchen, or might they have been the source within the kitchen? Despite a lot of effort, it just was not possible to tease those possibilities out.
Thank you. One last question for Jared Bullard. Jared, has the virulence of Group A Streptococcus changed is it, or is what we're seeing just more group A streptococcus in the post-pandemic era?
So it's a combination of both, right? So what we're seeing is overall more cases of invasive group-based strep. And certainly from Manitoba perspective, we saw that both in our pediatric population, but also to some degree in our younger adult population as well. And in addition, I was pointing out that M1 UK variant that we were seeing from a streptococcus perspective. And so that is more virulent. It is more likely to cause disease. And so more severe disease, more cases. So I think that's the combination coming together just to make it that that's what we're observing.
Thank you very much. Well, that rounds out this session. Thank you to all our speakers. I'd like to now introduce Dr. Heinz Feldman, who I'm not sure where Heinz is right now. I think he's somewhere in Europe. Heinz is the chief of the Laboratory of Virology and the chief scientist at the Level 4 Biosafety Laboratory at the Rocky Mountain Laboratories Division of Intramural Research, National Institutes of Allergy and Infectious Diseases, National Institutes of Health in the United States. His field of expertise is emerging pathogens with a focus on high containment viruses. And Heinz is going to give us an overview of the global impact of viral hemorrhagic fever viruses. Heinz, the floor is yours.
John, can you hear me?
Perfectly, thank you.
I'm just trying to, can you see the?
If you go to the slideshow mode on the bottom, you're almost there, keep going. There it is. No, next one. There we go, perfect.
Okay, well, you were asking where I am. I'm in a hotel room, so I apologize for the background. It's not my choice. In Italy, I'm trying to make the best out of it. I had some trouble to get hooked up, but I hope it's working. You asked me to talk about the global impact of viral hemorrhagic fever viruses, and interestingly, we currently have an outbreak of Marburg virus disease in Rwanda, as some or most of you know. So it's again a hot topic at this point. If you look at the viral hemorrhagic fever in more general, I lost my screen. Can you still see this?
Yeah, we can see your screen. Yeah, it's all good.
Okay. If you look at viral hemorrhagic fevers, fever viruses in more general terms, they cause an acute viral syndrome. They usually benign, begins with a non-specific illness that is very difficult to distinguish from other febrile diseases. The pathogenic hallmarks are increased capillary permeability, impaired coagulation, and systemic inflammatory response syndrome. Case fatality rates can be very high, but vary quite a bit depending upon virus. They also vary within a given virus, depending on the status of the patient. So that is very difficult to pin down. But Ebola can go up to 90%, as most of the people know. Deaths usually from shock and multi-system failure. And interestingly, which a lot of people think is the cause of death, hemorrhages are not seen and are only seen in the minority of the cases, and they're not usually large in volume. If you look at the pathogens themselves, they're all small RNA viruses. They come from the families. Taxonomy is changing all the time. So these are all either arenaviruses, bunyaviruses, filoviruses, flaviviruses, or paramyxoviruses. They're negative, positive strand RNA viruses, and some of them have an ambisense replication strategy to express additional proteins from usually a very small genome. There are envelope viruses, and in general, very fragile in the environment and against disinfectants. Collectively, they are found worldwide, but geographic distribution of specific viruses depends on the distribution of the reservoir. Almost all of them are zoonoses, and often there is a very specific virus reservoir or virus vector pairing. The reservoirs are usually not overtly ill, and maintenance in nature in the reservoir happens through vertical, horizontal, or mixed transmission. Many of these pathogens are high containment pathogens, so they need biocontainment level 3, 3+, or 4. And in the US, a lot of them are category A select agents listed and overseen by the CDC in Atlanta, the Select Agent Program. Looking at the vectors of the different viral hemorrhagic fevers, starting with the filoviridae. So these are Ebola viruses, Marburg viruses. They're different Ebola viruses. Nowadays, we believe the reservoir are different bat species. Even so, for Ebola, that has never been really documented. For Marburg virus, however, it did. If you look at the arenaviridae, this is Lassa, Lujo in Africa, and then there are these South American arenaviruses. They all have rodents, different rodent species as their reservoirs. Crimean Congo is a Bunya virus, belongs to the Nairoviridae family, is transmitted by ticks, and has multiple vertebrate intermediate hosts and reservoirs. The Hantaviridae, the different hantaviruses causing hemorrhagic fever with renal syndrome, or hantavirus pulmonary syndrome, or cardiopulmonary syndrome. They usually have rodents as their reservoirs, but there are hantaviruses that can be found in shrews and bats, but none of them has been associated with human disease so far today. Rift Valley fever, reservoirs mosquitoes and vectors the mosquitoes and certain vertebrates. Yellow fever, mosquitoes and monkeys. Dengue, mosquitoes and humans. Chiassenur forest disease and Omsk hemorrhagic fever. These are all flaviviruses, ticks, and certain vertebrate hosts. I think paramyxoviridae, hantavirus, and Nipah viruses are also viral hemorrhagic fevers. The literature goes back and forth on that, and those can be found in bats, and livestock can serve as intermediate and amplifying hosts. If you look at the general distribution, I know this slide is very busy, but there are some, such as dengue, yellow fever, CCHF, and the hantaviruses that have a very broad distribution. For example, CCHF is the most widely distributed tick-borne viral hemorrhagic fever. Dengue, I don't really have to introduce here, but some are very focal. For example, Omsk hemorrhagic fever, Chiassenur forest disease virus, or Alcumra virus, which are found in very specific geographic locations. These are flaviviruses causing viral hemorrhagic fever. Many of these are listed as priority pathogens by WHO and also by the NIAID. So they are important pathogens for public health response and emergency response. In terms of countermeasures, number one really is diagnostics. We have reference centers in each usually each country, and we have mobile field capacity to assist outbreak investigation. So diagnostics, early diagnostics, on-site diagnostics, very, very important to support treatment. The treatment is largely supportive, goes all the way up to intensive care unit approaches for the more severe forms of the viral hemorrhagic fevers. In terms of antivirals, there's not really much to offer. Ribavirin is being administered for cases of Lassa, so arenavirus viral hemorrhagic fevers, or bunyaviral associated hemorrhagic fevers, such as Crimean Congo hemorrhagic fever virus. But the effect is questionable, and you need very, very early administration, as you do with most of these antivirals. So diagnostics really become the key element also for treatment. Remdesivir is at experimental stage for philos as well as Henipaviruses. Favipiravir is at an experimental stage for arena and bunyaviruses. And then convalescent plasma, or much more important these days, monoclonal antibodies, are at experimental stages for many, if not all, of these viral hemorrhagic fever causing viruses. In terms of vaccines, we have different platforms these days. We have approved and licensed vaccines for yellow fever, dengue in clinical phases, being approved new vaccines, Junine virus, which is the South American hemorrhagic fever, Ebola, and there is a vaccine for Rift Valley fever, but not available for everybody. So a little bit of a question mark there. But many vaccine approaches for viral hemorrhagic fever pathogens are still at experimental stages these days. Very, very important for the response to viral hemorrhagic fevers are the animal models, because clinical trials are often difficult to set up and you know, in outbreaks such as filovirus outbreaks or arenavirus outbreaks, human clinical trials are very difficult to accomplish. We have reservoir models for these pathogens, and small and large animal models where we do the preclinical trials. These are either infection or disease models, depending on the virus and the different viruses. Intensive care, very, very important. Jim Strong from the National Microbiology Laboratory started intensive care for Ebola virus, modeling it in high containment. This is something that needs to be further supported in future years, because this is still one of the key elements to treat viral hemorrhagic fever patients in outbreak situations. Drug screening is intensified these days. It's either repurposing of licensed drugs, chemically modified compounds of licensed drugs, or the library screening of compound and drugs that then go from pre-experimental through in vitro analysis all the way to in vivo analysis, preclinical studies, before they then can be considered for clinical trials. On the vaccine side, I already mentioned the approved and licensed vaccines. We have experimental vaccines for Marburg, other philos. That's important currently in Rwanda. They're using one of those experimental vaccines in this outbreak. Lassa fever, other arenaviruses, Kaiser's forest disease, Omsk hemorrhagic fever, for some of the Hantas, and Crimean Congo hemorrhagic fever. The platforms that are widely used are either live attenuated vaccines, such as based on vesicular stomatitis virus or measles virus, replication deficient vaccines based on largely on adenoviruses, DNA vaccines, subunit vaccines, messenger RNA vaccines, and replicating RNA vaccines based on alpha virus replicon system. So overall, there has been a lot of progress addressing viral hemorrhagic fever pathogens in the past decade or 2 decades. But still, viral hemorrhagic fevers are an important public health problem, and there are many, many challenges. Looking from the public health point of view, we need advanced local and regional surveillance and preparedness, comprehensive regional and or global surveillance systems, online data sharing, and coordinated responses. On the preclinical research, we need the laboratory infrastructures. Many of them are containment pathogens, and that makes preclinical studies complicated and cumbersome. We need simple and immediate sharing of biological material, which is a big roadblock these days to fast response capabilities. We need pathogen identification and characterization. Animal models are still key elements of the response to viral hemorrhagic fevers these days, and we need preclinical countermeasure development. On the clinical trial side, we need infrastructure, development and establishment, countermeasures, fast tracking towards IND and licensure, and countermeasure logistics and implementation. And of course, for all of these, we need adequate and uncomplicated funding. So I want to stop here. I hope I gave you an overview on the status on viral hemorrhagic fevers. It is still a very specific field, but with high impact on public health and animal health. And the approach has to use the One Health approach, the approach to address viral hemorrhagic fevers. Many people have been working with me for and many others to address these over the years. The picture here shows our group at Rocky Mountain Laboratories, and in the bottom right corner you can see where the funding is coming from for these type of pathogens. It's the NIAID Division of Intramural Research and certain European programs, ZAPI, and then government programs in the US that we get our funding from. Thank you very much.
Thank you, Heinz. Stay around for the questions and answers in about half an hour. So thank you. We'll turn things over to Devinder Singh. Devinder will speak to us about respiratory syncytial virus, also known as RSV, vaccination. Another weapon in our armamentarium with a question mark on the end. So Devinder is a medical officer of health with Manitoba Health Seniors and Long-Term Care. He works provincially with Manitoba's immunization program and regionally with Southern Health, Sud. Devinder is also an assistant professor at the University of Manitoba in the Department of Community Health Sciences. Devinder, thank you for your presentation.
Great, thanks, John. Can you hear me and can you see the presentation?
We can see both you and the presentation.
Perfect. Okay, great. Thank you for the introduction. I don't have any conflicts of interest to declare. Going into the objectives, I'd like to describe the burden of disease caused by RSV in Canada. It describes the clinical data for the immunization products that are licensed for use in Canada for prophylaxis against RSV, and then review the National Advisory Committee on Immunization, I'll further refer to them as NACI, recommendations for the use of these products for the prevention of severe disease in adults and children. First, into the burden of disease. This data is taken from the Ontario surveillance data using their respiratory virus tool, looking back into last season. This is the burden of disease for RSV bed occupancy by age group in Ontario. In terms of incidence, you can see that the highest incidence of disease is in the 0 to 4 age group. It's not uniform in that age group. The highest burden of disease amongst them is under the 6-month stage, and then decreases as those children get older. And then next highest would be those 65 years of age and older. Granted, there's a lot more individuals over the age of 65 than from ages 0 to 4. So, in terms of absolute numbers, they do represent a significant number of people in these acute care beds in Ontario, and then much lower incidence among other age groups. However, compared to RSV compared to other respiratory respiratory viruses of importance that we look at each season. If we look to influenza, you can see that the burden of disease amongst those aged 0 to 4, is significantly higher for RSV than it is for influenza. But opposite to that, the burden of disease for influenza is significantly higher for those aged 65 years and older than it is for RSV for that age group. And then, following that trend, going one further, looking at SARS-CoV-2 or COVID-19, again, the burden of disease drops even further for those ages 0 to 4 for this virus, whereas for those age 60, the age groups are slightly different for this graph compared to the others, but for those age 65 plus, and especially 80 years and older, the incidence of COVID-19 far exceeds the other two viruses. We have to be careful when we look at the burden of disease for RSV for these populations, though, because most jurisdictions in Canada only report on associated disease with RSV. There's very few that actually distinguish between associated and attributable to or due to RSV. So Ontario is one of the few, and Alberta also reports on this distinction. And you can see that just between these two, the y-axis is the same. And so less than half of those hospitalizations that are associated with RSV are amongst those clinical care teams deemed to be due to RSV in Ontario. Onto the various immunization products. There's 3 products for the use of prophylaxis in infants that are licensed in Canada. The first is palivizumab, which is a monoclonal antibody product that's been around for the longest amount of time. It's relatively short-acting, which means that for those infants receiving prophylaxis, they need an injection of the monoclonal antibody every month during the course of the RSV season. Nirsevimab was significant advancement in technology of monoclonal antibodies for this prophylaxis of this group because it provided a longer duration of protection so that only one injection is needed to provide at least 5 months of protection, which would be ideally given at the start of or just before the start of the RSV season. And then the third product, which I'll go to in a moment in terms of the data, is the RSV pre-F vaccine. For those, the trade name for that would be Abrysvo, but I'll refer to it as RSV pre-F. And that is a maternal immunization strategy that provides active immunization of the parent and then transfer antibodies to the fetus and then provide passive protection of the infant for the first 6 months after birth. In terms of the efficacy of these products, I'll talk about efficacy because these data are from the randomized controlled trials. The nirsevimab had very high efficacy for the prevention of medically attended RSV, hospitalization, and ICU admission with 80 to 90% efficacy for these various outcomes. And I'll go into safety data later, but there were no significant safety concerns for this product. Real-world data has shown comparable effectiveness at matching these efficacy data for those jurisdictions that have implemented programs like Spain, other European countries, and then some data from the US as well. In terms of the RSV pre-F, so the maternal immunization strategy, the data also showed that this was an effective intervention, but the vaccine effectiveness compared to the effectiveness of the monoclonal antibody nirsevimab was lower for RSV pre-F, but still significant. So between 50 to 55% vaccine effectiveness for the prevention of medically attended RSV, respiratory tract infections, and hospitalization. There weren't enough outcomes to be able to stay with statistical certainty or statistical likelihood that that there was the prevention of ICU admissions. But again, just following from prevention of hospitalizations, one would assume that that would also prevent those needing to go to the ICU. 2 other outcomes here are highlighted. One is preterm births. There was non-significant but notable imbalance in higher preterm births after vaccine. This wasn't seen universally across the sites that were enrolled in the trial. It was mainly found in the sites in lower income countries in particular, but not in the higher income countries. So that was of note and it was important to follow after licensure. And then also the RSV vaccines are quite immunogenic. So there was a higher incidence of local, severe local adverse reactions. So that would be reactions like, for example, pain in someone's arm that would interfere with activities of daily living. So, they're rare, but still important clinically to note that that occurred. In terms of the efficacy of the interventions, the vaccines for older adults, we've got one is the same vaccine that's used for maternal immunization can also be used for older adults, and that showed 66% effectiveness for the prevention of medically attended RSV. There weren't enough outcomes of the severe events like hospitalization or ICU admission to be able to give more definitive vaccine effectiveness or efficacy for those outcomes. And as I mentioned, these tend to be quite immunogenic vaccines, so they noted significantly higher severe local adverse events. So again, things like pain in the arm that could interfere with activities of daily living. And then this is the other vaccine, RSV Pre-F3, also known as Arexvy in terms of the trade name of that. I'll keep referring to it as RSV Pre-F3 though. Vaccine effectiveness or efficacy, was 79%. And then again, it's quite an immunogenic vaccine. So, a number of local and systemic adverse events like fever, fatigue, things like that. One thing to note for the RSV vaccines in older adults, there was significantly lower efficacy during the second season compared to the efficacy during the first season for both of these vaccines. We don't have data published for season 3 because these are quite new vaccines, so we don't know if they maintain protection or continue to decrease their efficacy into that third year. Of particular interest was that the clinical trials did include an arm where an additional dose was given prior to that second season, and they did not notice any additional benefit in terms of the efficacy for those that received an additional dose in that second season compared to those who only received the one dose over those 2 seasons. So that was relatively unique in terms of the lack of a boosting effect for vaccine efficacy compared to many other vaccines as to what you would expect. So just something to note and to follow over time to see if there's any benefit or potential for any additional immunization for RSV in the future for those who have previously received a dose, or whether it's one dose and that's it for RSV vaccine protection for older adults. In terms of safety, I mentioned nirsevimab had no significant safety concerns. The RSV Pre-F, I mentioned the imbalance in the preterm births. So that a number of jurisdictions limited the indication to 32 to 36 weeks gestation to limit the possibility there. But again, it wasn't statistically significant. They noticed it in in a limited number of the vaccine trial sites. And then since the time of publishing the NACI statement and authorization, there have been one JAMA study from the US and then some aftermarket information from the US for their safety monitoring that has been reassuring, not seeing a higher number of preterm births in either of those, the publication or the surveillance data from the US. So both reassuring. In terms of adults, older adults, there was an imbalance of cases of Guillain-Barré syndrome and atrial fibrillation, not high enough of imbalance to confirm an association, but the aftermarket data in the US of Guillain-Barré syndrome has also noted a higher number, though extremely rare for Guillain-Barré syndrome in those older adults. So again, something to note, still, very rare adverse event, but of particular significance. terms of the NACI recommendations, NACI strongly recommends building towards a universal RSV immunization program. This is a virus that causes a very significant burden of disease in our infants, with prioritizing those at highest risk medically and those who are in remote locations where transportation, if they were to get severe disease, is more difficult or complex, or who have more structural determinants of health that put them at increased risk for either infection or severe disease. And then the second priority would be to build onto a universal program if the intervention was cost effective. Granted, the list price for these can be quite high, so that is a significant factor for programs. And in terms of the vaccine for maternal immunization, at that time that the statement came out, NACI didn't recommend a universal program for that, but they did say it could be considered on an individual basis. And that, the reasons for that were, there was still some more information that would be liked on the safety side. And also they did comment on some factors that may make it make sense to have that in a publicly funded program. So it's not like they strongly recommended against it. It was more like at the time of the statement, they couldn't recommend it, across the board. In terms of older adults, NACI strongly recommended individuals over the age of 75 get immunized against RSV, but particularly those at increased risk medically. One thing to note in that is that the cost effectiveness analysis did have a very significant distinction between those who were at medically higher risk and those who were at average risk, but between ages 75 to 79. So, for those that look at the cost effectiveness analysis, the cost per quality for that age group not at higher risk was over $1 million per quality. So, again, something to think about program-wise, but not necessarily at an individual person basis if you're talking to your patients or clients. And then for individuals 60 and over who are in personal care homes, which fortunately Manitoba and a number of other jurisdictions are implementing this year. NACI also supported co-administration of RSV with other adult vaccines. There's a little bit more complexity there in terms of, there's not co-administration data with anything other than influenza. And there was some signal with the influenza co-administration that noted that there could be decreased immunogenicity of the H3N2 strain in the vaccine with co-administration. So there's some caveats there, but the most important thing is, to immunize if you're going to immunize before the season starts. So it's permissive for co-administration. And then, there's currently no recommendations to administer a second dose for those who already received a dose. So again, I talked about the limited data in terms of the number of seasons of data and also the lack of boosting effect that they saw for season 2. So something to continue to follow. These were the multiple choice questions that I included in the program, and for those who want to check their answers when they go through, those highlighted are the answers, and hopefully you'll feel that I've gone over, accomplished these objectives, and I just want to thank everyone. Thank you.
Thank you very much, Devinder. We'll switch gears and welcome Sean Shore to present Immunize Yourself from Cyber Threats with this vaccine. Although not truly a microbe, we are facing nonstop threats by hackers and scoundrels. Sean is a practicing lawyer at Canadian Compliance and Regulatory Law, where he represents all categories of registrants in the Canadian investment industry, which includes providing tactical and strategic advice to firms on managing their ongoing cybersecurity obligations. Sean.
You hear me okay and see these slides, John?
Perfect.
Great. So thank you very much for that kind introduction, and we'll dive right in. Thank you for the presenters before me. That was quite interesting information, which I think I'm going to touch on briefly and link to this presentation. So today we're going to have, this is our agenda, and we'll go through these items. We're going to talk about what's current in my world and just some background on what we do at the firm. We represent registrants in the Canadian investment industry, and all of whom are required to have a process towards managing cybersecurity risk, which is old hat already. This has been in place for almost 10 years. And so part of what we're talking about here today is directly related to what financial services providers deal with, I would say, at least daily. So what's good for them, my thesis, what's good for them is good for other enterprises like hospitals, critical infrastructure providers, and so on. And it's also good for us in our day-to-day life, as I refer to myself as a civilian. So as civilians, these are words that we need to live by. So we're going to talk about what's current in terms of threats. What can we do to help ourselves not be victims? If the worst does happen, if disaster strikes, how do we manage that breach? And then there are some regulatory and insurance issues that we often deal with. So diving right in, just in terms of introductions, what is at stake here? Well, it's absolutely everything. And I really do mean that. I'm trying not to be dramatic about this, but patient data, anything sensitive information, and more recently, the disruption of the operation and functioning of critical infrastructure, which might relate to power supply, patient scheduling, and generally what I call chaos. And we've had clients throughout the industry, we've observed them get into hot water with these issues, and it is truly chaos, and that's what we're trying to avoid. Now, one of the themes that I'll mention throughout is that we need to understand that those who are seeking to implement this chaos, they are this is a business for them. And so they are here to make money, and the target is irrelevant. It is the question of what do we possess of value that can be used by them for something else, and can that be sold? So in the case of us as civilians, your personal information, data, currency, obviously, and loyalty points. If you're a member, if you use your app on your phone to order fast food or Uber Eats or anything like that, that is on the table. So if you want to, I found this yesterday when I was preparing for this, but if you want to really stay up late at night and see what is happening, go to this site here. It's easy to find, just Google that. And it really is going to provide a list of cybersecurity events throughout the world, including in Canada. And the one thing that struck me when I looked at this list for Canada was that there's actually no correlation between size of organization, the type of organization, what they do, and so on. And I've listed there, we're all familiar with what happened at the University of Winnipeg. FinTrack, which is the AML police, the anti-money laundering police for the securities industry, they were impacted, and other more high-profile ones, London Drugs, Marriott Hotels, MGM Resorts, and the list goes on and on and on. But I think that was telling for me, and it's a reminder to me every day that what's at stake here is that we have business operators. These hackers are running a business. They're in it to grab data, use that to their advantage. Typically, it's sold. And so that's what we're trying to be mindful of. And one of the most important things that truly is scary is how we manage our own user credentials, which would be our account name as well as the password that we use. And this was just from yesterday. So if you think that it's getting old, it isn't. And here's some information on what Iranian hackers have been using to disrupt infrastructure in Canada, the United States, and Australia. And what they're seeking to harvest there are credentials, user credentials. And that is the key here, which they then sell. So that brings back this concept that we often hear, which is make sure your user credentials aren't the same for your different apps, banking, your airline provider, hotels, CRA is a big one. All of them should be different, or if they're not going to be different, you've got to change those passwords very regularly. So in this case, they used something called a brute force technique, which was to take known compromised passwords and start stuffing them into login screens to see if one of them was still active. And that is something that happens very regularly, given the fact that given how many organizations throughout over time have been compromised and where your user credentials have ended up. And what was very interesting, and I'm going to touch on this towards the end of the presentation, was, and this is what I would call a red flag. Somebody had mentioned the word surveillance earlier, and I got very excited because I do a lot of surveillance for clients and educating clients on what to look for in terms of red flags when we're trying to figure out if we're observing unusual activity. And so what happened here is that multi-factor authentication was in use, which is great. However, the token or the code that was sent to the user was being pushed down in the user's email browser through multiple hundreds of emails being sent. So that's what was really happening to disguise or get the user to disable the multi-factor authentication. So once that happens, the threat actors then register their own devices and they can remain connected to the account. So that's just a little bit of background to warm us up for the real conversation. You know, understanding what's at play here is really important, and it's going to help you both either as a staff member at the hospital or any other organization, as well as in your civilian life, to be ready. And part of what I say is, remember, this is a business. Hackers are in the business. They get paid when they prepare code, and that code is used and deployed, and it's successful. So one of the things that we can try to be is, don't be the lowest of the low-hanging fruit, because the moment a hacker realizes, well, this password that I have for Sean is not active, it's not working, he's obviously changed his password, they're going to move on. Because there are plenty of people in the world who haven't done that. So hence the reference to low-hanging fruit. The other analogy I use is, if you're being chased by a wild, ferocious animal, which I just got back from Africa, which I wasn't, but if you are, you just have to be faster than the slowest person in the group. And that's the idea here, is that make it difficult and don't make it easy for the hackers who may have your user credentials on hand. They'll move on right away because they are in the business. They are in this business. So what are the current threats? Ransomware is not new. It's a volume-based business, as I've just described. What they're looking for is twofold. One, they're looking to disrupt the system in place, whether it doesn't really matter what type of enterprise we're talking about, but they're looking to interrupt or disrupt access to that system. And then data. And those are two very separate issues. One is your system is locked down, and the second is my data has been encrypted. And this can often be dealt with by multiple operators. And it's I hate to say this, but it's a franchise model. Different sectors of the hacking community are more focused on data encryption. Others are focused on keeping our system locked down. And both are very, very separate. So this is often done through a compromise. The service providers in your life, whether it be your employer or others, they often are compromised when it comes to the user credentials in question. It's less about what I've done wrong, more about if I've imparted any type of information that is important to a counterparty or a provider in my life, say your bank or a CRA or what have you. If that organization is compromised, then there's a problem. So the other item that we're seeing quite a bit of, and it continues, is really the idea of social engineering, which is, I think I talked about this last time, John, a couple of years ago, which is getting somebody to do something that they wouldn't ordinarily do. In the context of cybersecurity, you see an email, it looks familiar, it looks to be from your hotel chain. You click on a link because it looks to be a great deal to claim a room at a particular rate, and in fact, it's fraudulent. So it can come via email, which we've seen. It can come via SMS or text messaging, as I would call it. And I'm constantly educating my children when they get these messages. You know, hey, Dad, I've got this message from Rogers. It's a free phone or something like that. I have told them categorically, do not ever click on any link that comes from anyone that you don't recognize. And now what's even worse is that your voice is now often being used, and this is truly the next frontier, where we have deep fake that is harvesting your voice and using that as a passport or a password to unlock accounts. So oftentimes Rogers, financial institutions, others are using your voice to identify and verify who you are prior to accessing an account when you call in, for example. And so voice is now very much on the table, and AI is all over that. So in terms of trends, what we're seeing, law enforcement is far more active in this area now than it ever has before. You've got more companies that are disclosing breaches to regulators and privacy commissioners, and as a result, law enforcement is taking a far more proactive role. And it's not really restricted to sectors of the economy that are of strategic importance or that are that have intellectual property sensitivity. I had a friend of mine who used to work in an aircraft manufacturer, and he was routinely in contact with the government, I'll leave it at that, about warning him about the risks that they were under, both when they traveled internationally and so on. Artificial intelligence is really, really active in this area. It's being used not only, as I've described before, but to curate more effective and efficient compromises. Again, this is a business. How many people can I get to click on that link? How many people can I trick into doing something that they wouldn't ordinarily do? And AI is very, very effective at that. So now that we're all sort of miserable and nauseous about how terrible this is, what can we do to make our life better, or to at least implement some form of risk mitigation in our day-to-day, both as a practitioner or in your life? And I do sort of offer these comments both to our audience as well as the family members of our audience, in particular individuals who are elderly, who may be more vulnerable. That's another area that we deal with, that the investment industry is very focused on, which are vulnerable individuals who may be subject to financial exploitation, undue duress, and so on. So the young and the elderly are the critical individuals here. It's not just the people in the middle. So multi-factor authentication, by far biggest bang for our buck. If you haven't enabled multi-factor authentication on all of your accounts, you must go do that immediately. Now, what that is that in addition to me having to input my account name or account number and password, I also have to verify that I am who I say I am, and that's through the use of something called multi-factor authentication. So my mobile phone, for example, will receive a text message. Now, once I've logged into, say, for example, my CRA tax account page, I'll get a text message from CRA saying, input this code into the web browser before you're able to proceed. So this can take the form of a password, can take the form of a token, which is something that banking industry uses, or we're seeing more and more fingerprints, facial recognition, eye scanning, retinal scanning. Highly, highly, highly effective. This will be, provided your phone hasn't been stolen, which is a whole other conversation. This is a highly effective way to make you very less palatable to those who are out there trying to earn a living. Most of the time, when organizations that we work with are obtaining insurance, cyber insurance, this is required. So when the insurers are telling us that this is required, that's a signal that this is important, and it's kind of the table stakes. So again, what I say here is 100% this is applicable for our lives as civilians. Do it for CRA, do it for anyone that offers it. If they don't offer it, they should offer it, because that is an effective way to really make theft of this area more challenging. I always say that training and education, without question, is the most important part here. Without that, if we are not trained as individuals to recognize what the red flags are, this is going to fail, and this is going to be very difficult. So training ourselves, training our employees, training for the organization will absolutely be required. And I say this in jest, but it really is true. Weak user credentials, so weak passwords, clicking on unknown links, it happens every single day. So it is, no matter how many times we have these conversations, it does not get through. People still use the same user credentials throughout. Those user credentials are weak. They're not, it might be something like 1, 2, 3, 4, 5 capital W Winnipeg, whatever it is, but they're not what they call strong passwords. And this is really how it starts. So that's the key. Ongoing surveillance. I mentioned that I got excited when I heard the word surveillance. Understand what is normal in your life or in your practice. And if you see unusual activity, act on it. So number one, we need to be able to spot the red flags that are unusual. And then once we have the wherewithal to see that something is happening, we need to act on it right away. The push bombing that we talked about earlier, and I'll get to this at the end of the presentation. But if you do see your email box filling up with emails, that is unusual. I don't get very many emails, but if I do, if my email box is filling up, and I'm talking about with hundreds and hundreds of emails, you know something is going on. So review your online accounts. If it's banking, then review it banking, for example. Do it on a regular basis, become familiar with it, and that will enable you to spot what sticks out, because it will be an anomaly. In terms of your data backup, this is an obvious one. Don't businesses that do not do this are asking for a problem. If you do, one of the things that we expect in cybersecurity attacks is that data will be encrypted. So it behooves us to have our data backed up somewhere else, not in the same location, obviously. If it's behind a locked door, that's great. Those files should be encrypted and authorized personnel only. So you don't want the data backup to be subject to tainting as well. Incident response plan. We always plan for the worst, we hope for the best. So this is what happens if the worst does happen. And really the idea here is we detect it, we respond, and then we recover. And the idea is to have minimal disruption to patients and, of course, your own life. The plan is usually what we see is in writing. The people who have different roles, those are identified, contact information, and as well as to incident reporting. So that's typically what is in place. This is also important, counterparty risk management. What I mean by that is who are you and who do you do business with? Who are the counterparties of my employer, my practice, my life? Who do you deal with on a regular basis? Do you trust them? What are their cybersecurity policies? If we're talking about financial institutions, the government, CRA, and so on, I'm less concerned, we hope, because they should have a very robust system in place. But as we've seen before, CRA, FinTrack, which is what I mentioned earlier, they are no different than the rest of us. They can be subject to these types of attacks, and sometimes they work. But the point is, do you trust them? Are they secure? What do they have of yours? Well, they have my user account and they have my password. And if those two data points are identical, when you go and sign up for Uber Eats, Skip the Dishes, Air Canada, WestJet, the hotel providers, Cineplex, and so on and so forth, you've just handed over probably the most common piece of information that hackers will use. So if they have that from one site, one disrupted site, they're going to stuff that. And that was one of my questions that I asked. They're going to use that to credential stuff on all over the place. And one of these times, they may get lucky and say, great, my account at Subway, which has a million points in it, I finally got into that, and now I'm going to order some food. And that has happened. So understand how these items work. And if I'm sharing here, this, John, was how my own identity was compromised many years ago. I used to work for a company. They had different providers. One of those providers was a benefits provider. They had my name, my address, my social insurance number. They were hacked. And only 10 years later, did I get a letter from my employer long after I had left, pointing out to me very nicely, I might add, that my identity had been stolen. So this is how we are mindful of our own lives. Now, it is not cool to walk around with an ancient iPhone or an ancient technology. It really isn't. These hardware and software are designed for obsolescence. So it is important that when these devices or software are not being supported by the manufacturer, that they be put out to pasture, decommissioned in a safe way, and in the case of data storage devices, that they're properly wiped and disposed of. So that is also extremely important. If you're running Windows 95, it's probably a good idea to move on to the next version. Breach management. So part of the incident response plan is, what do we do if there is a breach? So when a breach, if and when heaven forbid, a breach does happen, what do we do? We've got our providers identified in advance, in particular our insurers, information technology, our lawyers, and the breach coach, which is an emerging field of which is very lucrative, I hear. Legal contracting is going to be important because the lawyers will want to assert privilege over as much as possible, in particular, given the required privacy disclosures. And what is very interesting, the fourth bullet there, is that senior management and board level involvement is now required. So especially at the board level, cybersecurity is one of those issues that is now a board issue. It is an issue that is of critical importance to the organization, and boards are now required to have a lot of involvement with this particular issue and awareness of it. And if I was sitting on a board, if you are sitting on a board, I would be asking those questions. What is the organization's approach to cybersecurity? Doesn't matter what the information is, doesn't matter what their sector, I would be asking that question. If you haven't asked that question, my argument to you would be that you'd be exposing yourself to claims of negligence if there was, or direct liability, if there was a cybersecurity incident. And obviously, in the case of breach management, time truly is of the essence. We need to act on this right away. Regulatory insurance, regulators and insurers are looking for that culture of compliance. Just an information technology department issue. It is an organizational issue. Insurance should not be relied upon as the primary tool here, because this is just really a transfer of liability to your insurer. Reporting to the privacy regulators is now becoming the norm, and it often very important, followed by client or patient reporting. On the law side, there are amendments nationally that will align Canada's privacy laws to those in Europe, which is long overdue. And obviously with that, we see a dramatic increase to penalties for organizations that fail to comply. So before we wrap up, I know we're at the top of the hour here, I wanted to give you a case study. I call it Tales from the Crypt. So we have a user. The user is a member of Aeroplan. I think a lot of people, that's probably not uncommon. That's interesting. The user notices that a ticket's been redeemed. Okay, and very nice ticket, actually. It's a business class ticket. Oddly enough, the user is in Winnipeg, and the ticket is for round trip travel, I believe, from Cairo to New Jersey to the United States. The user has multi-factor authentication protocols in place. The user tells me, friend of mine, and it was very odd, Sean, because my email account when I woke up in the morning had hundreds of emails in it. And I pointed out to her that that was because the push notification from her multi-factor authentication token was probably pushed to the bottom of the page so she wouldn't see it. And that is exactly what happened. Happened, of course, in the middle of the night, which is when everybody sleeps here in North America. It was daytime overseas. And a lot of points were redeemed. So there's a perfect example. I don't have to be a CRA or an organization with thousands of employees. It can happen to any of us. We should expect it to happen to all of us, and we just have to be prepared for that. So, John, that is the presentation, and we can move it over to you for questions.
Thank you very much, Sean. So let's transition to the questions and answers. A question for Sean. What happens if your daughter does click on that link that says Rogers is offering you a free cell phone? Now what?
If it was my daughter, dad would be very upset, number one. And I'd probably get on the phone to Rogers right away. So that would be the first thing that I would do, and then I would get the device in question, and I'd probably try to figure out if anything else has been compromised on it. So those would be the steps that I would take, depending on the provider, obviously. If I've clicked on a link from whatever from Rogers, I'm going to get in touch with Rogers to make sure nothing has been compromised. Once I'm comfortable with that, I'm then going to look at the device itself to make sure that there's no issues there. And if it's beyond my capability, which it most likely is, then I'm going to call some friends of mine who will help me calm me down and make sure that nothing else has happened.
So somebody asked a very good question. Is it better to bank using your phone app or your PC?
Doesn't
Does
matter.
it matter?
Doesn't matter. I tend to and this is just my own preference, I tend to more usually use my iPhone here, which will allow me easier access to log in because the multi-factor authentication tool is going to be sent to this device. So whereas if I'm on my computer and I log in, it's going to send a code to this device. And if I don't have the device, then that's more of a hassle for me. So it usually doesn't matter, but I typically gravitate to a phone or iPad because that's just out of convenience. But they're both going to be equally secure, or the same level of security will be in place for both of them.
Okay. And one final question about cybersecurity. Apple, Android, Windows, based device, or does it matter?
Apple always, we hear, is more immune to it. They're less concerning of viruses for Apple related products versus Windows. But I adopt what I've talked about throughout, and I'm talking to you on a PC right now, and yet I have iPhone, iPad, etc. So I adopt the same practices for both.
Thank you.
You're welcome.
When do you think or will we ever see an end to the seemingly nonstop surges of the different viral hemorrhagic fever virus outbreaks in Africa? Or is this just something that we have to live with?
Say that again, John. I didn't
sorry.
get the beginning.
So the question is, do you foresee an end to the repeated surges of outbreaks of viral hemorrhagic fevers in Africa? Or is this something that we're just going to have to live with and it's just part of life and society? Because it seems over the past 5 to 10 years, there's been a sudden surge and we go from one episode of panic to another. And the problem with the panic is that one day you're in Africa and 48 hours later, you're in North America. And that viral hemorrhagic fever virus could be in a restaurant in New York or in Winnipeg. And if you're a scientist from the National Microbiology Laboratory, you could be in Charleswood or River Heights.
Yeah, I think we're gonna have to accept that we're gonna see outbreaks occasionally, and in some countries it has increased, or overall it may have increased, but we are also more vigilant these days. We have better diagnostics in those countries. For example, the Democratic Republic of the Congo deals with Ebola outbreaks in the meantime very, very well. They have own diagnostic capabilities. They have own teams to go in outbreak areas. Each outbreak, of course, brings certain danger in terms of transmission and moving pathogens. We have seen that in relation to the West African Ebola virus outbreak. We have seen that in relation to the Nigerian Lassa virus outbreak. Yes, I think we're going to have to live with it. These outbreaks will occur and will happen. Virus reservoirs we won't be able to extinct those reservoirs, at least not very, very easily. And currently there are no concepts to it. So filoviruses are likely going to be in bats in many, many parts of Africa. And if circumstances are right and humans are being exposed, plus then circumstances in the public health system will amplify these outbreaks, and international or transmission to international sites around the globe are possible.
Thank you. So a couple of questions for Devinder Singh. One of the questions was, please remind us, immunize with RSV vaccine prior to or after influenza, or does it matter?
Well, I suppose it depends on what's the most convenient. One, with what's available in terms of when you get your influenza vaccine distributed to you. But there's also different time points to consider. The most important thing is, if you're going to immunize before the start of the virus season. So, if the virus is already circulating at high numbers, then, you haven't necessarily missed the boat, but the boat's on its way. So, get the vaccine before the virus starts circulating in high numbers. Then if you have the circumstances where you can, make this kind of judgment, because the person's going to be able to come back, you have some time before typically RSV starts circulating, which would be like in mid-November, on average. But of course, there's always the possibility that something's going to start earlier. Then you could look at two different time points. Like, one is, it takes about 2 weeks to get a significant immune response. So, if you can, because of the uncertainty here, I would probably immunize with COVID and flu at the same time first, wait 2 weeks, and then give RSV. Again, if you have time. The most important thing is to give the vaccines if you're going to give them. But if you have time, then that allows for the significant immune response to COVID and flu, which aren't shown to interfere with each other. And then you give RSV, which has the that potential for maybe a lower response to H3N2, which typically affects older people harder, which is a concern, because that's who you're giving the RSV vaccine to. And also, we don't have any data for co-administration for COVID, so we don't know what that looks like. Second thing to think about is that GBS. It's very rare, but it could happen. You give flu and RSV at the same time, and that person gets GBS, you don't know if it's due to the flu vaccine or it's due to the RSV vaccine. And realistically, the general advice is, if someone has GBS within 6 weeks of getting a flu vaccine, you generally, advise against that person getting that vaccine going forward. So, that's a potential significant impact to that person's health and their risk of severe influenza going forward for the rest of influenza seasons. So, those are two things to think about. But again, GBS is very rare, even though we are seeing it after that vaccine. So the most important thing, immunize before the virus starts circulating. Second, if you've got time, probably the 2 weeks between giving flu, COVID, and then RSV.
Thank you very much. I think we'll end here, so everyone can have a small break. We've got a 10-minute break, and then we'll return to the home stretch with Paul Vancasile, Philippe Lagasse-Weens, and Pierre Plord. So we'll see you back in 10 minutes. The next speaker will be Paul Vancasile. Paul is the medical director of Chatham Provincial Laboratory and a consultant on the Pediatric Infectious Diseases Service at Children's Hospital here in Winnipeg. Paul is also a travel medicine specialist at the Winnipeg Regional Health Authority Travel Clinic and a professor and a professor at the University of Manitoba in the Department of Medical Microbiology and Infectious Diseases. Paul is going to speak about Strongyloides stercoraris, an important but unseen parasite. And this nicely closes the loop, because earlier this morning, Chris Greenaway spoke about immigrant health and referred to Strongyloides stercoraris. So, Paul, at your convenience.
Thank you. I hope I've got the right view showing up.
You're on presenter view.
Remind me how I do that now, how I get off of here. Display settings, is that it?
Yeah, that's the one.
There we go. Okay, thanks very much. So I've amended my title a little bit here. We'll see if folks can pick up what the link is to something later on in the presentation. Let's talk about strongyloides though. We'll talk a little bit about some unusual parts of its biology that makes it kind of unique, some different clinical manifestations that are also fairly unique about it, and some appropriate investigations and treatment. And I have no conflicts to report while we're doing all of that. So what exactly is strongyloides or strongyloides? I kind of pronounce it both ways without knowing which is the proper way to say it. It's a parasitic microscopic worm, causes a neglected tropical disease called strongyloidiasis. It's also known as threadworm. It's a round worm, one of the 3 sorts of worms that we can encounter. I guess 4 if you count the unusual Acanthocephala. It has both a parasitic life cycle stage and a free-living environmental stage, so it's one of those soil-associated parasites. There are 3 species or varieties that infect humans. We're going to talk about Strongyloides stercoralis. There's also Fulleborni in Africa and Fulleborni kellii, which is in New Guinea. We won't be talking about those. Strongyloides has this strange and fascinating life cycle. Parasitologists love to talk about life cycles, so you're just going to have to put up a couple slides of that. Starts with infection by faleriform larvae penetrating usually the skin of the foot from infected or contaminated soil. The larvae then penetrate through the skin, and convention has it that from there they get into the blood carries the larvae to the lungs, they break into the respiratory tree, migrate up the respiratory tree to be swallowed, localize in the duodenum, finish their maturation in the duodenum, but only females develop. And then a couple weeks later, females out of nowhere, by a reproductive process called parthenogenesis, produce unfertilized but competent eggs that then hatch in the intestine for the most part, and then develop once again into faleriform larvae that can penetrate back through the intestine and cause this autoinfective multiplying cycle within the body. Those faleriform larvae in a high intestinal transit situation can be passed into the environment, or they can make it out onto the skin, the perianal skin, and infect through the intact perianal skin as well. So there's a couple of different ways that autoinfection can occur. So humans are the primary host for stercoralis, but stercoralis can also infect some other primates, some cats and dogs. There are no intermediate hosts such as fish or snails needed. Inside the body, parasitic cycles or forms can persist for 30 to 40 years, and there's certainly case reports exceeding 50 years that we can find. Environmental forms, though, only last for approximately 1 generation, 2 to 3 weeks kind of thing in the environment. And that requires more moist soil with a reasonable temperature range. Therefore, we don't expect strongyloides. We don't see strongyloides surviving well in temperate climates. We're usually talking tropical or subtropical climates. And so any faleriform larvae found in the soil are going to be from fresh or recent human defecation. So knowing that it's tropical or subtropical, where are we going to see strongyloides in its disease? It's largely in those areas. Up to 600 million are infected worldwide, and usually we talk about 5 to 7% prevalence in various and sundry areas as an average. However, there's no doubt that in poor tropical areas, we see prevalence of 40 and as high as 70 to 75%, particular in Southeast Asia. We heard from Dr. Greenaway that strongyloides has come to Canada, usually via immigration, and we see about a 12% prevalence amongst those populations. And it's estimated in some places that we might have as many that we have as many as 2.5 million infected in Canada. Looking at a heat map, you can see once again that it's the tropical areas, in particular in Central South America, sub-Saharan tropical Africa, and tropical Southeast Asia and Oceania that are infected. And we're usually talking about rural agricultural populations, low socioeconomic status, and institutionalized populations are at highest risk. But you can see that it does exist worldwide, and it's really only the Nordic countries, Canada and Scandinavia, that are accepted. We'll talk about the clinical presentations as well. So they're divided roughly into acute disease, chronic disease, which is fairly unusual amongst parasites, and we'll talk about that a little bit more, and hyperinfection syndromes, which is also a fairly unique presentation that we see with strongyloides. Acute presentations, we like to talk about ground itch, which is something we see with hookworm and Toxocara infections as well. You can see a itchy serpiginous rash at the point of larval penetration. Ground itch is usually a little bit more slower moving, but strongyloides caused ground itch is called larvicurrens, which means it's racing, and it moves very fast, 5 to 15 centimeters an hour. This is a moving rash. It can disappear in as little as 12 to 18 hours, but it can last for 2 to 3 weeks as well. It somewhat depends on host response and how many larvae are introduced. And some can have more severe urticarial or purpuric reactions. Less commonly, we might see pulmonary or intestinal symptoms related to the migration through the lungs and then the transit to the intestine. In the lungs, we might see something like Loeffler syndrome with an eosinophilic migratory pulmonary infiltrate with dry cough and wheeze. Intestinal symptoms might include nonspecific diarrhea or gastric pain as examples. Chronic presentations are probably by far the most common presentation that we would expect with strongyloides, and most are asymptomatic that persist for years or decades. All we might see is eosinophilia. 48 to 78% might be affected, and it can range from mild to severe eosinophilia, but it's not universal that there will be eosinophilia. There are lots of reasons why eosinophilia might occur from folks coming from endemic areas, many other parasite infections as an example. Thus, eosinophilia alone has poor positive predictive value for strongyloides infection. Nonspecific symptoms might be bloating or epigastric pain. Occasional perianal larvicurrens might be something that we see. Hyperinfection and disseminated strongyloiditis are of course, quite unusual for parasite infections. They are separate syndromes, if you like, but they're often considered together. Hyperinfection is when we've got unchecked autoinfection, so the immune system is not slowing down the parasite within the intestinal tract at all, and we get a heavy parasite burden that is migrating in heavy numbers through the gastrointestinal and respiratory tracts. Disseminated disease implies spread beyond those anatomic sites into other organ systems. The common thing about both is that they occur pretty much exclusively in immunosuppressed populations. Immunosuppression includes, as an example, those on corticosteroids or chemotherapeutic immunosuppression, especially those who are transplant patients. Advanced HIV used to be considered a significant form of immunosuppression as it relates to strongyloides, but that seems to be considerably less common than it used to be. However, HIV's close cousin HTLV it definitely has a synergistic relationship with strongyloides, and they can make each other worse. So that's an important infection to rule out. Alcoholism, malnutrition, diabetes, and chronic renal failure, all as examples, are minor risks. Hyperinfection syndrome has a high mortality with a mean of around 68% and nearly uniformly fatal outcomes if there's delay in diagnosis and delay in treatment. So some of the key features to keep an eye on for hyperinfection syndrome is, of course, the history of immunosuppression, in particular steroid. There's some work that suggests that there's steroid receptors on the worm that help accelerate its maturity. You can expect pulmonary and GI systems, of course, to be affected with cough, wheeze, hemoptysis, and pneumonitis. Abdominal pain might also include ileus and necrotizing enteritis. And often there's larvicurrens perianally as well. Fever and disseminated intravascular coagulation are frequently present. A clue that infectious disease types lock onto that makes them think of strongyloides is recurrent polymicrobial bacteremia, thought to be from the intense translocation of intestinal bacteria due to the larvae crossing the intestinal barriers there. Other end organs become infected as a result of all this mass larval migration. Polymicrobial meningitis is something that we may see, renal failure, hepatitis, cardiac disease, exocrine gland dysfunction, in particular pancreatitis, and peritonitis are all fairly common findings. So what about detection and diagnosis? Well, of course, you have to have the clinical suspicion plus the epidemiologic backdrop. Dr. Greenaway talked about getting a proper travel history or immigrant history. That can be extraordinarily important to consider. And of course, the supporting lab evidence. However, supporting lab evidence is not so straightforward as one might think. You'd think microscopy would be a good place to start, such as stool ovum parasites, but it's not generally recommended for uncomplicated strongyloides. Typically, there are very few larvae or very few eggs to be seen. One stool sample, as an example, is at best 30% sensitive. We get up to only 90% sensitivity if we're talking about 7 serial stool specimens, which is getting to be a bit much. Part of the problem as well is that filariform larvae hatch quickly and they can migrate right out of the container. And remember, they can penetrate through intact skin, so this is considered a hazard in the lab environment. That's why labs really like it when you put parasite specimens in fixative and preservative. And if you're thinking strongyloides, please also wrap a little paraffin around that nicely sealed top. So microscopy tends only to be useful, though, for hyperinfection, in which we're getting overloaded amounts of larvae and potentially even eggs in not just stool, but we may even see it in sputum. For the uncomplicated strongyloides syndromes, then serology becomes really our best option. So strongyloides antibody, which is for cadum, we do it here. It's a combination of IgG, IgM. It's around 90% sensitive and specific. There's some cross-reaction with other roundworms, such as filarial roundworms. And false negatives, of course, are going to be possible if it's early in the acute infection or in severely immunosuppressed. Sometimes you see fantastic-looking X-rays like this that are almost overwhelming to behold. In the lower right corner, sometimes we can see larvae in sputum, and I certainly encountered that and sometimes, and that can occur with a number of different parasites, but in particular with strongyloides. And then microbiology labs always get a kick out of doing the agar culture technique, in which we drop, say, a bit of sputum specimen on the plate, and then we see these little tracks develop where the worms, the little larval worms, have crawled around and left tracks of bacteria behind. That's almost specific for strongyloides. So who do we need to test? Well, certainly anyone at high risk of infection from a high-risk area with or without eosinophilia. Generally not from urban areas, but you need to do a proper history to figure out whether or not urban is a risk or whether it's not a risk. Anybody who's about to be immunosuppressed from a high or intermediate risk area should be tested serologically beforehand. And of course, we consider steroids, chemotherapeutics, immunosuppressive therapies, and transplant to be kind of the highest risk scenarios. I would say anyone with HTLV infection should probably be serologically tested as well. They're almost always from an endemic area, and there is that nasty synergistic infection that they can develop. And of course, if there's a suspect hyperinfection or disseminated strongyloides infection, then that's absolutely a time when the lab and infectious diseases should be getting involved as well. Treatment, we've got excellent treatment available with ivermectin. It is recommended for uncomplicated strongyloides. On Earth, we also have albendazole and thiabendazole available if you don't have ivermectin available to you. However, these are not available in Canada or not approved in Canada, I should say, and will require special access. Albendazole is technically somewhat effective. However, it's only about 30 to 50% effective, not well absorbed. It really isn't a good option, but if you're lacking access to all else, it might be something to temporize with at least. Severe infection, requires repeated and prolonged ivermectin dosing. I would say consult ID quickly. Ivermectin may need to be delivered by all sorts of unconventional and almost difficult to organize routes, such as systemic or even by enema. And broad spectrum antibiotics for the polymicrobial bacteremias that are almost certainly going to occur. You may need to not just monitor Strongyloides antibody, but you may need to monitor Strongyloides larva and egg shedding in the hyperinfection cases. There's some excellent guidelines for treatment of these sorts of cases from the Committee to Advise on Tropical Medicine and Travel, once again authored by Dr. Greenaway. Total control may not be realistic. There are some contraindications to ivermectin treatment. If someone is infected with loa, that is a contraindication. They can develop fatal encephalopathies, and of course, if there's hypersensitivity, we wouldn't give it. So to prevent, attention to sanitation and hygiene would be important. Contact isolation only if there's a hyperinfection syndrome nearby would be the rule. Wear shoes, don't lie on the ground. It only takes a few minutes and you can get yourself infected. Routine immigrant screening, certainly for high-risk immigrants, seems to be an excellent idea. And certainly all transplants and long-term immunosuppressive therapy patients from highly endemic countries should be screened serologically. Thank you.
Thank you, Paul. So next is Philippe Legassier-Weens, who will speak to us about dengue and chikungunya vaccines ready for prime time. That's with a question mark at the end. Philippe is a specialist in medical microbiology at St. Boniface Hospital. Philippe's particular area of interest is travel and tropical medicine. Philippe.
Thank you very much. Just confirming that you can see my presentation. It is in presentation mode.
Perfectly.
Excellent, thank you. So thank you for the introduction. I wanted to talk a little bit today about dengue and chikungunya vaccines, and many of you who are attending here may not even be aware that these are vaccines that are available, at least in some parts of the world, and even licensed in Canada in the case of chikungunya. Just some disclosures. I don't have any financial disclosures, but I do need to clarify that I am a member of CATMAT, which is the Committee to Advise on Tropical Medicine and Travel, which is a committee that's based with FAC. And this presentation has nothing to do with what our recommendations are going to be. They are really my personal opinions at this point, and the committee's recommendations on the topic are ongoing. Some products discussed herein, specifically dengue vaccines, are not Health Canada approved, and therefore any recommendations I might make are off-label. And lastly, I'd like to thank my colleague, Dr. Michael Libman, for some of these slides. The objectives, we're going to talk about the dengue and chikungunya vaccines, so what they are, their primary side effects and precautions, and how effective they are. And we're going to describe some possible indications for chikungunya immunization in travelers, and predict some possible indications for dengue vaccination if ever this vaccine becomes available, or if travelers happen to be going to a country where it is available. When I started in tropical medicine, we had a few tricks up our sleeves to prevent chikungunya and dengue infections. And these really boil down to mosquito avoidance. That is to say, avoid those day-biting Aedes mosquitoes. We knew that bed nets didn't work very well because they are day-biting mosquitoes. We knew that permethrin-treated clothing worked very well, but people generally did not follow that recommendations. We knew that mosquito repellents like DEET or picaridin worked quite well, but again, reliance on that, often travelers were not doing that. There are a few other mosquito repellents, some of which are available abroad. And then, of course, there's the option for travel avoidance, which we would really not generally do unless there were severe outbreak settings or there were very high-risk travelers, elderly, pregnancy, immunocompromised. But nowadays, we now have a discussion around vaccines, and that's what we wanted to talk about today. But before we dive into the vaccine discussion, we kind of need to know a little bit about the viruses themselves. Dengue, I like to describe as the it's complicated virus because there's actually 4 different viruses that cause dengue in humans. They're called 4 serotypes. These are arthropod-borne flaviviruses, as we heard already today, and they are transmitted by Aedes mosquitoes, and particularly Aedes aegypti and Aedes albopictus. The disease occurs anywhere where it's warm enough to have these vectors, and that includes tropical and subtropical parts of the world. And for people who may not be aware, that does include southern parts of the US and southern parts of Europe, where we often don't think of tropical diseases being present. Dengue is often an asymptomatic disease. So 20 to 80% of people who get infected actually never develop symptoms. And the infection with a serotype provides lifelong or believed to be lifelong serotype-specific immunity. In those who do get illness, most of them is fairly mild, actually. So people often are afraid of dengue, but most people who get dengue have a self-limiting febrile illness. So some cases can be severe, cause severe symptoms, and in about 2 to 5% of total cases, we get cases of severe dengue who need hospitalization. And this is largely due to something called antibody-dependent enhancement. This is because a second dengue infection with a different serotype, I mentioned that a single serotype provides lifelong immunity to that serotype, but a second serotype can cause an infection, and it seems that the immune response is enhanced to that second infection because of that first infection, leading to a much more severe presentation, and a relative risk of severe dengue goes up considerably with your second infection. The case fatality rate overall is somewhere between 0.1 and 1%, obviously higher for second infections, lower in travelers because most travelers who get dengue are getting a first infection. And there are a few risk factors, in particular, children and the elderly are more likely to get severe dengue or case fatality. The epidemiology is dramatically changed in the past 20 years. We have a lot more dengue than we used to. There's large outbreaks that have occurred in 2024, over 11 million cases as of the first 7 months of 2024, 7,000 dengue-related deaths in 84 countries and territories. So this is a widespread disease. It is omnipresent anywhere that's warm enough to support these vectors. We've also seen some autochthonous cases, meaning that they were acquired not by travel in the US, in Spain, in Italy, and in France, all in the past year. And there have been widespread outbreaks in the Caribbean, and we know the Caribbean is a common destination for our Canadian travelers. Overall, because people travel a lot, the attack rate is relatively low, about 2 per 100,000 trips, or 3 per 100,000 trips to Central America. But because of the huge amount of travelers that we see, this actually translates into a fairly high number of travel-related cases. Now, what of these vaccines? There are actually 2 currently available vaccines for dengue. One is the CYD tetravalent dengue vaccine. It actually uses a yellow fever vaccine backbone into which we've genetically engineered pieces of dengue viruses for the 4 serotypes. So it's tetravalent, has the 4 serotypes. It was approved almost 10 years ago now by multiple health authorities, takes 3 doses. It is approved by both the FDA and the European Medicines Association. And it's only given to residents of endemic areas. This is not a traveler's vaccine. And actually, the manufacturer, which is Sanofi Pasteur, has given a notice of discontinuation as of April 2024, and I'll get into why that is momentarily. The newest kid on the block is the Takeda vaccine, which is a live attenuated dengue 2 chimeric vaccine, meaning that it's built on dengue 2, but they've switched out some of the parts with dengue 1, 3, and 4, leading to a tetravalent vaccine. It's a 2-dose vaccine. It was approved at first in 2023. It is currently approved for use in Europe and many other countries, but not by the FDA or by Health Canada.
I'm in the middle of a conference.
Could you mute yourself, John, please? So some European countries have an indication for travelers, which is why we need to learn a little bit more about this vaccine. This slide very briefly just summarizes that basic science around the vaccine. On the top over here, we have the Dengvaxia vaccine, which is that tetravalent yellow fever-based vaccine. The backbone is yellow fever virus vaccine, and they've switched out the envelope gene for the 4 serotypes of dengue virus, leading to an immune response to dengue instead of yellow fever. And the middle portion here is the Takeda vaccine, which is based on dengue 2. It is a mutated dengue 2, which is attenuated and is also flipped out for its envelope gene for the other 3 viruses. So these are live attenuated viruses. They do establish viremia in patients who get the vaccine, and that's how they develop an immune response. Now, Dengvaxia, or the tetravalent vaccine based on yellow fever, was, as I said, originally approved in 2015, but by 2017, they started to notice that people who had been vaccinated were having higher levels of severe dengue in their initial infection. And this was found ultimately to be due to a higher response to dengue 4. And that left some of these individuals at risk of acquiring dengue from a second infection, and that it would behave like a secondary infection and therefore have that antibody-dependent enhancement of that infection. So this vaccine was probably acting as a first infection in people who had never been vaccinated or had never been infected with dengue virus before. They did not see this at all in people who had been infected with dengue before, leading to the conclusion that if you use the vaccine as the secondary infection, you wouldn't get severe dengue in later infections. But in naive individuals who had never been infected by dengue, you were basically giving them their first infection, and they were at risk of developing severe antibody-dependent enhancement later on. So it was discontinued because all recipients then needed to have serology to determine whether or not they had ever been infected by dengue virus before, leading them to be eligible for the vaccine. And just a very brief summary here. At the top here, you see an unvaccinated individual who has been naive and never infected with dengue would basically typically get a primary infection with a moderate degree of risk for severe infection, and then get a second infection, and that was the highest risk for severe infection. And in a vaccinated seronegative patient, that vaccine was acting as their primary infection, and their first real infection was more like a secondary infection, leading to higher risk of severe dengue. However, in those seropositive patients, they'd had a primary dengue infection before, and their vaccine was serving as that second infection, leading to a much lower risk of severe disease subsequently. Now in comes this new vaccine, this Takeda vaccine. Their hope was that it would not have this antibody-dependent enhancement, and sure enough, they enrolled over 20,000 participants in multiple countries and demonstrated across the board that this vaccine was effective to prevent dengue virus, dengue infection that was confirmed. So within a year, about 80% reduction in cases, a year and a half, 73%, and upwards to 4.5 years, a 61% reduction in virologically confirmed dengue cases, with a dramatic overall reduction in hospitalizations of 84%. And in safety studies, did not observe this risk of increased hospitalizations later on. But it's important to point out that 72% of the individuals in these studies were actually already infected at some point before their vaccination with dengue virus. They were all in endemic countries and therefore at risk of having already had their primary infection. So it behooves us to study very carefully that one group of individuals who had never received a prior vaccine and who had never been infected. And this is what this slide describes. I'll highlight some of the important differences here. In seropositive individuals, that is to say they'd been previously infected with dengue, we had across the board protection against all 4 dengue serotypes for subsequent infections. Best for dengue 2, maybe not surprising because that was the backbone of the vaccine, but across the board, we see protection against all 4 dengue viruses. However, in individuals who are who were seronegative and never had an infection in the past, we see decent protection against dengue 1 and 2, but no protection against dengue 3 and 4. And that was seen also in the antibody titers that they measured in these people, that in seropositive individuals, you got a big boost to all 4 serotypes, but in seronegative individuals, you got a very good boost to dengue 2 and a moderate boost to dengue 1 and lower to 3 and 4. And so this raises concerns about the effectiveness of this vaccine in travelers who are almost exclusively seronegative. If we look at the same data for serious dengue, we see the same sort of picture. We see significant protection in the dengue seropositive individuals that had already had dengue sometime in the past. And we actually see significant protection only for dengue 1 and 2 in the seronegative individuals. And there is a strong signal here, this negative 87.5, although it wasn't statistically significant, maybe even points towards a risk of severe dengue in individuals who are getting infected with dengue 3 if they were seronegative at baseline. So my take on it is that this vaccine appears to be effective with no signal of antibody-dependent enhancement after 4 and 5 years, but only in endemic populations. There is no data for travelers. The efficacy for seronegative recipients in endemic areas is modest at 3 years, but could be lower or even not there at all for 3 and 4. We do get good protection for severe dengue in endemic areas, particularly in those groups that are seropositive at baseline, but we do not see the same, and it might even be dangerous or increase the risk of severe dengue with dengue 3 and have almost no data for dengue 4. So it does not likely confer protection to dengue 3 and 4 in naive individuals. And we also know that the duration of immunity is quite uncertain. We may need boosting. Individuals in endemic countries may actually benefit from being exposed to dengue throughout their lives after vaccination. So my final recommendations for dengue is that it's not licensed in Canada. We don't have any submissions at this point. Travelers may ask about it, but given the current evidence, I would recommend against vaccination for Canadian travelers who have not been previously infected with dengue with a laboratory confirmation. I suppose in travelers who have this, which would be very few, and who have access to the vaccine, one could recommend it in areas that they are at risk of getting dengue. I'm going to speed up a little bit for chikungunya. Chikungunya is a disease also transmitted by Aedes aegypti and albopictus. It is common in tropical and subtropical parts of the world, along with parts of the US and Europe. We do see a lot of chikungunya in outbreaks in naive and dense populations. Half or more of the population can be infected within a year during outbreaks. But once they become immune, the incidence is generally low and fairly constant outside of these epidemics. So the disease prevalence is actually quite low even in endemic countries outside of these outbreaks. However, there have been quite a few outbreaks, and this map summarizes them. We can see in South America, particularly in Paraguay and in Brazil, there have been hundreds of thousands of cases in the past several years. And also we see cases in the southern United States and in India. So there are certainly some hotspots for chikungunya across the globe in tropical and subtropical areas. The disease is noteworthy because most infections are symptomatic, unlike dengue, and it typically presents with this very abrupt, non-specific fever, sometimes a rash, sometimes some headache, back pain, malaise, lymphadenopathy. But the key finding is significant arthritis or arthralgia, which is common in almost all individuals who get it. And it often presents as a synovitis or even periarticular swelling, so a frank arthritis. Severe cases are actually quite rare. About 4% of cases will be hospitalized. The hospitalization rate is higher in travelers, possibly because of the age factors. And death is actually quite rare. So fewer than about 1 in 1,000 cases will result in death. And those are identified cases. The chronic arthritis is problematic. It is often persistent and sometimes severe. It can last months to years. In fact, many studies have demonstrated that in about half of patients, it lasts for a year or longer. There's 2 forms of it, one that resembles rheumatoid arthritis and one that resembles ankylosing spondylitis. But the bottom line with the chronic arthritis is that it's very common. About half of patients will get it. There are these 2 major forms. It can be severe and relapsing and have a significant impact on quality of life. And it's likely longer than a year in about half of those affected. There are treatments, but they're not that effective. And they often mimic rheumatoid arthritis treatments. And lastly, in terms of clinical presentation, congenital infection is very serious. It's quite common. About half of infants whose mothers get infected between 2 days before and 2 days after of delivery will get infected. And the vast majority of them develop severe neurological disease with permanent neurocognitive outcomes that are poor. So what about this vaccine? It's actually been approved in the US in November and in Canada in June of this year. It's indicated for individuals at increased risk, obviously. It's a single dose, so that makes it convenient as a travel vaccine. There are trials that are now ongoing for younger kids, so teens. It is a live vaccine, so has all the same usual contraindications. And importantly, we actually have no efficacy data for this vaccine. So it was approved without any data to prove that it was effective against chikungunya. They only used seroconversion data. And so we saw that almost 100% of patients who received or trial recipients who received this vaccine converted, meaning that they had high titers of antibodies against chikungunya. And we believe that those are effective to prevent infection based on animal studies, based on the fact that when patients get chikungunya infection, they are usually protected for life against it, so similarly to a live attenuated vaccine. And we know that when we repeatedly gave these people live attenuated virus vaccines after their initial vaccination, they never developed viremia again. So there probably is some truth to that. The issue with this vaccine falls into the safety data, and I'm going to spend a little time on this because it's a very reactogenic vaccine. We saw about 15% of vaccinees got local reactions, but that's not that bad. That's quite common. We saw about half of vaccinees getting significant systemic adverse events, including headache, fatigue, and myalgias in about 30% of them. And severe systemic side effects were, although they were relatively rare, they were much more common in the vaccinees than in the placebo group. So about 2% of vaccinees had severe systemic adverse events. So high fevers that prevented their daily living, significant arthralgias or myalgias. I'm just going to skip this slide because the real money is here. Post-vaccine chikungunya-like illness was also sought because we know it's a live virus. Concern about whether or not it can cause prolonged arthritis in patients, obviously. And we did observe that chikungunya-like illness post-vaccine was present in about 11.7% of recipients versus only 0.6% in the placebo group. 1.6% had severe chikungunya-like illness when they got the vaccine, and about 1 in 200 vaccine recipients had prolonged chikungunya-like illness for greater than 30 days, for a median duration of 94 days and a range of 30 to 6 months. So this vaccine in some people appears to give a disease that is a little bit like chikungunya, although it's quite rare compared to the native virus. It does happen, apparently. So just to summarize those harms, every 64 people you vaccinate with this virus will get a severe chikungunya-like virus illness. Over 220 people that you vaccinate will get more persistent symptoms that last between 30 days and 6 months. And 1 in every 9 patients will get some form of chikungunya-like vaccine-associated illness, which will be mild in the majority of them, but nevertheless will be a chikungunya-like illness. So keep those numbers in mind as we talk about risk. We don't have direct data for Canadian travelers, but we do know that the risk is based on destination and ranges roughly on average from 1 in 1,000 individuals per year in endemic settings. So those places that the epidemics have already happened and most people are immune, to 1 in about 100 or 112 in a more epidemic setting. And in really extreme situations, it's about 1 in 10 individuals over the course of a whole year. And this was a global study that looked at chikungunya infection. We do know that if chikungunya gets introduced into a naive population that's very dense, you can get these explosive outbreaks, but that's not the reality for most destinations. And we also know that long-term symptoms are common, about half, and hospitalization is about 4%. So in my last few slides, I'm going to summarize the risk of infection based on this. In an endemic setting, where it's just sort of there, but not an outbreak, for a 1-month travel duration, you would have to have about 10,000 trips to get 1 case of chikungunya. In an epidemic situation, it's closer to 1,000 for a 1-month trip. And in a worst case epidemic, that 1 in 10 scenario, about 1 in 100 trips would result, 1-month long trips would result in infection. If we adjust that for the risk of chronic persistent symptoms after an infection, we see these 3 scenarios come out. In an endemic situation, it would take about 1 in 30,000 trips for 1 patient to develop a severe chikungunya-like syndrome after an infection. In an epidemic, you would get about 1 in 3,000, and in a worst case epidemic, 1 in about 300. So if we think back now to those risk of chikungunya-like virus illnesses, there's a very limited number of individuals who would benefit compared to the potential risks of this vaccine. So what we're seeing is in an epidemic situation, travelers longer than a month are about at a risk of 1 in 300 of getting the virus. And that's about the same as the persistent vaccine-associated illness. And in a worst-case epidemic, even travel as short as a month would benefit potentially from vaccine. So in summary, in my opinion, in highly epidemic locales, you might have a 10% risk per year, and that favors comparably with those risks of the vaccine. Sometimes it's hard to define highly epidemic or hyperendemic areas until they're underway, so that needs to be considered. There may be other possible target travelers, so very long-term travelers to these endemic or sporadically epidemic countries, or higher risk individuals like the elderly, the very young, and also you may consider exposures and activities, the time of year, but there is probably limited or no role for this current vaccine in stable endemic settings and short duration travels. It is important to know that we don't know if those vaccine-associated diseases are as bad as the virus-associated disease and are likely milder. So are these vaccines ready for prime time? I would say no, not yet. Dengue vaccine has uncertain risks in seronegative recipients, but may be okay in patients who have had dengue virus before. Chikungunya vaccine is quite reactogenic, and you will need to balance the actual risk of getting chikungunya virus infection with the risks of the vaccine. And remember, there's a whole bunch of other vaccines for both of these viruses on the way, so some may be better yet to come.
Thank you very much. So Pierre Plourde will give us a brief presentation entitled Rabies and Rabies Vaccination, Less is Way More. Sounds like Phil's vaccines. Pierre is a medical director of the of the Tribal Health and Tropical Medicine Services with the Winnipeg Regional Health Authority and a professor in the Department of Community Health Sciences and the Department of Medical Microbiology and Infectious Diseases with the Faculty of Medicine at the School of Medicine at the Max Rady College of Medicine. Thank you very much. Now, is that Philippe Legassier-Weens with rabies?
Sorry, now I've unmuted myself. Okay. Yes, so we will stick with Dr. Legassier-Weens' theme of vaccines and vaccine data, except this data will be closer to home in some respects. I have no conflicts of interest to disclose. And other that some of the data I will present was produced by our travel health clinic here in Winnipeg, and actually will be soon published in the Canadian Journal of Public Health. So you're getting kind of hot off the press preview of what will soon be published in peer-reviewed literature. My objectives you've seen in the in the conference package. So I will just briefly kind of repeat that I will be talking about two forms of rabies administration, vaccine administration: intramuscular, which is the traditional form that is registered and the way that it has been done for decades and that the drug companies support, and intradermal administration, which is not licensed currently, and so is what we might call an off-label use of rabies immunization. But before you get too worried about that, it's a use, intradermal rabies vaccine has been also used for decades and is actually approved by the World Health Organization, the Centers for Disease Control in the United States, and the Public Health Agency of Canada. So it's not like we're experimenting with intradermal, it's just not been licensed. And so what I want to show you is, so why is intradermal rabies immunization maybe favorable over intramuscular? And we'll talk about the immune response of the intradermal administration of rabies vaccine. And finally, I want to end up basically arming you to advocate for the utility and potential significant cost effectiveness of using intradermal rabies immunization. I don't think I have to explain too much to this audience the consequences of rabies. When humans get infected with rabies, the chances of surviving the infection are virtually 0%. it's so rare that anyone who survives rabies, is a case report and has tremendous media attention because it's worldwide, because it is so rare. On the other hand, there are over 59,000 human rabies deaths worldwide annually. And you can see here where the hotspots are, mostly in sub-Saharan Africa and in South Asia and Southeast Asia, where most human rabies cases occur. So again, rabies is not seen a lot in humans in Canada, but certainly Canadian travelers who travel to high endemic countries, and also people who work with animals, veterinarians and animal workers, are definitely populations that are at higher risk of exposure to rabies. Now, as I mentioned, rabies immunization is approved by the World Health Organization, both in intradermal and intramuscular administration. Intradermal is favored in that it only uses 1/10 of the dose of intramuscular. The intramuscular vaccine is 1 milliliter, whereas the intradermal is only 0.1 milliliter. And already you can see potentially 1/10 of the cost of immunization if intradermal is indeed as effective, requires the same number of doses, et cetera, and has the same effectiveness as intramuscular. The advantage of what I will talk about today is mostly pre-exposure immunization versus post-exposure, meaning that you're getting immunized against rabies before you're ever exposed to it. And why would you want to do that? The two important reasons is one, that if you do get exposed to rabies and you've already been immunized, you need fewer doses of the rabies vaccine after exposure to boost your immune response and to get very rapid immunity boosting post-exposure. And also post-exposure, you don't need the rabies immune globulin, which is a large volume, very expensive product made from human sera that is best avoided if you can. And if you don't need rabies immune globulin, it's even better because it can be hard to find in some countries. And so having a pre-exposure immunization to rabies offers significant advantages. And so we do offer it in our travel clinic to travelers, in addition to the people who we give it to for occupational health reasons, veterinarians and animal workers. This study, published in Canadian Medical Association Journal in 2018 by our colleagues, travel health and tropical medicine colleagues in Montreal, did a systematic review of sorts, or a bit of a review, showing that although intradermal dosing is not licensed in Canada, over the years, over the last couple of decades at least, because it's recommended by the Public Health Agency of Canada, more and more travel clinics have been administering, in this case, the red portion of the bars, intradermal rabies vaccine as opposed to intramuscular. What this does, both intradermal and intramuscular pre-exposure prophylaxis require 3 doses of the vaccine. And with the doses of 1 mil being over $200 and 0.1 mil obviously much less than that, you reduce the cost, the full pre-exposure immunization costs, from almost $700 to roughly just over $100. So a big cost difference in intradermal administration. The journal Vaccine looked at a systematic review and showed that there appears to be a marginal superiority of the intramuscular use over the intradermal, in that you seem to get a stronger immune response, that top line here on this graph, versus the intradermal dose. And the antibodies wane in both instances, but by 1 year, the intradermal dose immune response seems to have gone below that cutoff of 0.5 international units per milliliter, which is considered, again, below adequate amount of antibodies to have an ongoing good enough immunity against rabies. What happens when your antibodies go below that mark? We recommend a booster dose, which you would need here at the 1 year point for intradermal, but for intramuscular, you can wait out to 2 years before that immune response is below 0.5. And so there's always been a sense that intramuscular immunization is superior to intradermal, but really is it? Is a question that's been asked in more recent years. this publication from JID in 2020 looked at comparing, so you don't have to squint too much to look at all the details here, but I'll let you know groups 1 and 3 were intramuscular administration of rabies vaccine, and groups 2 and 4 were intradermal administration of the vaccine. But you don't have to figure out or try and look at which is 1, 2, 3, 4 here by the gray bars. Essentially, within 14 days of a 3-dose immunization series of rabies vaccine, pre-exposure prophylaxis, you had equal amount, the same antibody titer, whether you received intradermal or intramuscular dosing, and the waning immunity over the following year was the same for both intradermal and intramuscular. And then up to 2 years, up to 1 year, sorry, what we don't have is, what about the response out to 2 years? Is it still over 0.5? Is it still robust for intramuscular as well as intradermal? We don't know, or we didn't know. And the booster dose that was given that you see created a very robust immune response. All cases, whether you received intradermal or intramuscular initially, that booster response was again secondary to an intramuscular dose at 1 year. So they did not boost with intradermal, they boosted with intramuscular. So that left open the question that our colleagues in Montreal seem to have started to answer in 2015, published in CCDR here in Canada. And they showed that the immunity, this is intradermal dosing, of 3 initial intradermal doses of pre-exposure prophylaxis, showing 100% immune response protective antibody titer after the first series of 3 vaccine doses. And out to 2 years, they followed these people out to 2 years, only 35% after 2 years still had titers above 0.5. And so most people titers were down below that magical 0.5 cutoff. But with a single intradermal, they were the first to publish data with an intradermal booster dose, 100% response with the booster dose with an intradermal vaccine, suggesting that even those people whose immune response had waned below 0.5, they were still very immune because they had a very robust response to a booster dose, an intradermal booster dose. So we were able to try and replicate this data from Montreal, from our own clinic, because we had about a decade of data at the WRHA Travel Health and Tropical Medicine Clinic of rabies intradermal immunization with 1/10 the IM dose, giving our pre-exposure series on days 0, 7, and then 21 or 28 days. We followed people for 2 years and out for serologic response. So we were able to look back at the seroresponse data, and we boosted everybody who was below 0.5 with 1 single intradermal dose at 2 years, those who were below 0.5, and we were able to retrieve that data as well. So cutting to the chase, and John, I'm trying to make my presentation as short as I can to give you lots of time for questions here, is within 2 weeks, 1 to 2 weeks, or sorry, 2 to 3 weeks. So within a very short period of time of initial rabies pre-exposure immunization with the 3 doses, almost 100%, 98% of people had seroconverted to greater than 0.5 international units per milliliter. Overall, of all 324 people in whom we had data, 96% seroconverted. And when we followed these people out, or those we could follow to 2 years, because of the original 324, only 68 showed up 2 years later to have repeat serology, we found that the mean geometric titer was just above 0.5, but only 44% of people had maintained their immunity above 0.5, and over 50% had gone below 0.5. But as in Montreal, when we boosted these people out at 2 years with a single intradermal dose of vaccine, we got a huge immune response in 100% of people. That's only 20 out of 20. It's only 20 people, but at least everybody we boosted had a very strong anamnestic response, again suggesting that this is a very immunogenic vaccine, and it should not come as a surprise because the intradermal space, and we're learning this more and more, there are studies now trying to look at COVID intradermal vaccine with a fraction of the dose, and influenza intradermal vaccines, and the preliminary data on those studies show that the intradermal space happens to be a very immunogenic space, and we shouldn't be surprised because the intradermal space is packed with dendritic cells, macrophages, T cells, all the parts of the immune system that get very strongly stimulated, at least for cell-mediated and antibody-mediated immune response, that is actually not present in the intramuscular space, or to a much lesser degree. And so it's not surprising that a fraction of the dose, a tenth of the dose of an antigen in the intradermal space would be as immunogenic potentially as 10 times the dose in the intramuscular space. So in conclusion, intradermal vaccines are highly immunogenic. We're able to show relatively protective serologic response for 2 years following an intradermal rabies pre-exposure prophylaxis in at least almost 50% of individuals, but probably higher percentage because we know that it was highly and rapidly boostable, even with titers less than 0.5, and that we saw immediate, rapid, and long-term immunogenicity of intradermal rabies vaccine, as well as a strong and rapid response to a single intradermal booster dose, really showing the potential utility for intradermal dosing, not only for pre-exposure prophylaxis, but probably for post-exposure prophylaxis, which is why the WHO recommends the vaccine now for both pre and post-exposure. So it's likely that rabies vaccine in the long term, using less may actually turn out to be way more, at least if not administering 10 times less antigen in the intradermal space, turning out to be, if not more, at least equally effective than intramuscular administration of 10 times the dose. It's at least the intradermal route way less costly and much more cost-effective approach than the intramuscular route. So I'll leave it at that and hand it back to you, John.
Well, thank you very much, Pierre. Thank you, Pierre, Paul, and Philippe. Let's see what questions came through. So the audience seemed to be quite fascinated by Strongyloides stercularis. Paul, would praziquantel be effective against strongyloidiasis?
Short answer is no.
Would strongyloidiasis be able to cause endoscopically visualized erosions in the small bowel?
I'm not clear what we would expect with uncomplicated strongyloides, but it sounds like it might be possible with the necrotizing enteritis that is seen with disseminated or hyperinfection, that might be the case. But I haven't seen specific descriptions saying erosions.
Okay.
Phil or Pierre might have read something as well on this. They're well read on this stuff as well.
Can't add much.
So Pierre, one thing that we didn't talk about, and this is very simple-minded, what would the indication be for rabies vaccination, and who should receive rabies vaccination?
In the occupational health side, it's pretty easy. So anybody who's a veterinarian or works in a veterinary setting or works with animals, especially wild animals at the zoo or wildlife, or even in a pet store where you can potentially be exposed to a fatal infection that requires sometimes trivial exposure. You may have heard of the recent case in the media with a bat exposure and a child that died as a result without a visible bite wound. It's a vaccine that is very safe and virtually 100% effective. Certainly in those settings you would want to immunize, but we are finding more and more travelers when we explain to them and when we offer them intradermal dosing at a much more affordable cost, that they could have literally lifelong immunity to rabies, and with pre-exposure prophylaxis, get rapid boosting if they get exposed and no need for rabies immune globulin, more and more travelers now choosing to get immunized in advance, including myself, so that I no longer have to worry as much now about rabies exposure on my exotic travels. And, you know, many lose dogs in many countries. And so if you're a jogger, or if you're exploring caves, or if you're a cyclist, you're at pretty high risk of exposure to rabies because the chances of a rabid animal coming after you are much higher in other countries. And again, having that pre-exposure prophylaxis gives you a significant head start in post-exposure immunity.
Wow. So, Philippe, I found some of the data you presented fascinating in that it appeared that the vaccines were most effective in those persons who'd already had disease. But does the disease not confer immunity?
Well, so in the case of the dengue vaccine, that is correct, and the reason that this is the case is that dengue does, we have those 4 serotypes, and a single serotype will provide likely lifelong immunity, but only to that serotype. And at the same time sets you up for more severe infection with your secondary dengue infection, which would have to be from a different serotype. So we see these wild outbreaks of dengue, and it's often severe dengue when a new serotype is introduced into an area. So the vaccine for dengue, at least the currently available dengue 2 backbone vaccine, does seem to boost all 4 dengue serotype antibodies, but only individuals who've at least had 1 previous dengue infection. And it's a little bit more dubious with dengue 3 and 4 if you've never been exposed before. With the chikungunya vaccine, it's not the case at all. So your vaccine does seem to provide immunity and probably good immunity to naive individuals. So it's a little bit of a different story between the 2 vaccines.
Thank you. And then for Dr. Van Kessel, what do you consider appropriate therapeutic decline in strongyloides titers?
So there's limited guidance on this, but it suggests, and this should probably be done in concert with an infectious disease or tropical medicine doc, that following treatment, one should be monitoring the serology at 6 and 12 months and be looking for roughly a decline in about half the strength of the optical density within that time frame to show that there indeed is a significant decline.
Okay, and the final question about strongyloides stercularis. Can you comment about strongyloides stercularis developing ivermectin resistance, if any? Well, given the pandemic, I suspect that there's going to be lots of ivermectin-resistant strongyloides.
Interestingly, there's case reports of the steroid administration for severe COVID actually precipitating hyperinfection syndromes due to strongyloides. But I don't believe I've seen any description of ivermectin resistance in strongyloides itself. We are seeing ivermectin resistance in some other roundworms, and it is quite widespread for veterinary roundworms. So it's really only a matter of time before we start to really appreciate ivermectin resistance, which would be a shame. It's such a massively important medication.
Okay, well, I think that brings this session to an end. So, gentlemen, thank you very much, and that rounds out Bug Day at 2024. So. Please, for the audience, please submit your evaluations and your comments about future topics for Bug Day. Thank you very much.